Good morning, ladies and gentlemen. The people in the room here in Lagos, Nigeria, I say good morning again to Carol, and to the persons online. Thank you for being present. Right, it's really a lot for you getting up while you should be sleeping or doing other stuff to be online, and so we're not going to waste your time. We'll get started. If you're seeing the space for the first time, my name is Cynthia Oye-Isan, and I am the native doctor that always constantly on his mission. Today is the 16th of October, and it is the Lagos edition of the Practical Endovascular Conference for Africa. We had the first edition in Bielsa on Monday the 13th, and it was greatly impactful, insightful, like I like to say, insight fun. We had fun learning, but we gained a lot of insight. And we are enthusiastic about today, believing it's going to be way better than Bielsa, right? So, without wasting time, I would like to introduce the man of the moment, who is going to give us a welcome remarks. For 8 years, well, this is the 8th year he's done this, ensure that we have an endovascular conference held annually. Started in Bielsa in person, then we've had hybrid sessions like we're having today. So please join me to welcome Dr. Herbert Oye, the consultant of the Raleigh General Hospital, the West Virginia Vascular Institute, and the president of ISNBS, the International Society of Endovascular Specialists, the United States of America, the CMD of the Bielsa Specialist Hospital, and the Endovascular Clinic, Lagos. Need I go on? I mean, the guy has this very intimidating profile, but please put your hands together for Dr. Herbert.
Thanks. Good morning, everybody, and thank you for coming. This 8th annual Endovascular Conference for Africa, that's a practical idea that we came up with 8 years ago. We've been consistent in trying to improve endovascular care in Africa to bridge the divided gap between developed countries and the USA and Europe and Asia. I think the process is ongoing, and we hope that we'll continue to improve as time goes on. As Cynthia mentioned, on Monday, the 13th of October, we had very interesting case presentations and talks from international renowned speakers around the world, and it was very informative for the audience at that time too. So we hope today will be another step forward in that. The aim of this exercise, number one, is to ensure that, as the caption of this year's theme says, peripheral arterial disease and management, and the idea to prevent minimal amputations. In Nigeria specifically, 65 to 85% of persons lose their leg as the first line of treatment when they encounter problems with circulation. Our goal is to help train healthcare professionals, number one, to recognize problems with peripheral arterial disease and thus improve or refer the patients to an appropriate professional so we can minimize the risk of limb loss. The goal again is to ensure that we make our healthcare professionals aware that peripheral arterial disease is a major healthcare hazard, not only in Nigeria, but also abroad. We know that 20 million Americans, 12 million Americans affected by peripheral arterial disease, and globally around the world, 232 billion persons affected. So it's indeed a big. So we'll take this opportunity to get started with the program shortly, and I hope you relax and get your hands and pencils later on with the call. And some important data that we present to you. And additionally, the program will also be the YouTube channel. If for any reason you can go back and review the information. It's our pleasure to welcome you to Lagos, and we look forward to getting this program started. Thank you.
Hey, let me connect them now. I've connected to mine now.
Right, so all of our talks on Monday and most of it today will be centered around that. So our first speaker for today is the amazing man again, Dr. Oye, and he's going to be talking to us about making endovascular surgery visible in Nigeria, in Africa, and rural America. So please grab your pens, your notepads, and make notes as we learn about this. Thank you. Welcome.
Okay, we'll get started. As stated on the caption, endovascular intervention made it feasible in Africa and rural America, the blueprint of success. I'm an endovascular surgeon. I'm trained in endovascular surgery and vascular surgery. Endovascular surgery, for persons who are not familiar, it's a minimally invasive form of vascular surgery. While open vascular surgery offers you open surgical technique, have cut, and cut, and the tube in between cut sometimes it's wrong. And the vascular surgery does the reverse. It actually doesn't make any cuts. It requires really the use of the needle, wire, catheters, different forms of catheters to affect treatment. So that makes the treatment a lot more invasive. Crossing the issue. For many years, that's standard gold standard, it's not gold standard. But several years ago, we got past to go. The technology has improved to the point where we can now also offer states with flow reversal, that's what we call TCR. Where you put two in the two in the vein, and between the two, that's filter. So at a critical time when we need to inflate the balloon of the center right on the neck, the blood flow goes to the brain and that's first. So the patient can have blood loss. So that is visually was say pushing it in. Do this in your issues. Prior to that, yes, and most of the when compared to stenting that is the right area, these two options have better stroke risk issues associated with. The other area is which I my second topic would be called C-route, so in the vascular investigation. The second way of doing surgery in that area where you have blockage in the buffs of the outside is the major life from the bypass. Again, like surgery, you have to make an incision in the belly area, connect the area that's soft above the plaque. So too, pass it to the right or left way, and to make the arteries and then it's also open. That's a plus. This is the person that we'll hear more about that. And femoral arterial bypass is where the patient has a blockage between the hip and the knee, and we may continue to go around that area of blockage, and that's the surgery. So all these are open surgery, but they don't have endovascular applications where we make the endovascular surgery, which is much more debilitating. Make a lot of people case, often see the case with I think with tension and now getting on the sense that they have the getting on the blood pressure. And also something that intestinal pain from the blood that intestinal arteries, the superior vesical artery, SMA, also the extensive arteries also getting big surgeries and death which they do that. Shot was also sometimes good, effectively emergency with the vascular techniques. Sometimes you have the aorta made by so far. It can be very almost trying to say aorta. Situation like that, then the vascular technique is required to the area of the stairs, and you start with it in the middle of time, and see that lines. Yes, that's like. So this will give you a quick idea of some of the things we do in endovascular technology. This is a patient, the dialysis patient who has what we call AV interstitial, a connection between the artery and the vein that we typically use to treat them in kidney condition. Normally, when they show up with kidney failure, the first step is acute kidney failure will be some catheter or temporary catheter in the vein for dialysis. They recover fully, they don't need to come this. If that does not work, then the next step will be to put a permanent catheter and then they can solve with that. Which they can problems to mature, and before they can start handling or sticking pieces in that tissue. So now you see a patient on dialysis, and you see if you look at the screen, the larger portion on the left side is vein, and the smaller portion is artery, and you can see a tiny area of blockage. So in the vascular technology point to treat this patient, ordinarily the vascular options are available. The surgeon will have to make a cut in the larger area between the space and put a tube in those areas, or vein to small flow. And the last technology put a wire through that one. You put a stand, you can see it, most of the stand in that area. Next week. When the balloon opens the stand, it's getting wide. Next week. And that's not a example of the vascular technology for patient on dialysis who does have significant part of the vein, the little color of some vein in the vein. Now on the left, the wires through stand. You see the stand structure. You can see something on the lines. So again, if you don't do this, the AV especially if you grasp it, it will eventually fail. And that fails. You will observe it to stay fine. Next thing. So again, we talk about TV. So this is an example of the case that you can see on the left, blocking this. On the right. So we'll see that stands on the right side, no more flow limiting at this time. So that looks very, very decent. Next please. That's the T-car example. Next slide, please. This is a case of right superior vena cava aneurysm. So it's a patient who has a blockage in the superior vena cava. You can see a catheter was placed through from the right neck, and you can see the blockage of the narrowing in the aneurysm. So that's the narrowed area here, also the aneurysm there. The aneurysm is the rotation of enlarged area.
So we're able to treat that with a balloon. You can see the balloon here. And we put a stent and we're able to treat that and restore flow to the patient. And again, if that were completely clogged up, the patient's entire right upper extremity, in this case, may get swollen because there's no more venous drainage to that area. But successfully, we're able to make this work for the patient, and the patient did quite well. Next. These are examples of endovascular cases again. Again, this is another patient who is in sequence. You can see the areal blockage on the left-hand side. Yeah, you could on the far left, then the balloon on the middle and the balloon on the far right showing improved flow. Next, please. This is a patient who had massive swelling of the left upper extremity. Again, you see another patient with narrowed area on the left and improved on the right. Next, please. All right, we talked about PAD, which is essence why we're here today. And PAD has been the beneficiary of endovascular interventions. Most patients that have PAD just don't show up with PAD. It's a gradual process in most people. They would probably have pain initially when they walk. That's called claudication. Then step 2 is when you have pain at rest. You're not walking, you're having pain. Step 3, you have tissue loss, something like that. And step 4, you have overt gangrene. So in this spectrum or continuum, patients present at different times with different problems. The irony of it is, even in developed countries where we practice, and Africa, the patients sometimes present with identical issues. You think some of the patients I see in Lagos or Port Harcourt or Bayelsa are patients we see in America just as bad. The difference also is patients we see in America typically smoke a whole lot more. They are heavy smokers, but we don't smoke as much here. But diabetes is an inciting factor, and you hear that during the course of the lecture. Next, please. So you see, go back one. On the previous slide, on the right-hand side, so see the patient on the left with a toe problem. Once we did an examination extremity, we found that the patient had some blocked arteries between the femoral artery, the hip area, and the knee. And you could see we're able to make a wire go on the screen to the right, and while it's going through that, we're able to balloon that area. Next, please. We did balloon angioplasty. You can see the balloon on the left and see the final picture on the right. That looks a whole lot better. So more flow gets in, and that patient with a bad toe in about a month or so will get resolved. If the society the patient lives in cannot offer endovascular technology or open vascular intervention, that patient may be destined to losing their limb, which is a big problem. In Nigeria, 65 to 80% of persons will lose their limb with a presentation like that. Next, please. Okay, so this is a patient with an aneurysm. We talked about aneurysm before. So a patient had an aneurysm, which is bulging of the aorta. This is the kidney arteries right and left. You can see the aneurysm bulging there. So this patient we can treat with an endovascular technology by putting a stent that starts here and goes all the way down and will cure this problem. Many years ago, when we started, aneurysm surgery was started in the 50s, the 1950s, as open surgery in those days. But nowadays, the technology has shifted. When I trained in the 90s, we did open surgery. Then when I did endovascular fellowship, we did endovascular more. When I started my clinical practice in 97, I was more like 60-40. But now we're like 90-95 endovascular to open 5 to 10%. So again, the technology has taken wave. It's expanding rapidly, and the technology is just amazing. Next, please. So it's the same patient. You can see the final picture. So that aneurysm we've seen before is gone. And this patient was a 90-plus-year-old gentleman that we treated. He did have an area of his IMA with his artery that serves the lower portion of the large colon. We had to put a little coil to make sure that does not continue to flow into the sac of the aneurysm. So this procedure on a 90-year-old worked. If you do open surgery on a 90-year-old person, they will die. because they may not have the cardiac reserve to survive such surgery. So that's the benefit of endovascular surgery. We do have a lot of aneurysms in Nigeria, believe me, it's more than we think. Many years ago, we thought aneurysm was not a major problem in Africa. It is. A lot of people, young people, particularly in Nigeria, are having a lot of aneurysm issues. I'm talking the age of 39 and above. So that's a problem. So that's a classic example before and after imagery of an endovascular intervention. And that's what we're trying to do to ensure that we train physicians here in Nigeria to do this type of surgery. We did an endovascular intervention in 2017 involving the thoracic aneurysm starting from area of the chest, subclavian artery, to right about the bifurcation of the aorta in the patient in 2017 at National Hospital Abuja. And it was an interesting case at that time. It was endovascularly done. It was a hybrid procedure. At that time, it was a patient who was about 50 years old, had a dissecting aortic aneurysm. We're able to treat him, and he did well. Next, please. Again, the key areas of interest are aneurysm care, stroke management, controlled blood pressure, amputation prevention, respiratory ischemia, hemodialysis care, cancer access care. Those are the key areas in the vascular surgery can provide solutions. Next, please. This companies that are found that do business in the U.S. The ones that are common in Nigeria are Medtronic. Medtronic Strong is the main company that provides aneurysm care for Nigerians. All the others keep saying they don't have say in Africa yet. It's not part of the radar. Again, it's a problem. Next, please. GE is also common in Nigeria. Next. So why is there successful endovascular programs in the Western world, like Europe and the US, unlike Africa? That's a basic fundamental question we must answer. Hospitals are more supportive of technologies due to financial profitability in the US. Access to resources readily available, such as cath labs and hybrid operating rooms where these surgeries can be performed. Industries, like I mentioned, the other companies I mentioned before, have mutually beneficial financial interests. Therefore, they're able to provide the care. The irony is some of these raw materials that these people use to provide this instrument equipment are gotten in Africa. They transport the raw material to Europe and America, make these products there, and have a difficult time getting these products back to Africa because of governmental regulations and matters that make things difficult. It's a problem. So that tells us that we need to start thinking about having our schools of technology be interested in thinking about doing research to improve our ability to make some of these materials ourselves. No concerns about power in those countries that have power structure in the US and Europe, but it's a problem in Africa, of course. Trained staff availability or local staff provided in the US. We have to work hard to get the trained staff here. And that's one of the goals of our mission here, is to ensure that we train our local healthcare providers, that they become competent enough to be able to provide care and prevent patients from losing their legs. Healthcare costs are subsidized by Medicare, Medicaid, other private insurances in the US. To a lesser extent here, patients have to pay out of the pocket, and most people cannot afford it because per capita income for many persons is only $360 US a year. How can you afford a cost of maybe $3,000 US in the or $60,000 as it may be to treat one endovascularly? So our goal is to make endovascular surgery cost effective and cost affordable by making sure we have a lot of tools in our toolbox, but we have to train our persons here to be cost-minded and cost-efficient in using the right item for the right procedure. So just because you have a lot of tools in your toolbox doesn't mean you have to use all of them at the same time. In the US, we can get away with that, but you can't get away with that in Nigeria, for example, because the patients just cannot afford to pay. Next thing. Fundamentals of endovascular surgery, the ABCs, that's what I do for a living. It's easy for me to see it again, but I train a lot of medical students and residents, and we go through this all the time. For you, it's important. I tell my students, you have to do a history and physical. The first encounter with your patient typically means you have to talk to them. You have to ask them what the problem is, what brings them to you, a chief complaint. You have to understand them fully. You have to now examine them. You can't just depend on doing a CAT scan or MRIs without touching your patients. That's a no-no. You have to examine the patients before you make a diagnosis. So the fundamentals, again, you have to have the basic test, which we'll talk about, the other speakers talk about it again, ultrasound, CAT scan, CT angiogram, catheter, arteriogram, venogram, all those things that we do to confirm our diagnosis as to what we're going to treat the patient with. And these are some supplies we definitely need to engage with endovascular intervention. We need wires. They come in different sizes, 0.035 inch, 0.018, 0.014. These are wires, catheters, because we travel from one point of entry and will be treated at distant location further away. So we need long wires to do that. Next, please. Treatment can be performed in many ways. So you can go from one point to the other, either from above or from below. That's when we talk about retrograde. You go, say, from the knee up, it's retrograde. We talk about antegrade, you come and say from the groin down. So those are the concepts you have to remember. As most speakers will talk today, you'll hear those words, retrograde, antegrade. So retrograde simply means you're going towards the heart. Antegrade means you're going away from the heart. Treatment options, again, biggest fundamental of endovascular surgery is if you have a blockage, a wire must go through that blockage for you to affect treatment. If a wire does not go through that blockage, then you cannot offer endovascular treatment. And the treatments are angioplasty, balloon to inflate the area, putting a stent, atherectomy, which is a way to shape the plaque, which you can see on the screen below, embolectomy, which is a way to remove blood clots in the arteries. All these are options for endovascular therapy. Next, please. Okay, we talked about the options again, balloon angioplasty and all that. Again, we need special drugs that we give patients. If you intervene in patients who are doing endovascular surgery, we might need special drugs so they don't form blood clots later. And that includes giving them heparin during the time of surgery if they're not allergic to it. If they're allergic to heparin, they can give them 2B3 agents, such as Angiomax or Agathroban to help them out. Next, please. Okay, these are some other blood thinners that we give patients: aspirin, clopidogrel, Prerena, Eliquis, Coumadin, Xarelto, and all that. After the procedure, when we're doing the endovascular surgery, our patients are able to have the sheets that we use in the procedure be removed, and they're observed for 20 to 30 minutes. And if they're doing well, they're able to go home the same day within 2 hours to 4 hours, depending on the complexity of the surgery. Next, please. So what the challenges we face in Africa, what are they? We have fewer international endovascular companies that show an interest in helping us out. Again, we have to help us out. We cannot depend on the companies outside Europe, outside Nigeria, Africa to do our bidding for us. We have to have universities, biochemistry, biochemical persons, take up the challenge to do better. We'll have to decrease the cost, the high cost of endovascular surgery, by making sure we're providing or producing those equipment and wires here in Africa so we can drive the cost down. Again, we also have to do research and development to improve our care. Improve our power supply across the country is the major problem because this procedure requires very complex, heavy-duty machinery that use a lot of power. So we have to make sure we have stable power sources for care. Absence of governmental regulation or decrease government regulations to improve care is also important. Above all, we need security. You can't invite folks to come to Nigeria or other parts of Africa to help educate our persons and have an insecure environment. So again, the security of our country should be the top priority of this government. So that is something that's important for investors to seek attention. We need to improve our security situation. Next, please. So in summary, I would say starting solutions to improve endovascular will require starting a pilot program, which we're looking on in Lagos. Successful similar programs can be performed in other parts of West Africa and major cities. Fast track endovascular training. It's important that general practitioners here in Nigeria or other parts of West Africa who show interest in surgical technology can seek endovascular training to improve their understanding, and that will help us bring to bear more endovascular trained persons. As an endovascular trained surgeon now, even in the US, there's very few of us. So if we're very few in the US, you can pretty much imagine a population of 232 million people in Nigeria, that's going to be a problem. Improving security, as mentioned, is important. Consumer medical education, that's important. Educator conferences such as this is an avenue to engage interest and for the persons to learn about the program. And development of a viable virtual endovascular platform as a bridge to this technology to decrease the gap between Africa and USA. This is what we're passionate about. We do have an endovascular platform. So when we train doctors in Nigeria, for example, they can communicate with us virtually as once they need help to help see those patients and make sure the patients are seen on hand to get the best treatment possible. Next, please. Again, there are very few specialists in Africa. So solutions to engage in practical internships and mini fellowships for experienced surgeons interested in endovascular techniques who can range from 1 year to 4 years, and full fellowship for younger general residents and consultants interested in endovascular surgeries. Endovascular skills and judgment require dedication and commitment to learn these fundamental principles. It's not learned overnight, so it takes time to gain the critical knowledge, skill set necessary to perform these procedures. We want trainees to be excellent. We want them to be very good at what they do, but that requires persistent training, and it's an ongoing measure. Even as an endovascular trained surgeon, I still have to go to seminars and trainings and keep the skill set up. Next, please. There's an acquired skill set that requires patience and time to develop. Participate in national and international endovascular seminars like you're doing today. It's one way to do that. Development of actual endovascular practice, screening program through virtual and in-person platform like we're doing today can be helpful. Utilization of a virtual platform for direct patient care is what we're passionate about, and we have done successes in cases like that already. We have to utilize international organizations such as ISEBS, the International Society of Endovascular Specialists, of which I'm the president of the Africa chapter, to improve endovascular technology in Africa. Over the past 6 years, we've had the West Endovascular Institute, actually 8 years, the Global Vascular Wound Care Center, and other collaborating institutions in Nigeria, the Silver Cross Diagnostic Healthcare System in Abuja, the Bio Special Hospital, and collaborating physicians here in Nigeria, microsurgeon Dr. Ajani, who works in many institutes here in Lagos. We've been working collaboratively to improve care. Dr. Ray Bayo also works in Nigeria as a collaborating physician, and Dr. Ugoji also in Lagos. So we've had the opportunity to improve endovascular care in Nigeria to some extent. We can do more. Our goal is to make sure people don't lose their legs. Our goal is to ensure that endovascular technology and the awareness is not only with the providers, but also with our patients. So once they have a problem, they know where to go, who to call to direct them to where they can have their problem solutions achieved. Next, please. We have perfected endovascular care in the operating theater and transformed complicated procedures from a cath lab to office-based lab or office intervention suite. We do that, and we can simply do that more. And that's one way we can drive the cost of endovascular care down. Because when patients go to big centers, they are mandated to pay a huge amount of money to help to seek help. But in the office-based lab setting, we can decrease some of that cost. The benefits of transition, you can decrease healthcare costs to patients, decrease healthcare paid from insurance companies to hospitals. This is in the US too. Minimize prolonged inpatient hospital stay to shorter outpatient same-day surgery, faster discharge from time of intervention, and improve quality of patients' health and decrease mortality or death. Next, please. Again, these are examples of cases you can do in the office-based lab, including wound care. We can do dialysis catheter placement in these places. We can do interventions. We can do really complex surgeries in these settings. Next, please. Again, examples of procedures we can do: balloon angioplasty, angiograms can be done, atherectomies and stuff. So we can do a lot of procedures that way. Next, please. In conclusion, I'd say endovascular interventions can be performed in Africa with appropriate collaboration amongst international partners and African counterparts. Proper training is a prerequisite for success. Don't want people jumping and say that they can do endovascular surgery without being fully trained or adequately trained. They can cause more harm than good. Recruiting driven clinicians interested in learning endovascular knowledge is what we're saying, and that's why we're doing this seminar. Understanding the fundamentals of endovascular surgery is something you can learn. We can train you to have a successful program development and engagement of international endovascular industry and development of our endovascular program becomes safe and dependable. So thank you outside of this stage. Thank you so much. Any questions, I'll answer them for you. Any questions, sir? We may wait with some questions on the platform. Yes, yeah, yes. Yeah, that's an excellent question. That's where the world is going. And surgery has not been left out. And physicians in vascular surgery and non-physicians in vascular surgery are trending towards that end. Again, AI is key to patient improvement, and we have adopted that already in our clinical practice in the US. And it's a big deal. One of the speakers on Monday, the 13th of October, was a cardiac surgeon from Iowa, spoke to that land, AI, incorporate AI into our clinical practice. A physician who does not incorporate AI into their clinical practice right now would have some major issues down the road, because AI is the way to go. It will lead you, when you deal AI, you don't tell AI what you want to hear. You ask AI what you don't know, and it will then complement what you know. So that's the way we're adopting it strongly now in the US, and I hope our mentoring counterparts will do so. Yeah, great question. Yeah. All right, any more questions? Dr. Ibrahim, you have any more questions on your platform before I step down?
No, the question, the chat box is clear.
Okay, all right, yeah.
So what is the age, like enough to help, what's the age range that doctors have to do? That the age marker and like the diet also really big, why in Africa or Nigeria, like the diabetes and stuff.
For the PAD related issues? Yeah, the risk factors for PADs, you'll see later in the conference, are hypertension uncontrolled, diabetes, smoking, which is common in the US and European countries more than us, then you have sedentary lifestyle, and you have genetics. 30 to 35% of persons who have PAD issues have a genetic factor. Either mom or dad has the problem, and when we automatically get 30 to 35% of chip all the time. But age over 50 is what the textbook says. So yes, it can be. But again, the reason why we're seeing a whole lot here is uncontrolled hypertension and diabetes, more than anything else. The reason why we see it more in West Virginia is smoking. But the disease profile, it doesn't matter if it's West Virginia or Nigeria, it's identical in terms of actual seeing the extent of end-stage disease and the ramifications of it. Identical. Yeah. Very good. So again, we'll talk some more about this and we'll go from there. All right. Thank you so much.
Please put your hands together. But that's for that insightful and encouraging talk, because there's hope for us that we can access endovascular treatment and care in Africa, Nigeria specifically for me, and of course rural America. So thank you. The guys that sitting in here virtually, I hope you're having a great time. Here we're having our candies and drinking water. So I hope you're hydrating yourselves, if nothing else. We're gonna keep things moving on. And to make you guys sitting online, enjoy and actively participate, I'm gonna have one of you run through the next couple of sessions that we have. So I'm gonna introduce to you Ibrahim at Ibikunle, a medical student with, hold on a second, so I don't say Lagos State University, just hold on, with Avalon University School of Medicine. He's working closely with Dr. Oye, and he's going to be taking over at this point to introduce or preside over the virtual session going forward, because our next couple of speakers are all online. So in person and online, please put your hands together for Ibrahim Ibikunle. Ibrahim, the floor is yours. You're most welcome.
Thank you, Cynthia, for the wonderful introduction. So our next speaker is a third-year medical student, a fellow third-year medical student, Nadeen and Aladham, who is with Ross University School of Medicine, and she will be presenting a case on flush occlusion of the SFA managed with retrograde popliteal approach, the CRACE report. So I'm going to share your slides, Nadeen, and the floor is yours.
Hello, everyone. My name is Nadeen. I am a third-year medical student with Ross. Thank you so much, Ibrahim, for introducing me. And thank you guys for having me here. I'll share my slides and we can get started. Okay. So today, I'll be presenting a case report that I worked on with Dr. Oye for the flush occlusion of the superficial femoral artery managed with retrograde popliteal approach. So to introduce the topic, the superficial femoral artery occlusions are a leading cause of peripheral artery disease, and it's contributing to the claudication and limb ischemia worldwide. The occlusion occurs due to chronic atherosclerosis, plaque rupture, and superimposed thrombosis, resulting in impaired distal perfusion. Flush occlusions present in a unique technical challenge because of the lesion that originates at the femoral bifurcation, and there's no distal re-entry to engage with the guide wire. Imaging modalities like CTA and fluoroscopic angiography are critical for visualizing the occlusion length, the distal reconstitution, and runoff vessels. Traditional approaches like Fogarty thrombectomy, TPA thrombolysis, mechanical thrombectomy, they often fail in the flush or long segment. And flush or long segment due to limited access. The retrograde popliteal approach allows for distal to proximal revascularization, offering better visualization and improved guide wire control. And this minimally invasive technique reduces the postoperative risks like lymphatic injuries and wound repair as well. And it's an alternative to the femoral popliteal bypass in anatomically complex lesions. So for this case report, it was about a patient who came in with a past medical history of hypertension, hyperlipidemia, hypothyroidism, and peripheral vascular disease. And she had no known surgical history, and she takes antihypertensives, lipid-lowering agents, and thyroid hormone replacement for medications. It is a 56-year-old female that presented with an acute left leg pain and diminished distal pulses. The CTA demonstrated a complete occlusion of the left SFA, and you can see that on the right side. And an anterograde right femoral approach failed, and it prompted the decision to expose the left popliteal artery for a retrograde access. You could also see the fluoroscopic angiogram showing the complete occlusion of the SFA. For the methodology of this surgery, the popliteal artery was exposed through the popliteal approach, posterior approach, sorry, and a retrograde arteriotomy was performed. Under fluoroscopic guidance, the guide wire was advanced through the occluded segment of the SFA until it re-entered the full lumen at the iliac level. So a sequential balloon angioplasty was carried out, and it was using a 6 millimeter by a 200 millimeter plain balloon, followed by a 6 millimeter by 300 millimeter drug-coated balloon. And the plain balloon allowed for initial mechanical plaque disruption, while the drug-coated balloon provided a luminal expansion and antiproliferative drug delivery to reduce the restenosis risk. And the thrombus and atherosclerotic debris were also extracted using the thrombectomy balloon catheter during this process. A completion angiography confirmed the restored flow through the left SFA and profunda femoris artery. So the arteriotomy was closed and the incision was repaired in layers, and postoperatively the patient was able to get a palpable distal pulses as well as a complete resolution of the plaque or of the occlusion. Here you can see the guide wire getting reintroduced retrogradely through the popliteal artery to cross the occlusion, and then it went successfully to the iliac artery, confirming the re-entry into the true lumen. Here you can see the angiogram showing the restored flow through the left SFA, and it was following the retrograde popliteal angioplasty. Another one here, you can see that there's patency of the flow and full restoration of the flow. So the retrograde popliteal approach was selected due to the failure of the anterior grade femoral access to cross the flush occlusion. So this approach allows for direct re-entry into the distal true lumen, enabling the wire transversal through the chronic total occlusions while minimizing the surgical trauma. It eliminates the need for groin incisions, and it reduces the risk, like I said, mentioned earlier, for infections, lymphatic complications, and wound breakdown. Modern endovascular tools and imaging techniques have advanced the safety and reducibility of this method, and recent literature demonstrates high technical success rates with durable outcomes comparable to the femoral popliteal bypass, but it has less morbidities. So in this case, the patient actually benefited from the complete revascularization as well as restoration of flow and a rapid postoperative recovery. The technical pearls would include careful ultrasound-guided puncture of the popliteal artery and the use of hydrophilic guide wires for controlled crossing of chronic total occlusions. So adjunctive devices such as aspiration catheters or penumbra systems can be used to manage thrombus burden and minimize the distal embolization. Reported complication rates are as low as less than 5%, with rare reoccurrence or occurrences of the flow vessel dissection, pseudoaneurysm, or hematoma at the access site. And comparative studies shows similar long-term patency of 80 to 90% a year between retrograde popliteal and femoral popliteal bypass, but with significantly reduced morbidity, like I mentioned, and recovery time. Hybrid techniques that combine the popliteal access with contralateral femoral intervention allow simultaneous profunda femoris revascularization and plaque extraction. So this approach exemplifies the modern endovascular philosophy, targeted intervention, minimal invasiveness, and preservation of the future surgical options. Emerging technologies, drug-coated balloons, IVUC, US, and robotic navigation continue to enhance the precision and durability of this approach. So the combination of the retrograde popliteal access and sequential balloon angioplasty allowed for a successful management of the complex flush superficial femoral artery occlusion without requiring an open bypass surgery. So this hybrid technique enabled the simultaneous thrombus extraction and the plaque removal as well, addressing both the mechanical obstruction and the embolic component. Overall, this case highlights the clinical value of the retrograde popliteal revascularization in scenarios where anterior grade access is not feasible. So it demonstrates that when performed carefully, it can achieve an excellent technical and clinical results while minimizing the operative morbidity and recovery time. So in conclusion, the retrograde popliteal revascularization presents an effective, minimally invasive, and technically reliable method for managing the flush occlusions of the superficial femoral artery. By providing a direct access to the distal true lumen, it overcame the limitations of failed anterior grade approaches and reduces the need for an open femoral popliteal bypass. So this approach significantly decreases the post-operative risks such as groin infection, lymphatic injury, while enabling the hybrid techniques like thrombus extraction, drug-coated balloon angioplasty. And in this case, the use of retrograde popliteal access resulted in durable vessel patency, restoration of perfusion, and full symptom resolution, underscoring its clinical value in complex peripheral arterial disease management. Thank you all so much. Any questions?
Thank you, Nadeen.
Of course.
Let's see. What? Can you come again, Dr. Ray? Sorry, there's some artifacts in the background. We can't hear you.
Yeah, essentially, that's a great presentation and use of retrograde technique to restore flow. It's important for the audience who may not be familiar with what the doctor just presented. Essentially, a patient presented with left lower extremity blockage from the groin to the knee, and it was not possible to go from the top portion to enter the blocked artery because it's 100% hard stone, area of plaque. So we had to go from the groin. We made a cut above the knee, and from that cut, we entered that artery, took some plaque out from that area because it was so hard. Then from that area, we're able to advance the wire, specific wire, carefully from the hip, from the knee area towards the hip. Then it entered the regular, unaffected portion of the artery above the hip. Like I said earlier on, endovascular surgery works if you're able to make a wire go through it. If that wire were not able to go through it, that person would need a much more extensive surgery, will be a bypass, meaning you have to cut in the groin. You already made a cut at the knee level. You have a tunnel of tubing between both cuts, and then sew the tubing above the blockage and below the blockage, and that will be the where you do a bypass, bypass or going to knee bypass. For this patient, the value of the Recurrent technique is it prevents from doing the bigger surgery. Yes, I can make one cut, and with that one cut, when the soft patient's wrong way to do up, also down to the flow, if need be, to ensure that it's good flow. The advantage of doing this, you prevent that you get bypass. Now, once you do a bypass is not foolproof. In America, most of our patients go in our community. So if you do a bypass, the bypass will work in a non-smoker from 5 to 7 years. And then a lot of the end, you have to figure out to make it work then. So because we have a lot of smokers, we tend not to do bypass first choice. We do a hybrid procedure, so it's rated by Nadeen, and we just go ahead and restore flow, and then get it out, and that will buy more time. We do not burn any bridges. We burn bridges later on if you do a bypass and fail to meet the patient get amputation. So again, that's good benefit of this Retrograde technique that we routinely do commonly. We do done in Nigeria, we do 7 times, we did 1-0. Also in my hands and so do it all the time. But it's a great presentation. Thank you so much. Any further questions? Okay, that's a big thanks for your presentation. Appreciate it.
Thank you all very much.
Hey guys, can you see my screen?
Yes.
Yes.
Great. So, hello everyone. My name is Ibrahim Ibikunle. I'll be presenting the next case, and my case is titled Utilizing the Pedal-Artery Loop Technique in Complex Infrapopliteal Interventions, an innovative case report. Before I begin, I would like to thank Dr. Oye for his guidance in the writing of this presentation, as well as his expertise in the performing this case. So I'll be discussing a bit about the definition of PAD. I'll talk about the vasculature of the lower extremities. Then I'll dive into the patient's presentation, what they came in with, the symptoms. I'll go into detail about the exposure, and then I'll talk about how the patient did postoperatively and discuss what this case and what this technique could benefit and could be used for in the future. So peripheral artery disease, I'll just gloss over this slide, is a circulatory condition in which we have narrowed arteries, especially in the lower extremities, and those narrowing of the arteries reduces blood flow to the limbs. It's primarily caused by atherosclerosis. However, it's accelerated by diabetes, uncontrolled hypertension, and smoking. The symptoms of peripheral artery disease are remembered by the mnemonic, the 6 Ps, and those stand for pain, which is often with activity, also termed claudication. However, this pain could occur at rest in more severe or advanced instances of the disease. You could also get pulselessness, in which you have lost or diminished distal pulses. You get abnormal sensation, which is termed paresthesia. You get paralysis. However, this is a late finding in which you would have muscle weakness or an inability to move the limb. You could get pallor due to the diminished blood supply to the region. And you could get a cold leg, and the fancy medical term for that is poikilothermia. Now, among the ways to treat peripheral artery disease, the 2 most common of them is balloon angioplasty and stenting. And as Dr. Oye mentioned, the basic tenet of endovascular surgery is you get the wire through and you're good. That's like half of the work. As long as you get the wire through the occluded lesion, then you're good. So in balloon angioplasty, all you have to do is get the wire through the areostenosis, put a balloon over that, inflate the balloon, and voila, you got the expanded artery. The same thing occurs with stent angioplasty. You put a wire in, you put a stent over that, expand the stent or inflate the stent, and you have a compressed plaque and restored blood flow. There are other ways to treat peripheral artery disease. These are just 2 of the most common. Dr. Oye mentioned in his PowerPoint slides that a way to treat peripheral artery disease is Other ways include atherectomy, which is when you scrape off the plaque, embolectomy, which you take out the blood clots, or thrombectomy. And you could also use lithotripsy devices, which we actually employed in this case, and I'll go into more detail. Is divided, or it's quite simple actually. After the superficial femoral artery, which becomes the popliteal artery, the popliteal artery then divides into 3 branches, which is termed the trifurcation. Those branches include the anterior tibial artery, the peroneal or the fibular artery, and the posterior tibial artery. These vessels, along with the SFA and the popliteal artery, are the most commonly affected vessels in peripheral artery disease. So they're most heavily burdened by plaque, and that's why most patients present with lower extremity symptoms. They present with claudication, pain with walking, and that's why it can often lead to amputations if not adequately treated. So I'd like to emphasize the anterior tibial and the posterior tibial arteries. I'd also lay an emphasis on the peroneal, the fibular artery as well, just because it too plays a role in the vascularization of the lower extremity. Now, the pedal arch, or the plantar loop or plantar arch, whatever you want to call it, is the basis of the technique that we use in this case. As you can see here, the anterior tibial artery runs down into the leg that'll be the lateral side of the leg. And then it loops around and it creates this kind of loop, which you can see in other parts of the body, like the hand. You've got a loop in the hand as well. And it's in direct connection with the posterior tibial artery. And I hope you can appreciate that there are branches coming off of this loop, and these branches serve to supply these structures in the feet. However, what's interesting is that the anterior tibial and the posterior tibial have this direct connection, which is this loop illustrated here. Now, there are variants to this anatomy. Sometimes the loop may not always be present. Sometimes the loop may not be continuous. Sometimes it may be tighter in some areas, and that will prevent you from using it to access other parts of the tibial artery system the way we did it in this case. However, I'll discuss more about the limitations of this technique. But to just kind of illustrate what we did, we went through the anterior tibial, put a wire in, and we were able to advance the wire across the plantar loop or the pedal arch, and then go retrograde into the posterior tibial and then treat the disease in the posterior tibial. So our patient was a 68-year-old female who presented to the outpatient clinic with complaints of left leg claudication. So she had pain with exertion. Now, this is particularly important because she had a history of peripheral artery disease and also had a history of left iliac angioplasty in the past. So her physical exam was we noted weak pulses in her dorsalis pedis and the posterior tibial artery. And so given that, as well as her history and her neo symptoms, we sent her to the hospital for a stat CTA. This image is her stat CTA. As you can see here, she has pain in iliacs, SFA, popliteal, and then over here, I hope you can appreciate the collaterals down here around where the popliteal artery is supposed to be. On the right side, everything's kind of continuous. On the left side, however, the collaterals are kind of the only thing that's keeping her leg alive. Slightly below over here, there's almost there's no contrast flowing down, demonstrates an occlusion right here. Now, I took a cross-section of the knee over here so you can kind of appreciate right above the red dot. This is the popliteal artery. Sorry, what was that?
Okay.
All right. So right above the red dot, this is the popliteal artery. And then on the left side, you can't really see the vessel as well as you can see it on the right side. You can see these collaterals, these tiny, more like white dots. These are the collaterals. They're helping give her what little blood she's getting to the legs. However, I hope you can appreciate that there's extensive disease in the left side of the leg. So we took it to the OR. We started by performing a popliteal arteriogram. As you can see here, there's extensive disease below the knee. Here's the distal SFA. The popliteal artery appears to be stenotic. These robust collaterals again. And because we're unable to pass a wire through here, we had to open her up and perform an endarterectomy, which is the scooping of the plaque through directly from the vessel. So we opened her. This is a tibial trunk. We opened up the tibial trunk, scooped out the plaque, and then we're able to cannulate the tibial trunk, as well as the anterior tibial artery. Now, this patient had disease in all three of her vessels of the trifurcation. She had disease in the anterior tibial and disease always in the tibial and with extension into the posterior tibial, which you can't see here, and the peroneal artery. So we cannulated the anterior tibial artery, and on this slide, we performed an arteriogram, and as you can see here, there's heavy plaque burden throughout the anterior tibial artery. Here's the proximal portion of it. You can see there's kind of notching of the vessel. More distally, once again, notching of the vessel. And then there's almost a halt in the flow of contrast when you reach the ankle. Hope you can see here that this is the ankle bones and this is the foot. And so this patient had extensive disease in the anterior tibial artery. So we decided to treat that disease, and the way we decided to do that was by employing intravascular lithotripsy. Now, for those non-physicians in the audience, intravascular lithotripsy, what that essentially is that we put a wire in, put a balloon over that, and then we use shock waves or sound waves to kind of pulverize the plaque, and that restores blood flow and restores patencies of the vessel. So like Dr. Oye said, the first step in endovascular surgery is to get a wire through. If you can get a wire through the lesion, then you're halfway there. And we got a wire through. We put the lithotripsy device in place, and then we inflated the device to treat the diseased vessel. Now, on the right image, you can see that even though we tried to inflate the device and inflate the balloon, there was some resistance, and that's why there's kind of some notching over here, and in between. But that's because of the heavy plaque burden that was in this patient's anterior tibial artery. Nonetheless, we're able to successfully treat the anterior tibial, and here's a quick before and after illustrating the patent anterior tibial artery. Here it was before, and afterwards, it's almost complete. Like it was we were able to revascularize the patient. So the question now was, how do we access the posterior tibial artery? Because like I said, the patient had disease in both the anterior tibial, the peroneal, and the posterior tibial. Now we only really need two of these vessels to kind of restore blood flow to the leg. We don't have to maintain a three vessel runoff. We were perfectly fine with having her have patency in the anterior and posterior tibial. But because we couldn't do an antegrade cannulation of the posterior tibial, Dr. Oye thought of the idea of trying to cross the pedal arch in a retrograde manner and access the posterior tibial from the distal aspect of it, and then push up and eventually cannulate and successfully cannulate the posterior tibial artery. Now I use this image as kind of a oversimplification of the vasculature of the lower extremity, where you can see here the popliteal artery, anterior tibial, the pedal arch, posterior tibial. So the idea was you put a wire through here, you go down, cross over, push it up, and you should have access to the posterior tibial. And so that's what we did. It was slow, it was difficult, but eventually with expertise like Dr. Oye, we were able to make it through the posterior tibial. Here, you can see the catheter slowly into the anterior tibial. As we advance the wire, we also advance the catheter. This is the catheter in the arch. And eventually we're able to successfully push the wire through. After we confirmed that we're in the posterior tibial, we then performed an arteriogram of the posterior tibial, and it showed extensive disease, an occluded posterior tibial actually. And it's, well, you can appreciate these collaterals over here, and that is a result of the occlusion. So once again, we attempted to pass the wire through the entirety of the posterior tibial. It was difficult at first. As you can see here, the wire isn't straight. On this image, the wire actually kinks over itself and kind of rolls back on itself because it's meeting some resistance. But slowly and surely, we're able to push the wire through. And on this image, you can see this is the wire going down in the anterior tibial, and it's the wire going up in the posterior tibial. And because we had that open arteriotomy site at the tibial peroneal trunk, once we push the wire down the anterior tibial and up through the posterior tibial, all we had to do is just pull it out of the anterior tibial, flip it over, and we had access. So we flipped the wire over, we put a balloon through it, and then proceeded to perform a balloon angioplasty of the posterior tibial artery. So here it is. We're inflating the balloon, inflating the more distal aspect of the posterior tibial. We're treating the distal most aspects of the posterior tibial. You can see here that the balloon isn't fully inflated because there is heavy disease burden in the posterior tibial artery. But having cannulated, having done the balloon angioplasty, we're able to restore patency. Here's a before and after image of the posterior tibial. Here you could almost see no flow through the posterior tibial, and after balloon angioplasty, we're able to restore blood flow through the posterior tibial and the anterior tibial. And so this is an example of how hybrid procedures and endovascular surgery can treat complex cases such as this one. So the popliteal artery also needed some balloon angioplasty, and so we decided to treat that. Here you can see there's some areas of stenosis over here. Over here, we inflated the balloon so it's full and restored patency. So here's a before and after image. You might not see the knee as well because of the subtraction image. However, this is a before image where you have the distal SFA, the popliteal artery, which is heavily diseased. And here you have the popliteal artery, which is more continuous. And you can see blood flow in the popliteal artery it was successful. So after the procedure, we then proceeded to close her up. We closed the arteriotomy site. We closed the patient in a stepwise fashion. And we confirmed the DP and PT pulses with Doppler ultrasound. Postoperatively, the patient did well. She stayed in the hospital for about 2 days. Her pulses were present on DP and PT on Doppler. Her Jackson-Pratt drain was removed on the day of discharge and had minimal bloody drainage. Sorry. She was discharged on dual antiplatelet therapy, aspirin and Plavix, 81 milligrams, 75 respectively. And she was told to follow up in the clinic in a week for removal of her stitches. So what are some technical pearls that we can derive from this case? Well, first, the patient's positioning and exposure of the vessels is key. You flex the knee to allow for adequate exposure and of the popliteal artery and perform the endarterectomy. Then you cannulate the patent tibial vessel. In this case, it was the anterior tibial. We were able to cannulate. We introduced a guide wire, first the antegrade fashion, going down, and then crossing the pedal arch, and then going up in a retrograde fashion into the posterior tibial artery. Throughout this throughout the technique, we had to exchange support catheters and perform whatever intended therapy that was needed. In the anterior tibial, because of the disease, we had to do intravascular lithotripsy in the posterior tibial. We did balloon angioplasty. Had there been a case for thrombectomy or atherectomy, we would have done those too. And I would like to emphasize that having multiple wire and support options is crucial and critical, as the pedal arch is highly tortuous. First of all, it's an arch, but it's incredibly tortuous. Luckily, this patient didn't have as much tortuosity in her pedal arch. However, if you meet or you encounter tortuosity and heavy calcifications, then it would help having multiple wires and having different catheter supports to help navigate through the occlusion. Some things to consider intraoperatively: anticoagulation strategy and embolic protection planning. If the patient had a thrombus, we would have to use aspiration devices to prevent the embolization of that thrombus. We managed heavy calcifications using intravascular lithotripsy, using balloon angioplasty, and had we needed, we would have also done an atherectomy. We were able to troubleshoot the crossing failures by changing support catheters, changing wires, using alternative wires. We injected some contrast to kind of guide our path through the arch, and so we can know like where we're going with, and not enter like aberrant branches or enter the collaterals. And finally, if all else failed, we could always extend the surgical site or stage a hybrid bypass. Some strengths of the pedal loop technique include the expanded access that it gives you. It provides an alternative when the antegrade or distal percutaneous routes fail. This combines a hybrid, an open and endovascular procedure into one. So it's a hybrid. It's a great example of a hybrid procedure, best done in a hybrid OR. It enables full tibial and pedal revascularization as using one stick. By preserving other access sites using one stick, we're able to treat the anterior tibial, and had the patient had disease in the pedal arch or the pedal system, we would have been able to treat that, and we were able to treat the posterior tibial as well. And so we preserved access sites, we avoid multiple distal punctures, and we're able to avoid more foot trauma. Some limitations to the technique, however, I would say the most important is the anatomical dependence that this technique requires. The technique requires a continuous and patent pedal arch. Can't stress this enough. Not everyone is going to have that perfect pedal arch. Some people will have a variant in anatomy, which I'll discuss in the upcoming slide. But some people will have a variation in their anatomy, which would make this procedure virtually impossible or make them ineligible for the procedure. If the patient were also to have severe calcifications, we would also have to abort the procedure and try some other way, because that would prevent the wire or device to pass through the lesion. And like I said, if you can't make a wire go through, then you're not going to be able to do anything. You won't be able to treat either using lithotripsy or using balloon angioplasty. Also, the procedure requires that the patient be placed, or the procedure be done in a hybrid OR setup. And it requires that you have experienced operators, as this is an endovascular procedure as well as an open procedure. And because there's limited data and fewer comparative studies, you're kind of doing this procedure on a learning curve. So there's no strict guideline as to how to do it. You kind of just take it as it goes. And so these are some of the limitations of the technique. Like I said, the anatomical variants vary from patient to patient. Some patients may have a dominant posterior tibial artery supplying the leg. Some may have a dominant anterior tibial, and some may have a dominant peroneal artery system supplying the legs. And so pre-op planning really makes a huge difference in this when deciding to employ this technique. Some patients, they might have an incomplete or an absent pedal arch, and so they would obviously be poor candidates for the procedure. Now, pre-procedural planning, like I said, is important. If I learned anything in my rotation with Dr. Oye, it's that CTA isn't always right. However, with the advancement of more advanced and modern imaging techniques, such as the 4-dimensional computed tomography, we're able to properly visualize the vessel caliber, the vessel size, the degree of stenosis, and the tortuosity of the vessels. And so we're able to map out and plan the procedure much better with these more advanced imaging techniques. If the pedal arch is incomplete, we'd have to consider alternative strategies such as antegrade techniques, and if those fail, then a hybrid bypass. And we also have to plan the device sizes to be used, the catheters to be used, the wires to be used, whether it's a stiff wire, a glide wire, etc. And we do all that based on the pre-op planning. We do all that based on the patient's vessel diameters and their calcification patterns. So to conclude, the pedal arch crossover technique is a valuable tool in our endovascular toolbox to be used when antegrade or distal access is not feasible. It enables the delivery of intravascular lithotripsy, drug-coated balloon, angioplasty, atherectomy, or thrombectomy to occluded tibials, and with minimizing the punctures that we give to the patients. It's best used for patients with a continuous pedal arch and acceptable surgical risks. These risks include wound issues such as wound healing, embolization, and technical failure if they have unfavorable anatomy in the OR. It also requires a high level of technical expertise by the vascular surgeon or the interventionist in manipulating guide wires and using the support catheters. So future steps that could be done is we could perhaps employ larger studies to determine the long-term patency and limb salvage outcomes, as well as comparisons between the pedal arch technique versus, say, antegrade techniques or more retrograde pedal revascularization techniques. Thank you for listening. I'll be taking any questions now.
Thank you, Dr. Ibrahim. That was a very comprehensive talk. Nice presentation. Again, for the audience here, what Dr. Ibrahim has indicated as a patient today with long artery in the knee area with a blocked artery in the knee area. And I also have blocked artery from the knee to the ankle, and the inner side of the leg. The blocked artery from the knee to the ankle and the outside. Outside the leg. So to the ankle. So the way it was achieved, primarily this patient came in with osteosis in the leg. So to prevent that, we either have to do two options: open surgery, which will do a bypass from above the knee area to one of the target arteries at the ankle area where the arm will be open. Or we can use this technique where we open the artery at the knee level, and from that area choose the plaque out or plaque. Then we're able to direct a wire into the outermost portion of the artery, the anterior, which is this one here. And we took that wire down and with some lock and scale, the wire went down. Then we're able to use a special ultrasound called intravascular lithotripsy, like ultrasound machine that blasts plaque. With that, we're able to have both the artery, so the area that are tight to that artery run better. Once that was better, we then were able to manipulate the ketone, this ketone area. But the reason we talk why it's so unique is the artery in the top of the foot, top of your foot, that goes from the outside of the inside, it's an arch, so the heel arch. So making a wire going through that heel arch can be very tricky. And plaque, you have this very winding and bendy, but we're able to carefully manipulate the wire through that arch. Once that occurred, and we now said, okay, we open one artery down, I have no illusion. Okay, we open the other artery, which I have to go from the groin to the ankle. So we then manipulate the wire from outside the leg through that deeper arch and came up. Retrograde, now we go into this part, retrograde. When you go away from the heart, it's antegrade. And when you go towards the parts, it's retrograde. So with some law, I'm the benches. We're able to make a wire go up through a complete block artery from right here and all the way up. So when it comes to the knee, we capture the wire, because we made a cut here already. We capture the wire, then we use the special balloon and it's draw coated balloon to now open that artery, and it has to be called which shows in the artery, and that's all which is problem to some extent. If you look from the knee down, it's not solved. But the original problem she also had was she didn't look at the artery at this knee level. So we had to make a wire to go up from that level below the knee, go towards the head. And again, we use a special tool again to open up arteries and to supply out and we solve the patient's problem. At the end of the surgery, the patient had a pulse on the top of the foot and on the side of the foot, and the side of the circumcision artery. So again, this patient just was saved from losing her leg by doing this unique technique, not go through the second cut of the ankle, not do the bypass. We had to do a bypass, had to take a vein from the same leg of the slab, so then do a bypass, make a cut here, make a cut here, and tunnel that vein top here to here to get the flow down. So that's going to save the patient in the long run. So big surgery, such as vein, having another cut, take vein out, all that, we avoid it by using just one cut to solve the problem, which is the total problem. So that was a great case. Great. Any other questions? That's a great presentation. Any other questions from the Senate? Any questions here? Any questions? All right, we'll move on to the next. Thank you. Thanks.
Okay, thank you again, Dr. Ibrahim. I'll give you a minute to catch your breath so we can introduce the next speaker. And I believe after the next speaker, we're gonna go on the meeting break, right?
Yes.
All right,
Next
so
speaker.
ready? So the next speaker.
Our next speaker will be a third-year medical student, Laurentia Ugoji. She will be presenting a case on unmasking the myocardial bridging. Laurentia, the stage is yours.
Okay, thank you. Laurentia, the floor is yours.
Thank you so much for the introduction, Ibrahim. Okay, I'm just going to share my slide right now. Okay, my slide is visible, right?
Yes,
Hello,
it is.
okay,
Yes, it is.
awesome. Okay, perfect. Good morning, everyone. I'm Laurentia Ugoji. I'm a third-year medical student, and I'm making this case report on the topic and unmasking of a myocardial bridging. And I do want to acknowledge my preceptor, Dr. Sad Safar, under whose guidance I got exposure to this case. So in the course of this presentation, I will talk about the case itself, the investigation and the findings, the pathophysiology, the clinical relevance, the management and the outcome, discussion, and a conclusion. So just getting started right into it. This case was a 63-year-old male who presented in the ER. He complained of chest pain that began while pushing a partner on a wheelchair. And during the episode, the patient did pass out and was brought into the hospital. There was no radiating pain in the arms, neck, or any prior chest pain as of presentation. The past medical history of this patient did include a coronary artery disease of over 10 years and hypertension, which was being currently managed. Surgical history of this patient was a coronary artery bypass graft 7 years ago. And the social history of this patient was smoking history, however, does not use recreational drugs, but is an alcoholic. So, with the investigation and findings for this case, the aim was really to rule out a stroke versus a cardiogenic cause of syncope. So, a CT head and neck was done, an EKG was done, an echo was done, and a CTA as well was done. And on the CT scan of the head, there was no hemorrhage seen or a skull fracture. So, that helped us rule out a stroke. And on the EKG, a normal sinus rhythm was seen. However, a stress test echocardiography showed an inferior wall ischemia, and the ejection fraction of this patient was around 45%, which was slightly below normal, which would typically be around 55 to 60%. And on CTA, a segment of a coronary artery was seen to actually deviate from its normal epicardial path, diving right into an underlying myocardium. And this is typically what you would have seen on the CTA of this patient. And the conclusion was that a systolic, for every systolic that the patient did go into, you would see the coronary artery get compressed. Now, moving over to the pathophysiology and clinical relevance of this case. So I'd really just quickly define what a myocardial bridge really is. And it's a situation where you have a band of muscles known as the myocardium cover or actually compress coronary artery. And oftentimes it's seen at birth. It affects about 5% of the population and it's incidental. Most times you do catch it on an angiography. However, 25% of the cases are seen in autopsy, so that's at death. And the clinical impact is that it presents just like a typical angina. You would see ischemia. A patient as well could present with arrhythmia, and it could also cause sudden death. When it comes to the prognosis, that is the outcome of this scenario, most cases actually are benign. They do not cause as much significant health problems. However, depending on how dilated or how affected this coronary artery is, and the coronary vessels, just to clarify, are the vessels that supply the heart with oxygen. So depending on how compressed it is within this muscle, you would actually find this patient being symptomatic and having like a heart attack or even a sudden cardiac death. So when it comes to management and the outcome, oftentimes if they are actually symptomatic, you would go for pharmacological interventions like beta blockers and calcium channel blockers. And on interventional cardiology aspect, you would have these patients going for a cath. And in our patient, 2 stents were actually placed on the right coronary vessels to actually aid the supply of blood towards the ischemic portion of the heart. That was actually reported when the CTA was done. And a surgical approach could be taken into consideration as well. However, you do have to consider that there could be other prevalent comorbidities. And in this case, we actually stuck with pharmacological management for long term, and there was significant improvement in our patient. So over here, I do have an image of a typical myotomy, which is a procedure, and it's an open heart surgery. It's a procedure where you go right into open up the heart and you take out the muscles that actually compress and cover this coronary artery, which is causing the myocardial bridge. So over to the discussion. So a few things I do want to highlight in this discussion is that a myocardial bridge is often not benign. So you would typically see this presenting as angina, arrhythmias, an MI, or even a sudden cardiac death. And when it comes to the therapeutic considerations, pharmacological aspects are indicated. However, unlike a typical MI, myocardial infarction, or a heart attack, you actually don't want to give these patients nitrates because nitrates will actually exaggerate the systolic compressions, and they have a way of dilating the vessels that are actually distal to the myocardial bridge itself and cause a decreased reperfusion time. So when to intervene in a situation like this for a PCI, which is a percutaneous coronary intervention. Oftentimes you would want to do that, but it fails because this portion of the heart being supplied by the blood, or rather the vessel that's actually bridged over here, is predisposed to fracture and restenosis of the stents in such an area because there's always a higher shear force around this vessel that is in the bridge itself. So a surgical myotomy could also be considered. However, that is a high risk surgery. So you have to also look into the patient's presentation and what else could be factored in to ensure that they actually have a better mortality rate with this disease. And in conclusion, recognizing the myocardial bridge is critical because you want to prevent misdiagnosis, you want to prevent an availability bias, and guide a safe therapy. Thank you so much for listening, and if any questions, I would be open to answer them.
Next presentation. Presentation. There's a patient especially locally in that area. Any more questions from the audience? Can you hear me?
Yes, I can.
Yeah, was it to drink locally in that area?
Sorry, I didn't get the question.
Yeah, was it to medically or someplace else for the stenting?
Yeah, I still didn't get the question.
Was the patient treated in Beckley or someplace else?
Could it be typed into like the chat probably?
Okay.
Yeah, thank you.
Thank you so much.
Thank you too.
Let me just try this for her.
Okay. Okay, okay. So this patient was actually at Raleigh General Hospital.
Raleigh.
Okay, very well. Thank you.
Okay.
Thank you so much. All right, thank you, everyone.
Thank you.
So we're gonna break right. Okay, does anyone have questions, any else? Okay, Brian, anyone with questions from your end?
No, there's none.
Okay, so at this point, we could go on a 5-minute break, just so you can stretch your feet and then.
That's
Okay.
right. Ask him if he's gonna stay there or is gonna transition to another patient.
Okay, Dr. Ibrahim, are you gonna stay there or are you gonna transition, change location?
I'll stay here.
Okay.
Okay,
Now, can we improve the audio quality on your side or is it from our side?
we're looking for earlier now because you have networks. Okay, 5 minutes. Remember, the theme is PAD, and one way to not be on that boat is to have good circulation. So stretch whilst you have your break. Thank you.
Thank you.
Stretch you all okay to stretch. Don't leave a sedentary lifestyle. Can you mute me now, please? Stretch people. While we're stretching. It's me, it's me.
Ibrahim.
It's not nice. Are they ready?
Okay, welcome back everyone to Dr. Ibrahim, are you there?
I'm here.
Okay, awesome. Can you take over from here and introduce your next speaker?
Sure.
Thank you.
Ladies and gentlemen, I'd like to introduce our next speaker, Dr. Oluyemisi Sangodeyi, a seasoned general surgeon and healthcare leader based in Beckley, West Virginia. He's the founder and CEO of MedSurg Physician Group, where he oversees a broad clinical practice, including surgery, wound care, trauma services, and medical administration. Dr. Sangodeyi is a board-certified general surgeon, a fellow of the American College of Surgeons, and holds credentials in addiction medicine. He's a graduate of the University of Ibadan Medical College. His postgraduate training including surgical residencies in Pittsburgh and Colorado. Beyond his surgical work, Dr. Sangodeyi is deeply invested in global health and charity through his co-funded World Health Mission Organization, which provides free medical care to underserved communities. Dr. Sangodeyi today will be speaking to us about global health, and we look forward to his presentation. Dr. Sangodeyi, the stage is yours.
Thank you, Ibrahim. Good morning here in US and good afternoon over there in the rest of the world, I think. Can you all hear me? Because the audio was very poor initially. Are we hearing me well?
Yes, we can.
That's very good, Cynthia. So the wall behind me, you see the world map that I intentionally got to sit behind me because of my big interest in global health. Recently, I was looking at my email, and the American College of Surgeons is going to start sometimes in January a 12-month online course on global surgery, which is so exciting. I mean, Dr. Oye will be an expert in that as he's been globetrotting and doing global surgery. And I do have some experience in that as far back as 1980 when we formed the World Health Mission. But not to bore you with my introduction, my talk today is a brief overview of global health. Global health is such a broad topic. It's usually a 12-month postgraduate course. I did the certificate in global health at University of Pittsburgh many years ago, and I do practice global health with my experience globally in different parts of the world. So today I will be giving you an overview of global health. It will be a very, very brief introduction. There's no way to cover such a broad topic in such a small time. Well, in front of you is the globe of the world with the African continent fully enlarged. And then next slide, please. So what is global health? There are so many definitions to global health. But basically, global health is a field that is very interdisciplinary, and its aim is to improve health and to also achieve equity all over the world. So you have to realize that health challenges transcend national borders. No matter what is going on in the world right now, globalization is here to stay, and no country can just harbor and protect itself fully. There's a lot of challenges with regard to health all over the world. Global health requires collaborative and multidisciplinary solution. It's not just about physical health, but it addresses the biological, social, economic, political, and environmental determinants of health. Global health aims to prevent disease and promote well-being and extend life expectancy on a global scale. The acronym PACE, P-A-C-E-S, describes fully what global health is. P for population, A for action, C for cooperation, E for equity, and S for security. So in short time, basically describe what is global health. Next slide, please. Go ahead to the next slide, please. Good. So what is health? I prefer this World Health Organization definition of health. The way we regard health is usually just a physical well-being. This is not true. Health is state of complete physical, mental, and social well-being. It's not just merely the absence of disease or infirmity. So World Health Organization has defined health as that, and that's what I believe in. At the end of this lecture, I want everybody listening to be interested in global health. This is a field that needs contribution from everybody, engineer, economists, teacher, physician. So it's not just healthcare that should be involved in global health. And at the end of this lecture, I want everybody to be able to be very interested in global health and contribute or study and research global health. Next slide, please. Now, the World Bank has categorized various countries. I think in the world, globally, there's about 7 billion people in the world across 200 countries. And the World Bank has used the gross national income per capita to define countries' wealth. And the importance of country wealth to global health is very critical. Next slide, please. So this slide is very busy, but I will just summarize it. This was every July 1 of every year, the World Bank will review their classification and print out their different categories. There are low-income countries, lower middle-income countries, upper middle-income countries, and high-income countries. High-income countries, example, are United States, Germany, Japan, Australia, and Canada. Their GNI, gross national income per capita, is over 13,000. Nigeria belongs to lower middle income countries with gross national income being between 1,000 to 4,000. The very low income countries include Afghanistan, Nigeria, Yemen, Mozambique. So this is very important to classify country according to the wealth that develop. Next slide, please. Now, this income classification is very important. It helps us understand health disparity, funding, and policy planning. For those who are policy guru, trying to figure out where country belongs to is very important. So life expectancy, infant mortality, disease burden differ very sharply by income group. And various funding group like the Global Fund, the Association for Vaccine and Immunization, they call them Gavi, very important, and IDA and other funding like Bill Gates Foundation. They look at all these income classification to decide on where they fund. Same thing with policy planning. So it guides resources allocation for health system, education, and infrastructure. Next. So the trends since 1990 to now is that many countries are moving upwards, which is good. So many countries like China, India, and Vietnam, they used to be low income, then they moved to middle income. However, because of wars and conflict all over the world, certain countries still remain kind of trapped in the low income status. The global inequality persists. In the high income countries, the GNI is 40 times higher than in low-income countries. So there's a lot of disparity between income of nations. Next one, please. Now, global life expectancy is another important thing in global health. We want to live long, but it's not enough to just have a long life expectancy. You want to live healthy. So there is the global life expectancy, and there's what we call in global health HALE, healthy life expectancy. I may live healthy for 60 years, but the next 20 years of my life may have chronic illness. So it's not enough to just have long life, but also you want to have long life in full health. So life expectancy globally is very important as part of the way to measure impact of global health. Next slide, please. Now, the current global figures, 2024 to 2025, globally, the life expectancy is about 73.5. This is just an estimate. It has increased from 66.8 years in 2000. And then the health life expectancy, HALE, which I call HALE, is 63.5, which means globally, most people will live healthy life to about 63 years, and then subsequently, everything starts to deteriorate. That's what they call the golden age. So people describe golden age and say, well, this is nothing golden at all. I'm falling apart once I reach 60. So we all know that women live about 5 to 6 years longer than men. And there's a lot of regional variation. As far back as 18th century, the life expectancy globally was only 35 years. So you can see there's been a lot of improvement with improvement in disease treatment, and we are up to 73.5. In Africa, the life expectancy is about 64 years, whereas in Europe, it's about 79 years. But I always look at this figure with concern. My mother is 99 years old and still very healthy. And many people on this conference have parents that are very old and 100 years old, 99 years old in Africa. So this figure may be revised, but I remember growing up, when you live in Nigeria to be 50, you are very, very old. That's not true anymore. So I'm happy to report that life expectancy in Africa is up to 64 years, very possibly a lot higher than that. Next slide, please. Now, this is a very busy slide, but I'll just read it to you. It basically just gives us the 2024 data of regional life expectancy. You see Africa is 64, America is 77. Why is Africa life expectancy so low? It's still because we have infectious disease burden, what we call communicable disease. There's a lot of maternal and child mortality. Whereas in the Americas, the chronic disease management, because most of the death now is because of non-communicable disease, and there's been improved chronic disease management. Next slide, please. Now, another important topic in global health, so I'm just going through these topics that are very relevant to global health, is child mortality. Well, this is one of the most important indicators in global health. It actually reflects the combined effects of health system, nutrition, education, poverty, and equity. So if you study the child mortality in each country, you can guess how good their health system is or their income. Next slide, please. Now, what do we define as child mortality? I'm sure most of you listening to this lecture understand what that means. Well, it refers to the number of deaths among children under the age of 5 per 1,000 live births in a given year, where this includes infant mortality rate and under 5 mortality rate. All you need to know for this lecture is the importance of child mortality. Next slide, please. And again, this is another busy slide. This is just comparing child mortality in various countries. So you see in sub-Saharan Africa, under 5-year mortality per 1,000, that is how many children will die per 1,000 at the age of 5 or under. Sub-Saharan Africa is 70, which is the highest. And look at the Southern Asia is only 37, and Europe is only 5. So you could see that sub-Saharan Africa has the highest rate of under 5 mortality. That reflects our poor health system, the poor health system in that part of the world, and the inequality, the low income, sanitation, and all those. Next slide, please. Now, what are the causes of neonatal death? Preterm birth complication like birth asphyxia, trauma, neonatal sepsis, post-neonatal, which is like 1 month to 59 months, pneumonia, diarrhea, malaria are big problem. Malaria continues to be a big problem. Malnutrition, also big problem. So these are the examples of problem that causes our high child mortality in that part of the world. Now, there are other emerging issues like vaccine preventable disease, humanitarian crisis, which is basically war, WARS, conflict, climate-related displacement, migration, and all those problems. So this, in summary, these are the causes why we have such a very high child mortality in that part of the world, the sub-Saharan area. So we all need to join hands and improve this problem. Next slide, please. Now, I must say, despite all this doom and gloom story, there have been some success stories. Example is Bangladesh, very poor country in a way. They have reduced their under 5 mortality by over 75% since 1990. How did they do it? Community-based care and female education. We all know the importance of educating female in all cultures because the female control and they are very influential in bringing up their children. So if you educate female on healthcare and basic education, and you have a community-based program instead of just saying I, if you remember that we, WE, is greater than I, this can be accomplished. Another success story is in Ethiopia, which has improved their immunization and so far reduced dramatically their child mortality. Vietnam and classic Rwanda is another success story. They focus on primary care and equitable based intervention. So we can learn from these 4 countries as to how to improve child mortality and improve health across the so-called low-income countries. Next slide, please. Now, maternal health is another very global topic. It's another way of measuring health of a country. Maternal health refers to the health of women during pregnancy, childbirth, and the postpartum period. So according to the World Health Organization, maternal health is a reflection of a country's overall development and the strength of its health system. So if you give me the maternal mortality rate of a country, I can tell you their health system is good or not good as a globalist. Next slide, please. Now, this is another basic slide. I'll just kind of read it to you. What causes maternal mortality? Big one is severe bleeding, postpartum hemorrhage. When I was in training in UC Ibrahim, we see a lot of death just from postpartum bleeding. There are simple devices that can easily control postpartum bleeding, but we see a lot of people succumbing to this. It is one of the leading direct cause of pregnant women. Eclampsia and preeclampsia, hypertensive disorder, infection, obstructed labor, unsafe abortion, and malaria, HIV, anemia are all things that could increase maternal mortality. Fortunately, all these that I mentioned are very elegantly preventable. So it is the job of all of us, doctors and non-doctors, to find a way to treat this condition so our maternal mortality can decrease in the so-called poor country. Next slide, please. Now, there is a global progress in maternal mortality ratio, but 2016, the progress has kind of reduced. In sub-Saharan Africa, the maternal mortality is about 545, which is 136 times higher than in Europe. In the high-income countries of like Europe and US and UK, it's only 12. They're still significant. So this is all these disparities due to racial, socioeconomic, and geographical inequality. It's our job as healthcare and globalists to try to bridge this gap and reduce all these inequalities. Next slide, please. Now, well, during the COVID, there was a lot of setback because of disrupted maternal care and supply chain. So another thing that is important is adolescent pregnancy, about 12 million annually, climate change that increased malaria, food insecurity, and migration risks for pregnant women. Despite the naysayers that don't seem to believe in climate change is real. So it's irrelevant what the fake news is saying that there's nothing like climate change. It is real, everybody knows it, but people pretend like it doesn't exist for political gain. Now, humanitarian crisis, I'll talk about war, WARS. This is a big thing in different parts of the world. We just seen the Israel-Hamas conflict, the Sudanese conflict, Yemen, Russia, and Ukraine. So there are still many parts of the world where humanitarian crisis, conflict zones continue. This affects global health significantly in those parts of the world. Next slide, please. Now, what disease pattern that we see, what is the classification? We have the communicable disease, which is basically what we call infectious disease, transmissible disease. These are diseases that could be spread between each other by pathogens. Those pathogens could be viruses, bacteria, or parasites. This is still a big killer in the developing world or the underdeveloped world or the low-income part of the world. But I must say that globally, non-communicable disease is still the main killer. What do we call non-communicable disease? Examples are cancer, diabetes, and obesity, and coronary artery disease, and peripheral arterial disease. Now, the big one that people don't seem to talk about enough, but it seems to be getting attention, is mental health. I must tell you, 14% of global health burden is due to mental health. And it's alarming that only 0.3% of health funding is devoted to mental health globally. So mental health is very important. 14% of the global health burden is due to mental health. So it needs to take a big priority in all over the world. Trauma, one of my big concerns each time Dr. Oye traveled to Nigeria is the roads. And And when I travel to Nigeria, roads is the scary place. A lot of accident on the road, all over the world. As a trauma surgeon, I deal with trauma all the time. And of course, the big one, which is the big elephant in the room, is wars. It's so sad that human being can go to the moon, but we cannot prevent wars. So war is a big issue across the world. Next slide, please. Now, another big thing that is very important is vaccine preventable diseases. These are infectious diseases that can be prevented by vaccination. It's unfortunate that you have, especially in the US, there's a lot of people that have been fed their stupid issue like vaccine doesn't work or something like that, or cause problem. But these are very important diseases that can easily be treated. Now, the core principle of WHO is that no child should die from a disease that can be prevented by a vaccine. Let me just repeat that. No child should die from a disease that can be prevented by a vaccine. It's a very safe immunization system that has saved a lot of people across the world. Next slide, please. So what are the vaccine preventable diseases? We have recognized at least 21 diseases that are vaccine preventable. And I'll quickly go over that. Measles, polio, diphtheria, whooping cough, tetanus, hepatitis B, Haemophilus pneumococcal disease, rotavirus, HPV, and influenza. I will not go into explaining that for lack of time. Next slide, please. Now, so I have to tell you that HPV, the success story is that HPV vaccination is now scaled up in over 140 countries. This targets cervical cancer. Measles deaths have declined significantly. So let me just tell you the global impact of vaccines. It has prevented at least 5 million deaths each year, every year. Vaccination has prevented 5 million deaths every year. Child mortality from this kind of disease has fallen dramatically since 1990. Global vaccination have coverage reached 84%, but unfortunately, there's still at least 14.3 million children that still need to be vaccinated and could not be vaccinated yet. Next slide, please. Now, let me just, while we're talking about the vaccine preventable disease, I have to remind you that smallpox was a big killer of human beings up until recently. Smallpox was eradicated from the face of the world in 1980. It was declared eradicated. We hope it never come back. Polio is another disease that has been satisfactorily cured or prevented. And I believe in 1990, at least 99.9% of polio has been eradicated. There are still 2 countries that we still have polio, Afghanistan and Pakistan. We are hoping that will improve. Now, another one that I need to talk about before finishing is what they call neglected tropical disease. This is basically what I regard to as forgotten diseases. Why are they neglected? One big reason is the pharmaceutical investment. They don't see money in developing medication for this kind of diseases, so they don't do it. There's low political priority, and there's underreporting, and the poverty and history of these diseases. Next slide, please. Now, again, I will just read this to you real quick. So these are the neglected diseases. They're mainly tropical, mainly in sub-Saharan area. Chagas disease, what they call Trypanosoma cruzi, Leishmaniasis, Schistosomiasis, Elephantiasis, Onchocerciasis, Trachoma, Buruli ulcer, yaws, guinea worm, and dengue fever. Those are the classic tropical diseases that have been neglected because there's no good treatment for it. But these are very easy to treat if we can get pharmaceutical agent to help developing stuff. So for all the young people and the young scientists and young doctors in the audience, this is one group of people that you can work on and help, because it's a big burden across the world, especially in sub-Saharan Africa. Next slide, please. Now, pandemics is another global thing that we all know. It looks to me like every 10 years, there's a major pandemic across the world. No matter what is done, we're going to have another pandemic sooner or later. Unfortunately, the powers that be continue to distract from preparation for the next pandemics. The big one was HIV, that was started in 1981 up to the present time. The global impact was important. There was at least 40 million deaths from HIV, over 85 million people infected. This is bad. So the global initiative like UNAIDS, PEPFAR, and Global Fund have significantly reduced mortality. Next slide, please. I got to move a little bit faster. Another one is H1 swine flu. Next slide, please. Ebola virus. Next slide, please. Zika virus. Next slide, please. These are the most recent pandemic. And of course, the big one is COVID-19, which killed at least 7 million. Next slide, please. Monkeypox, which they call Mpox. Next slide, please. The trends and future, okay? So a Millennium Development Goal of the United Nations and the need for big data and health metrics, artificial intelligence, all this is going to help us continue to fight this. Now, I will need to just mention before I close, organization in global health. World Health Organization, which unfortunately one other country is trying to defund. Gavi is very important in immunization. CDC, unfortunately, this used to be the main bulk of good science. This has also been continue to be built up. Bill Gates Foundation, UNICEF, World Bank, World Health Mission, Oasis Global Health, Uzuma Foundation, and the Oasis Foundation. So all these organizations are very important in fighting in developing global health. Next slide, please. Because of time, and I rushed this presentation, like I told you, I cram a 12 months postgraduate course in 20 minutes. I thank you very much. If there's any question, I will listen to you. Otherwise, the next speaker seems to be ready. Thank you.
Thank you, Dr. Sangodeyi. Thank you, sir.
Okay,
Dr.
you're welcome.
Ugoji here.
How you doing, doctor?
Thank you, sir.
Good.
I'm fine.
That's good.
It's so very reassuring. Gives me hope that our world.
Yes, that's correct.
Hearing you, a surgeon, speak like a public health physician.
Yeah, that's what I like. Actually, like that a lot. Okay.
I love the transition.
Good. Thank you very much. Thank you very much.
Okay, sir. Thank you for your presentation.
Thank you.
Let me take it just to make a comment and then observation. When you got to, because I had it that I was going to ask, what you think. You got to the point where you say pandemics. I noticed something with the COVID pandemic, that the criteria the World Health Organization uses before then to declare a disease process, an infectious disease, a pandemic of global proportion. That with COVID, it took a while. Lots of the COVID epidemic, as it were, had made significant inroads into so many countries. And yet the World Health Organization was still waiting. I know there are set criteria, already established criteria. So what I saw there was that it took too long to declare, much longer than comfortable, to declare the COVID pandemic a pandemic of global proportion. I don't know what you think about that, if you followed that, and what you think about that. I will be suggesting to the World Health Organization to review that. And then you mentioned in your presentation that there is going to be some other pandemic in 10 years' time. And I've always said it, there will be another COVID, and that might just be worse. So I think it is high time the World Health Organization review the criteria for declaring an infectious disease process, in particular a pandemic of global proportion. They need to reduce the threshold a bit. They need to review it. Then just look at one of those statistics we put out, maternal mortality, 40 times worse in the developing countries. It's really scary. And I'm sure in some pockets, it's much more than that. I just wonder, I know, there's so much to be done about bridging the gap, as you've identified. May I know what your organization and the likes of OASIS are doing in engaging at governmental level or ministerial level, yeah. Especially
good
for
question.
The developing countries, those countries you visited. You talked about Gambia the other time, and you were going to Gambia. Do you have the opportunity to engage at those levels?
Well, good question. Yeah, I agree with you. There was a delay in WHO declaring global emergency. And so that's something, but with regard to what we are doing, let me tell you a classic example. Uzuma Foundation, which I am the vice president and co-founder, we are doing some work in Gambia to help with maternal mortality. We are working on hypertension and cervical cancer. So at the lower level, we are doing what we can do. OASIS Global Health is going all over the African country, helping with surgical management, developing endovascular techniques. So we're doing what we can do. But with regard to WHO, we can always write letters. I have to tell you, WHO, according to the current administration in US, they are trying to get out of that. Whether they did or not, I'm not sure, but I think they did. But I think progress doesn't go in a straight line. It's up and down, and sooner or later, somebody will see sense and start to do WHO. So yes, we will start working on that, but this refers to everybody to wake up. So I appreciate your comment. Thank you.
Thank you very much, sir.
All right.
Good seeing you again. Yeah.
Thank you, Dr. Sangodeyi. Thank you, Dr. Ugoji. And thank you for your presentation. Our next speaker will be a fourth-year medical student, Prerena Upadhya, who will be discussing a case of recurrent ischemic stroke following carotid endarterectomy, lessons in post-op thrombosis management. Prerena, the stage is yours.
Thank you so much, Ibrahim. Good morning, everybody. I'm going to share my screen. Right. Okay. Can you see the slides?
Yes, we can.
Okay. All right. So good morning, everybody. My name is Prerena Upadhya, and I'm a fourth-year medical student with Avalon School of Medicine. And first of all, I'd like to thank Dr. Oye for giving me this opportunity to present for today's global grand rounds. And today my case will be focusing on ischemic stroke following carotid endarterectomy, lessons in post-op thrombosis management. Okay. So our case starts here with a 64-year-old female that presented to the ED with acute neurological symptoms that began 2 hours prior to arrival. The patient complained of right-sided facial droop accompanied by progressive right-sided weakness starting last evening, prompting immediate evaluation. Symptoms are progressive in nature, and the patient had another event at the time of CT angiography. And the past medical history here is interesting because patient has a history of factor V deficiency along with DVT, PE, MI, mitral regurg, multiple sclerosis, and hypertension. And patient was on Coumadin therapy for DVT at the time of admission. So our chief complaint was right facial droop and right-sided weakness. Moving on to past surgical and social history. Past surgical history, patient did have a cardiac cath, which is pertinent to this case, and social history, patient is a former heavy smoker and currently is also smoking about half a pack a day, and no alcohol use, no illicit drug use. And then upon physical examination, our NIH stroke scale score was 8, which is moderate stroke severity. About 5 to 15 would be moderate stroke severity. And patient was alert, but did have mild dysarthria, so the patient couldn't really give any history, but the patient could say yes or no. And neurologically, she had right facial droop consistent with left hemisphere lesion, which we know is the dominant side of our brain. And she had expressive aphasia, again indicating left frontal involvement. Right upper extremity had flaccid paralysis and decreased muscle strength. Cardiovascularly, patient had regular cardiac rhythm without arrhythmia, and we did have left carotid bruit on auscultation. So initial symptoms, right-sided facial droop, right-sided weakness, and then the symptom progression to expressive aphasia and flaccid paralysis. And then we did a CT head non-contrast to rule out any hemorrhage or acute intracranial pathology, ruling out a hemorrhagic stroke, because patient does also have a history of hypertension. And then we did find CTA head and neck, we did find more than 90% stenosis of the left carotid bifurcation, and there was thread-like caliber of the right vertebral artery. So this is the imaging, and there was no collateral flow as we just discussed. Right. So here, this is the actual case where we can see, I don't know if you can see my cursor, this is the left side of the internal carotid. Here we have a better image, hopefully. And so initial management was first acute anticoagulation. Separate infusion was started immediately, and patient was discontinued from the Coumadin therapy. And then patient was taken for an open carotid endarterectomy over TCAR because she's not a good candidate for TCAR. Also, Dr. Oye decided to do an open CEA because first there was symptomatic stenosis, And we would offer CEA when there's more than 70% stenosis, and this patient had more than 90% stenosis, and then the patient was within acceptable time window. And also the perioperative risk profile was also acceptable. So he decided to go for an open CEA on the left side. So here we have Dr. Oye proceeded to do an open left carotid endarterectomy under the guidance of a on-table CT arteriogram. And then the procedure was tolerated well. And then post-op CTA, the patient did have acute left MCA infarct, which was consistent with the initial presentation. And then on post-op day 2, the patient developed a new event when the patient was doing fine, but under 24 hours, patient complained of sudden onset headache, which was enough indication to go and re-explore on the in the OR. So the patient was taken to the OR again, but there were no new neurological deficits. There was worsening of the right-sided weakness, flaccid paralysis, and CTA head and neck again showed us a complete occlusion of the left carotid artery bifurcation, but this time this was an acute thrombotic occlusion. We'll discuss why this might have happened later in the slides. So patient was taken to the OR again, and this time he performed a catheter-directed thrombolysis and revision. Catheter-directed thrombolysis was performed on the left carotid bifurcation. Infusion catheter placed under fluoroscopic guidance, controlled intraluminal thrombolytic therapy administered to dissolve the clot burden. Following thrombolysis, re-exploration of the carotid artery was performed, and then he put a temporary shunt to maintain adequate perfusion, and the thrombus fragments were removed. And this is a picture from the actual case, the thrombotic fragments. And then he closed the revision surgery with a patch angioplasty to close and reinforce the arteriotomy site, and place the JP drain. Satisfactory flow was confirmed by Doppler and angiography. Post-revision outcome, hemodynamically stable post-operatively. Also, we have to keep in mind that we need to maintain adequate blood pressure during and after the option. And follow-up duplex, patent left carotid artery with adequate flow. Neurological function did improve over the next 48 to 72 hours. And patient was placed on dual antiplatelet therapy. And we did a warfarin bridge. And then there were no further thrombotic events. Patient was discharged, and patient was doing good. And also the patient was referred to rehab for the expressive aphasia. So discussion for this case. First, we have early post-op carotid thrombosis is a rare but critical complication following TCAR or CEA. Usually, peri-op complications, they're pretty rare, but along with acute thrombosis, the patient can also develop cranial nerve injury like the hypoglossal or facial nerve, or it could be hyperperfusion syndrome. And then for this particular case, potential causes are hypercoagulable state, factor V laden, which I discussed in the first slide, I think. So this could be a reason the patient developed acute thrombosis. And then that caused plaque instability or stent thrombosis. Inadequate antithrombotic coverage could also be a reason. Then management goals are to rapidly devascularize to restore cerebral perfusion in the given time window. That is also a very important factor. Prevention of further embolic events, and long-term anticoagulation and risk factor optimization. Surgical revision with patch closure offers structural integrity and reduces recurrence rate. So again, key clinical considerations. First is timing. The urgency of revascularization against perioperative risk in this acute setting still remains controversial, but for this case, it worked out in patient's favor. And then anticoagulation, maintaining appropriate anticoagulation, especially with the patient's history of DT, PE, and factor V deficiency was really crucial. And then the aphasia worsening, this was an indication to re-explore the operative site. Again, given in the time window that we had. And then long-term success depends on anticoagulation control and smoking cessation. Smoking cessation is also very important because it continues to play a big role during these carotid stenosis cases. So yeah, thank you so much for your attention. And if you have any questions, I'm open to take any questions now.
I don't have a question. I have more of just a comment. Like, so post, carotid surgery where, there's a risk for ischemic strokes, in vascular, like we use a lot of like heparin, like drips and like stuff like that. So if we do see a patient post carotid surgery with stroke-like symptoms, I think it's important to know that we should, I think from the medical standpoint, hold like any kind of anticoagulation post-op until we get like, that CT brain, and it rules, even if we get a CT brain and acutely rules out a stroke, right? Because it takes a while for a stroke to show up on a CT brain. We need the MRI to confirm the stroke. But I think it's really important that we hold anticoagulation until we, confirm the stroke, just because acutely we're at high risk for hemorrhagic conversion, right? I think sometimes like with post-carotid surgery, it may not be a stroke. It can present like stroke-like symptoms. And sometimes we want to give the heparin and the full dose Lovenox, but we should ideally hold that until we rule out a stroke, just to prevent hemorrhagic conversion. I've just seen like from the medical standpoint, sometimes we give the heparin before ruling out the stroke. So I think that's just an important thing to make note of.
Yes, that's an excellent point, and thank you so much for emphasizing on that. Dr. Oye did tell me that we should give heparin in progressive doses, but not too much to prevent the hemorrhagic bleed. And also the patient had a history of multiple sclerosis, so the neurology department, they wanted to make sure that it's not a flare-up of MS. So yeah. Thank you.
Troy, you're muted. In case you're speaking, we can't hear you.
Acute for new onset ischemic problem of the brain and or bleeding. Because the bleed that you have to check the product population, because there's worst stroke symptoms, burn ischemic stroke, or hemorrhagic stroke. So that's correct. However, in the line of vascular stroke itself, in the cases where a patient had presented with the symptoms of carotid Retrograde disease, where the intervention in this case with a headache, which apparently stared off to the intervention, the intervention. We did do a CT post-op, which showed from the conclusion of the ICA. So there's no question about that. We should go back to surgery, and that's what question answer. Some has cardiac endarterectomy, they have to show up, post-op have occlusion disease confirmed in this case. Didn't back to surgery. If they're within the recovery room, set up a hospital, you just did it back or you just did a CAT scan. But in this case, because she was out of the OR for at least 2 days, we definitely to find out what's going on first. So we went ahead and did an increased CT, confirmed the occlusion, then took the surgery. We did not do thrombolysis, say we did thrombectomy with catheter-directed thrombectomy, and then did a 0.2 value flow and confirmed that absorption to blood clot in the ICA. Prior to closure of the artery, because the artery here smaller in view and on the redirect, we also did, because of stroke event, did put a shunt, arterial shunt for this procedure, definitely to minimize the risk of once in stroke. And we were able to now patch it, so we have to about confidence in time to patch it to make it bigger. And finally, the patient did well, was a postoperative #3 in ICU. Came on rounds and she's actually sitting in a chair. This is a patient who doesn't move her right hand that day before. This is a patient who had speech problems still, but she said yes. At the end of the surgical surgical care, before she starts rehab, she was beginning to say a few words. But take this coach, turn this salvation, and she's completely verbal. And she's also, in addition, she drove herself to the point of that's an elevation. So again, it's a critical message rather than read thrombosis, take that back to surgery and surgery.
Thank you, Dr. And then and thank you, Upadhya, for that beautiful presentation. Dr. Ibrahim.
Yes. So our next speaker will be a registered vascular technologist and financial advisor based in Beckler, Virginia. Ladies and gentlemen, please welcome Tracy Herbert. With a background in healthcare and years of experience in financial planning, Tracy brings a unique dual perspective, understanding both the clinical and financial challenges faced by healthcare professionals. Today, she'll be speaking on disability insurance for healthcare providers, helping us to understand how to protect our most valuable asset, our ability to work. She'll walk us through the essentials of coverage, common pitfalls, and practical strategies for securing financial stability.
Good morning.
Good morning.
Can everyone hear me?
Yeah.
Okay, good morning, and thank you for that introduction. Yes, I want to also thank Dr. Oye, actually all of the Dr. Oyes. I know the family personally and have worked with them over the years. So I really appreciate this opportunity being here this morning. I'm going to start off with just elaborating a little bit more on my introduction about myself. I'm a registered vascular tech by trade. I spent 20 plus years in the healthcare industry in one modality or another. A lot of those years were as a medical device rep in the peripheral intervention space, where I spent a lot of hours, days, nights in the OR and in the interventional suite setting with Dr. Oye. More on a personal basis, I'm a single mother with 2 adult children. And the reason that this topic is so important to me is that, number one, I see healthcare professionals and then also other clients affected by disability every day. Personally, I was affected in the aspect that one of my adult children was diagnosed 6 years ago with a grade 5 cerebral AVM. This was found secondary to a concussion, and her life changed after that. Being a young adult, she became disabled. She now has intractable epilepsy, and she's paralyzed on the left side of her body. I was still working in the healthcare setting at that time, but I was lucky enough that I had a financial advisor who I had a very close relationship with, who I called up not to invest money, but to say, what's next for me? He had tried to recruit me professionally for years to come work for him. And this is the moment that, I had to take the leap and go in a different direction, because one of my priorities in my life was to care for my children financially, but then that transition to being an at-home caregiver as well, part-time. So that's why I'm here, because the moral of my story and the moral of my introduction is life happens and you never know when that's going to happen. So I kind of have a perspective from both sides. And fortunately, I'm able in my new role, to continue to still help people. And my heart is with healthcare professionals. So I feel very blessed to give this presentation to you all today. Next slide. So I want you to remember that you are your greatest asset. And when I say that, as a financial advisor and my clients come in, we talk a lot about net worth, what you have versus your debts. But you are your greatest asset. Your income is the foundation of your financial strategy in your life. It's the foundation to your family. So keep that in the forefront of your mind, because it's very important that you protect that. Next slide. So imagine this. Imagine that you're participating in your favorite extracurricular activity, and you're injured, or even that you become ill, like one of your patients, and you have to encounter an injury or an illness that lasts for weeks or even years, and you can't work. So what are you going to do? How are you going to cover that? As part of a financial advisor's role, the first thing I talk about to someone before we do any investments is setting aside 6 months of income for emergencies at bare minimum. There's other ways to look at that in terms of if you encounter a short-term disability, because truly, the risk of experiencing a disability may seem unlikely to you. However, statistics show that 1 in 4 working individuals will actually become disabled in one manner or another before they retire. So even though you may feel that it's highly unlikely, don't rule that out. And it's very important to you and your practice that you have a strategy that enables you to still reach your financial goals and take care of everyone involved. A couple of the key points in terms of if you're, who's likely to incur a disability, and where protecting is truly, a goal that you have to have in place. Think about occupations. Although more labor-intense occupations have a chance of incurring a workplace disability, it's very important that professionals such as lawyers, doctors, dentists, executives, they have something in place, because those are higher earners, and you want to make sure that your income is protected for whatever goals and your family has in mind. Age plays a huge factor. You see the older that your patients get, the more likely they are to become ill or incur an injury. Gender, women are more likely to experience a disability. And when I say this, pregnancy is also deemed as a disability, a short-term disability, because it's pretty traumatic to the body, and it takes time for you to heal after you bear a child. And then lifestyle, of course, just as other diseases, those who smoke, or even we talked about extracurricular activities earlier. If you encounter or engage in those types of things, high risk behaviors, then you're more likely to become disabled. Next slide, please. So we categorize disabilities into two categories: short-term disabilities, kind of just like acute illnesses, except a short-term disability is deemed a disability that lasts fewer than 6 months. This can include like pregnancy and birth, short stints of illnesses, maybe breaking a bone in an accident, things of that nature. When we think of this is as a financial advisor, this is where I really highly strategize with my clients to have that 6-month savings in place. I also spend time with my clients reviewing their employer benefits because this is something that's often overlooked. A lot of employers like IDNs, they do give you group short-term disability. That may be staged out in terms of payment. Maybe every policy is a little bit different, but you may actually accrue 100% of your earnings for like the first 12 to 14 weeks of that short-term disability. And then the policy may say that drops down to 50% of your earnings, from weeks 14 to 24 or 26. So that's something that you really have to pay attention to. Open enrollment is upon us if you are employed by a healthcare organization. So pay really close attention to that. You can also purchase individualized plans. These plans are very expensive because the likelihood of someone incurring a short-term disability versus a long-term disability, there's a total difference there. So if you're shopping for a short-term disability plan, first of all, and those you deem as too expensive, then definitely don't rule out a long-term disability plan because we're going to talk about that shortly. But the reason we recommend that you have a plan in place for short-term disability is, the obvious. Again, this is an acute occurrence. You really weren't expecting it, most likely, unless it's a pregnancy. And we want to plan for having 100% of your income replacement in place. And that's going to be after tax dollars. And then should this disability, continue to last. Next slide, please. Unfortunately, when a disability lasts longer than 6 months, which is less common, it has a bigger financial impact on you, your practice, your family. In terms of protection, this really is often limited by insurance because at this point, you're really digging into your assets that you didn't put aside for emergency purposes. So as with short-term disability, we recommend that you try to replace as much of your income as possible so that you're meeting your income and your savings needs. Again, I discussed how expensive short-term disability is. Long-term disability, you're going to see a reduction in that price because the likelihood of someone incurring a long-term disability is less. Typically, this is 1 to 3% of your gross annual income if you pick up an individual policy. And again, if you're employed by a healthcare organization, usually these employers offer long-term disability plans as well. The payout is less. It may be 50, 40, 30% of your income. So pay close attention to that as well. And even if you have a group disability plan through your employer, it's really important. Again, you're wanting to replace 100% of your income. So you will want to seek out an individualized plan. I will give you an example right now. I have a friend who's a dentist who just, I saw him last week, not as a client, but as a friend, and he just went through his 6th back surgery. He's in his 50s, and we came up on this discussion, and he said, had I not taken out, he owns his own practice. He said, if I had not taken out multiple, not just one, but multiple long-term disability plans, then my family would have never survived. 6 surgeries. Think about that. Spinal surgeries. He said, my career would have never survived, although he's hanging up his career now. He's in the midst of selling his practice. His career would have never survived. He would have never been able to educate his 2 children. And his wife, who's also a dentist who had to retire early due to multiple sclerosis, their family would have been devastated. But he was smart enough to prepare for his future and take out multiple long-term individual plans. So in terms of plans, what do you need to look for? Again, we talked about employer plans, and again, there's individual plans out there as well. These can be tailored to fit your needs. Back to the employer plan, it's also important to realize if you leave that employer and let's say you move to a different IDN across town or you move states, what happens to that employer plan that you have in place? Most likely it goes. So you don't get to take that plan with you. So it's pretty crucial that you do your homework and prepare on an individual basis as well, and not rely so much on your employer. I'm going to hone in a little bit. In the U.S., we have some government protection, the Social Security Administration. I want to talk about this just slightly because you encounter patients that you are on disability. I want you to know that when an individual files a claim with Social Security, a disability claim, it takes an average of 270 days for that individual to receive a response about their disability claim. That is after they can't even file that claim until after they go past the short-term phase. So 270 days after that claim is filed, they get a response. 65% of those claims are denied the first go around. A lot of these patients, and at this point, if you have an injury or an illness, you became a patient, they have to file appeals over and over again. It is often years before the government actually kicks in and approves claims. They have to hire attorneys. They have to go through a really long, grueling process. So keep that in mind for yourself, as well as what your patients have encountered. Next slide, please. These are just a few caveats from some in terms of what to think about when you are choosing an individualized plan. Again, I'm not going to go through these caveats. Just know that plans can be individualized based on your individual needs. It's really important that you sit down with a professional that has a lot of experience in income protection and go through this. Everyone's needs are a little bit different. So it's really crucial that they understand your profession, what you need to protect in terms of income, what your family dynamic looks like. Really be transparent with the professional that you sit down with. Next slide. So I want to talk a little bit as well to you as a business owner, if you happen to be in that perspective. So if you own your own practice, there's also plans that protect not just yourself and your loss of income, but that can protect your business. So if you yourself have an injury or an illness where you're out of work for a certain amount of time, you want to make sure, obviously, if you plan on coming back to your practice, that your overhead expenses, such as your mortgage, your equipment leases, your maintenance to your practice, your facility, are all covered, your utilities, etc. And then also, sometimes your employees, they obviously need to be paid if you anticipate coming back sooner than later, and you would like to maintain those employees. A consideration would also be to take out or to provide the benefit of long-term disability insurance to your employees. Because if you lose a key person, say you have a nurse that you've worked with for years, you want to make sure that you're providing her or him with the income they need as well, should they face a disability. There's also disability plans in place for your business that should you not be able to return to your practice, that provides a provision for a buyout. Should your disability be long-term and you need to sell out your share of the business or the business at whole. So again, These plans can be very customized. So just make sure you're thinking ahead. And when you sit down with a professional, you don't leave any stone unturned. Next. So in summary, it's very important that you consider, the impact that a personal disability could have on your financial goals for your practice, for you and your family. And as I said, there's ways to cover yourself, whether it be saving for a certain amount of potential time off, or to make sure that you have plans in place in terms of insurance coverage. And I can't enhance, more than just, again, be very transparent when you meet with a professional about what you need, so that strategy can be personalized to protect you and your family. Next. And in terms of you and your practice, don't fall into the practicing common misconceptions. It won't happen to me because I'm very active and I plan to stay healthy. I have a physician colleague that is a snow skier. He fell and hit his head in a snow skiing accident and suffered, a bleed. Didn't even realize he had this bleed for weeks when he actually took a prophylactic aspirin to jump on an international flight. And at that point, his brain bleed presented itself, unfortunately. So don't ever think that it can't happen to you. And don't ever think that I already have coverage through my employer and or the government, because it's never going to be enough. So keep those things in mind. And seriously, sit down with a professional and plan for your future. Because again, your income is the foundation of your financial strategy for yourself and your family and your employees. Thank you for having me. Are there any questions that I can answer today?
Tracy, I've got a quick question.
Yes.
So as we're all med students here, I just wanted to ask, is there anything we should be looking out for in particular when we're transitioning from residents to being attendings?
First and foremost, in terms of, that's a transition in your life where, you don't know what your income is going to look like. So if you're going to go with employment with the healthcare system, seriously pay close attention when it's open enrollment to what the hospital system is offering you. And the other thing is, the sooner the better, because the older you get, the underwriters get to choose whether or not they cover you in an individualized plan. So although you think you're not susceptible to a disability early in life, again, accidents happen. I shared with my daughter, she's in her early 20s. We never thought we would, encounter that. But on the professional level, the sooner you become insured in an individualized plan, the better. The other thing that does for you as well is, guarantees coverage. So yeah, that's the big caveat from that one.
Thank you.
Mm-hmm. Any questions from the medical students that you have? I know this is a totally different subject that you probably haven't thought about at this point in your career.
Hey, Tracy, can you hear me?
Yes.
Yeah, I've always thought that it's important for the medical students to start thinking about disability concerns as they approach their internship or residency commencement, because you really don't know. When you become a resident, you can get hurt, or you become a attending physician, you can get hurt. So, and build up on that disability based on the income that they get as they go up the ladder. So again, this is the impetus for making sure you talk to us. So at least it's something that registers in their radar. Again, the next question would be for physicians who practice in more challenging places, how would you advise they get about better financial planning?
I mean, the big thing is, income replacement. The more successful you become, the more, years you're tenured, obviously, in most instances, your income increases. That's why, like, the dentist took out additional disability plans, was as he grew his practice, he realized that, okay, I need more coverage should something happen to me. And he was absolutely right. So put a base plan in place early in your career, and as your career accelerates, then revisit that plan. And that's totally something I do with my clients. I mean, I revisit their income and their family needs every year. I meet with my clients at least once. We sit down and put together a big financial plan, and I seek to understand where they're at in their career and their earnings. And part of the plan isn't just stocks, retirement plans of that nature. It is truly income protection. So make sure, that you're including that in your financial plan.
Thank you. Thanks a lot.
Mm-hmm. Again, thank you all for having me.
Thank you.
Oh.
Thank you. We'll be taking a short 5-minute break, and we'll reconvene in about 5 minutes.
Okay, thank you.
Yeah, right.
All right, everyone, welcome back. So our next speaker is Dr. Gwen. Dr. Gwen is a board-certified plastic and reconstructive surgeon with extensive experience in advanced wound management and reconstructive techniques. Dr. Gwen's practice focuses on complex wound care, reconstructive surgery, and aesthetic procedures, combining surgical expertise with a patient-centered approach to healing and restoration. Today, he'll be presenting on wound care and plastic surgery, exploring the latest strategies, technologies, and multidisciplinary approaches to optimize healing and functional recovery. Please welcome Dr. Vinny Gwen. Dr. Gwen, you can share your slides. Dr. Gwen, you're muted, so we can't hear you.
Mute, okay.
Yeah, we can hear you now.
All right, thank you for joining me. Dr. Oye asked me to share my experience with wound care in my, I guess I can call it short career compared to his. All right. So have no disclosure. All right. So my title, my lecture as a wound care basics is advanced. So in this lecture, I just go over a little bit of wound physiology. We begin with possibly non-surgical, and then certain wound will require surgery to get to heal. So surgical, some wound care product that's out there, and then my wound care regimen that I have been used for about 5 years or so. So just begin with the patient that this is in 2019. I had this patient who has been at multiple wound care clinic, and it doesn't go. The wound doesn't make any progress. So they referred to me at the one of the center that affiliated with the hospital that I was working for then. So he's about 50 years old, morbidly obese, with only like diabetes and high blood pressure. Otherwise, he's healthy. He had this wound. You can see all this ulceration. And if you stick a hemostat or a pickup in there, you will pull out a piece of calcified tissue. And due to the morbid obesity, this is most probably the cause is venous stasis, and then it develop into infection, and then develop into some sort of calcified tissue. And this is what his X-ray looked like. So when I see a wound, a lot of process going to like I say, what's the cause of this wound? So most of the time is infection. So the wound is overwhelmingly colonized with bacteria. The body's probably spend more energy try to fight a local infection than try to get it to heal. The other thing is, some sort of cancer, whether it's skin cancer or whether it's from metastatic cancer. Another thing to think about is foreign body. So the patient have some sort of procedure, like orthopedic procedure, and they have like a non-absorbable procedure, and it's braided. So it can cause bacteria to colonize and develop biofilm, and that lead to like an open wound. And until you remove that foreign body material, it will not heal. The other thing is vascular disease, peripheral vascular occlusive disease. No blood flow to the area, definitely not going to heal, or venous stasis or lymphedema. The other thing is trauma. The patient have burn or repeated trauma, such as pressure ulcer. And those things, if not fixed, it will not heal. Medication, metabolic diseases, and nutrient, those will help delay wound healing, but not necessarily causing an open wound. So you have to look at the overall picture. So we have also have an osteopathic principle that's been taught to us from day one. We're looking at the whole person. And we know that the body have all the necessary tools to heal itself, but sometimes the infection or whatever the reason is overwhelmed, is tipped the balance. So the body cannot heal itself. We have to bring the balance back for the body to heal. And then of course, the rural artery is supreme, because if there's no blood flow to the area, it doesn't heal. So vascular surgery, bring blood flow back. But in plastic surgery, our flap depending on the blood supply, the pedicle that provide blood flow to the flap to keep it alive. So just go over briefly about wound physiology. So there are phases of wound healing. You can go a little bit over each one of them. There are 4 phases that work simultaneously, not just like one finished and the other start. So it's like a construction site. There's always something going on. So first, if you injure yourself, of course, you have to stop the bleeding. So by doing that, the blood vessel constrict, and then the platelet aggregate that trigger the clotting cascade, and then the release of the growth hormone and cytokines that will attract more cell to the area, which lead to inflammatory phase. In surgery, so this acute wound, after surgery, peak around 3 days, but this phase can stay indefinitely in a chronic wound. And then from there, I go to the proliferative phase, this is when the wound is start to build and to heal. This is when the basal cell proliferate and the epithelial migrate across the fibrin network, bridgework. In the secondary intention wound healing, this phase, depending on the length, the width, and the depth of the wound, And I will show you in the later photo of all this phase what's going on. Fibroplasia is when the fibroblasts lay down the collagen network, and the collagen will, the fibrin, and it will stimulate the blood's, what's it? Blood vessel grow, and that called granulation tissue. The fibroblasts also produce a contractile protein called myofibroblast that will help, the contraction will help reduce the wound size. And then the remodeling phase, this is when the collagen cross-linking is converted from type 3 to type 1 collagen. And again, in surgical wound, in 6 weeks, the strength is about 80% of the original. And then it continued to change for up to a year or longer. But by 6 months, things return to almost normal. And then the strength of the scar will never be the same as the original. So we go back to this patient. So I took the patient to the OR. I cannot cut through that tissue with a scalpel, nor with a Mayo scissor or any type of scissor. So the only thing that can help me cut through the calcified tissue is the rib cutter. And I use this to dissect bluntly and cutting through this thick layer of calcified tissue. So this is immediately after surgery. This is what the wound looked like. So I used a wound vac to help with control the drainage, as well as help stimulate granulation tissue grow. So I don't apply the sponge directly into this wound. That will, number one, may cause bleeding if the sponge stuck onto the any blood vessel that is there. So I put a thin layer of, at the time, a thin layer of silver impregnated seed. It's called Acticoat, and the silver supposedly help control the bacterial growth. So I see him in the off. I see him every week for the wound vac change, but this is 2 weeks later. You can see all the black area. That's not dead tissue. That's the silver. That's all transferred to the wound. Again, as I mentioned, the silver should help control the bacterial growth, but it really doesn't. This wound have a foul smell, so it's localized infection, but the patient is not septic. And then the wound vac help with all the drainage. And in the office, during dressing change, I apply vinegar soaked gauze to help decrease some of the bacterial load to the wound, and it helped with the odor can be tolerable. This is a closer look. And this is about a month later. As you can see, the wound is much cleaner. This is the day I took him to the OR to apply a extracellular collagen network. All right. The reason is he said, he still have some pain on the back of the calf every time I change the dressing. So apply that layer just to help cover the nerve that's exposed. So I applied the thing called, the material called integral bilayer. And then this is a closer look of the wound. This is about 2 weeks later. As you can see, the extracellular matrix is the yellowish layer on top. That is not a pure material. That is like a fibrin that I apply on, and slowly infiltrate with new vascular, new blood supply, blood vessel. And again, I continue to change the dressing every week. And as you can see, now all that extracellular matrix is infiltrated with a new blood vessel. So good granulation tissue that can support a split thickness skin graft. So on this day, I take him to the OR for a split thickness skin graft. And this is about a few weeks later. As you can see, the skin graft is well taken, but it still continues on filling up all those gaps within the skin graft mesh. And that's the donor site. And this is about 4 months later. You can see the different on the left is the original, and on the right is the skin graft. It's pretty much healed. There's some area that's still open, but it will eventually completely heal. And apparently the patient doing well. So that's surgery. So this patient requires surgery. There's no way this won't heal with just local wound care. So just recently this year, I had this patient who came to the ER. He played with a chainsaw to cut some ice, and somehow it slipped, and it cut his on the back of his leg. So I close, bring the skin back, and I close it in the ER. Initially, it looked good, but looking back, I could have debulked the subcutaneous tissue and maybe proceed with what's called a full thickness skin graft. Just use the skin rather than everything. But I'm giving a try. Some of the connections still there, so there may be still some good blood supply that can support this avulsed tissue. This is about 2 weeks later. Just thinking about whether this skin and the subcutaneous tissue is like may or may not live. There's some epidermal lysis on top there, right? Then this skin probably completely non-viable, but I don't. So most people think I should take the patient back, taking patient to the OR for debridement, but based on experience, you don't have to. This can act as a biological dressing, and the body amazingly have the ability to auto debride this wound and heal from the underneath and the surrounding. And my wound, I prescribe my wound care regimen, and hopefully he follows it. But you don't know that. But I see him about from February to May. That's how his wound look, and it's look clean. It's healing. It's small. It's smaller, and you can see underneath that there's the yellow fibrin tissue that the body built, and epithelium will migrate that fibrin network to heal this wound. And I would say, give it another month or so, this wound will completely heal. So you don't need to do any surgery to get this wound to heal. So what to do when you see a wound? Well, first, I take a history and do physical exam. That's the basic with everything. And then if it's a chronic wound, I proceed to do either a punch biopsy on a big wound or a small wound. I probably do an excision or biopsy and close it. Okay. For local wound care, if it's a venous stasis, lymphedema or acute trauma, I usually that will lead to edema. So I usually do a compression dressing to help reduce that, so the wound will heal better. If you don't do it, make the wound worse. If the wound is dry, we'll apply dressing to keep it moist. If the wound is wet, draining a lot, I will do a dressing to help keep the wound moist, not dry. And then, of course, certain wound will require surgery to get it closed, or create an acute wound so that the wound can heal. So this patient with lymphedema, so this patient, there's no way I can get this to heal except for compression, compression, and the patient will require probably long-term compression. Maybe she need for the rest of her life. So I like to use Zeroform to help keep the area moist, and also any drainage prevent from going back in to cause the wound to be wet. And then the compression. So wound care dressing, there are a lot out there, too many actually. So Zeroform, Vaseline, Adaptic, Naked Pressure, Medihoney, and those are the thing that I use the most. The dressing that I use the most, Zeroform, Vaseline, Adaptic, and sometimes Naked Pressure wound therapy. The rest really doesn't, I don't think it's making any difference, except for increasing the cost. Irrigation that I use is acetic acid, 2 to 5%. That's vinegar that you can buy at the store. And in the hospital, they don't have acetic acid, so I use Dakin solution, the lowest strength possible. And that's around a quarter strength. And I even dilute that in half. A biologic product, cell-based therapy. Nowadays, if you have a big wound and requires skin graft, and there's not enough graft on your body to harvest, so they send a piece of skin to a lab to separate into individual skin cell, send it back, and then they will spray on to the wound and help skin grow. Collagen-based matrix, like integral bilayer, that was I used on the patient that I presented, is a collagen, bovine collagen, and glycoaminoglycan. It's a collagen scaffold, and it's put on a silicone layer. The silicone layer will help prevent moisture loss. Amniotic and placental tissue, dermal matrix, like human cadaver skin, like Aladham. Animal tissue, now like pork, bovine, and now even fish skin. And then that thing now called adipose tissue graft. It's a cadaver fat, and they remove all these cells. But these are just a matrix. There's no live cell in it except for your own skin cell culture. So it's expensive, and I don't think it does anything except if you put this in an infected wound, it just provide food for the bacteria to eat. So I don't use most of this stuff anymore. But in the past, I have used them. I do use the integral bilayer because it's been out there for a long time, and in the right situation, it does work. So wound care regimen, what do I do? So this is my everyday wound care regimen I prescribe to all my patients. If the patient have a wound, I allow them to take a shower and wash the wound with soap and water. I don't know about third world country. I don't know how clean the water is, but here in the U.S., it's pretty decently clean. So everyone shower, soap and water. That's good for the wound. And then I asked them to soak a gauze or Curlex with vinegar and put it over the wound for about 10 minutes. The reason I keep it on for 10 minutes because you allow that vinegar to soak into your wound. You just spray on or wash it, just run off, and it doesn't pick any deeper bacterial colonization of the biofilm. Then the patient can change the dressing every day or every other day, depending how the wound look. If it's cleaner wound, I'm allowing them to change it every other day. But it's in a dirtier wound, use it every day. And my dressing is zero form. It's just a Vaseline gauze with some medication to help prevent bacterial growth. If they run out of that, they can use Vaseline, and it's keep the wound moist, but also prevent, again, the moisture from going back into the wound to cause maceration. Curlex to hold thing in place, ABD or some sort of absorbent to help absorb the fluid. And the ACE band is to help compress any edema.
Okay, I find it so. Okay, go ahead.
Okay. So final thing is I don't use Central anymore, or even prescribe. If I see anyone prescribe in the hospital, I automatically discontinue. Central is a collagenase that break down collagen tissue. So why would you do that? It doesn't discriminate whether it's good or bad collagen. It just does its job and make the wound worse. So don't ever use or prescribe Santo. Antibiotic ointments, a lot of is out in the over-the-counter pharmacy. So I don't use it because the antibiotic can cause a reaction, and that can make the wound worse. So I've seen it with my patient. So I don't use antibiotic ointment, just plain Vaseline works just as well. And again, not every wound need debridement. Open drain wound usually rarely causing the patient to become sepsis. Only occluded wound or non-draining wound. Open wound with foul odor doesn't necessarily need antibiotic. Okay, so and that's all I have. Any question for me?
Dr. Nguyen, I have some questions for you.
Yes, sir.
Number one, there's a general consensus, rightly or wrongly, for patients, some patients. Some doctors or healthcare professionals would say take a shower, others say don't take a shower. My preference is take a shower, of course. What's your preference?
My patient, any open wound, I want them to take a shower. I want them to wash the wound with soap and water. I took the in-service exam last year for get CME with the American Plastic Surgery. One of the question is, what do you do with the wound? Everyone, it's okay to wash the wound with soap and water, and it's in there. It's in the literature, and I haven't done this since I start my practice. Been now in practice, so every wound, soap and water is the best thing. The soap will remove the biofilm, will be deloading the bacteria, so make the wound better.
Absolutely, I agree. Soap and water is the best treatment for any open wound. The question is, you may tell the patient soap and water, and the nurses will tell the patient, don't take a shower. So there's a disconnect between what you may want and what the nurses or the healthcare attendant may tell the patient. So that's an important point. The second thing I would ask, in your presentation,
last slide pretty much, you mentioned no Santo. That will make the drug company very, very sad because number one, it's a very expensive medication. I agree. I'm not a big fan of Santo myself, but obviously, what's your rationale for saying no Santo?
Because as I show you, the wound, my rationale is Santo is a collagenate. The body spend time in a proliferative phase to build the fibrin network, bridge work, allow for the epithelium to migrate to heal the wound. Santo again doesn't discriminate whether it's good or bad collagen. It just degrade the collagen, and it's just like a you build and then you break down. Apply a product that break down the collagen, the fibrin. So why would you do that? You don't know. Yeah, it's just like fighting a battle. So my rationale is, why would you apply something that degrade the stuff that the body built to heal itself?
Now, one final question maybe. Your the first patient, was that a case of severe calciphylaxis that you excised the massive circumferential excision? The X-ray showed some suggestion of arterial calcification, obviously. So when you took that specimen out, was it hard like brick, or what is it? Was it soft? What exactly was it? And would you have considered the use of wound vac and vasojet debridement at the initial surgery after you took the mass out?
Yes, I use what was the first question? What do I use to cut it out with?
No, you cut it out quite well. I don't have a problem with that. I just wanted to find out if it was a case of calciphylaxis. Obviously you see calciphylaxis in diabetics, in patients with renal failure. Was this patient demonstrating a case of severe calciphylaxis where the tissue was so hardened and inflamed that you needed to take it off circumferentially? And number two, could you have used the vasojet after you took it out to smoothen the skin out? And number three, did you use a wound vac, or could you have used wound vac as part of your treatment regimen?
Yes, I did. This patient has what's called dystrophic calcinosis cutis. It's caused by, from what I read, it's caused by a local infection, and some patients develop it, some patients do not. After the tissue is removed, yes, I used the wound vac to help because it helped control that wound can drain a lot, and the wound vac will direct all the drain into a canister, make it easier for management of the wound.
Very good. Any other questions for Dr. Wen?
Yeah, I have questions for Dr. Wing.
Okay, go ahead.
Good afternoon, sir.
Go ahead.
Thank you, Dr. Wing, for your presentation. I can see that you have preferences for Vaseline, simple things, which I'm practicing in a poor resource country. Simple things really are the things we look for here. Around here, we use acetic acid, but interestingly, I have found that a lot of patients find it very irritating and painful when you apply a primary acetic acid dressing. So what I've left that for now is whenever there is Pseudomonas infection for the wound, that's when I bring it in. But it looks like you use it for most wounds, regardless of Pseudomonas infection. How tolerable is it for your patients? Most of my patients, they are very uncomfortable with it.
Right. So first of all, acetic acid, I know there's not a lot of study out there, But just I think recently in 2015, there's a publication in the like the country Indian Journal of Surgery. They did some study with acetic acid, and it worked for pretty much all sort of bacteria, not just Pseudomonas, and even with fungi, like yeast infection. That's my personal experience as well. Is
Okay.
dermatitis from moisture. I apply that on one of my patient with it, and it go away pretty fast. So yeah, it worked for all kind of bacteria, not
Okay.
just the Pseudomonas. I don't know what percentage that you apply. You know, when me in my practice, I apply the maximum, either 4 or 5%, whatever is available at the grocery store. But if the patient cannot tolerate it, I usually dilute it in half to about 2 to 2.5%, and sometimes the patient can tolerate that better until enough granulation tissue develop to help protect that nerve, the sensory nerve on the skin or the subcutaneous tissue. So you can dilute it to about.
Okay. Okay. I know that. I didn't hear you mention you saw. We use you saw here a lot, especially for wounds that have slot. What is the option there?
What is it?
You saw.
I've seen all kind of wound. In my current practice, I have a lot of chronic wound from the nursing home, uh, but yes, I mean pretty much a different type of wound. And in my experience, some patients have, for example, when I was in Maine, the patient have a skin cancer excision on the scalp. It's a large wound. The ENT guy closed it, but it's dehisced, and the patient had a chronic granulation tissue in that wound for a couple years before I came just to do locum work there. And I asked the patient, I asked them about the history, what have they been using and stuff. And then I said, I try my regimen first, and I usually give about 4 weeks before they come back to see me. And if it doesn't heal and stuff, and I can do skin graft. But when the patient came back for skin graft, that wound already healed, just a small opening left. So I don't do a skin graft. So I use vinegar regimen on that wound. And then here in my practice, there's another one with the elbow wound. It's about a 1 centimeter wound that's been there for years. And then I said, all right, go home, try my regimen. Not go home, but the patient is at the nursing home. They try my regimen, and lo and behold, it healed. And even the local doctor here was like surprised as well. So I think it does. There's a study that during this lecture I do literature search, and there's a study come out with, I think, Denmark in 2017. They thought that the pH will help with decrease the bacteria and wound healing, but the pH doesn't. Not the only thing that kill the bacteria, because they did acetic acid and hydrochloric acid pH, and that doesn't kill a certain bacteria, but the acetic acid does. And but every wound, the drainage pH is around 8 or 9. So I think the acetic acid, the acidity will help balance out that basic environment of the wound, and it help heal the wound. I think the acid will help release some of the oxygen into the wound. Yeah, I mean, I don't do the in vitro stuff, and but that's what I read, and it seemed to help. So.
All right, thank you so much. And then
Thank you, sir.
Dr. Ware, we have to move on to our next speaker. Thank you so much for calling from Lewisburg, West Virginia. We thank you for giving us a comprehensive recap. With your information here, we'll probably link to different practices. I appreciate it so much. Go.
Thank you.
All right, thank you.
So our next speakers will be Dr. Michelle Oye and Jared Yates. Jared is a third-year medical student with Avalon University School of Medicine, and Dr. Michelle Oye is a dedicated hospitalist based in Beckley, West Virginia. Dr. Oye has built a strong reputation for a compassionate approach to patient care and her commitment to advancing evidence-based medicine in the inpatient setting. As a hospitalist, she manages a wide range of complex medical conditions with special interest in cardiovascular, health, chronic disease management, and preventative care. Today, Dr. Oye will be presenting on peripheral artery disease and its medical management. Her talk will cover the pathophysiology of peripheral artery disease, the importance of early diagnosis, and the latest evidence-based medical strategies to reduce morbidity, improve limb outcomes, and enhance quality of life. Please join me in welcoming Dr. Michelle Oye.
Thank you, Ibrahim. Let me just put my camera on if I can. 1 second. Ibrahim, how do I put my camera on here? Sorry, I'm technically challenged. Can you see me now, Ibrahim?
No, not yet.
Let me see, I don't know what happened.
We can hear you here.
What is it?
We can hear you.
Okay, hold on, I think I got it now.
Yeah, we can see you now.
All right, hi, yes, my name is Dr. Michelle Oye. I'm a hospitalist here in Beckley, West Virginia at Raleigh General Hospital, where I have the honor of working along my father, Dr. Herbert Oye, on almost a daily basis, where a lot of the times I do handle the medical management on his post-operative patients. So the prevalence and relevance of peripheral arterial disease is a very hot topic here in Beckley, especially with our patient population. And today I will be presenting with Jared Yates. He's a third-year medical student completing his clerkship in internship this month. He's going to start off by talking about the evaluation, diagnosis of peripheral vascular disease, and I will talk about medical management. And just a heads up, Jared has 2 questions throughout this PowerPoint for our audience today. So if we can get some participation, that would be great. So, Jared.
Thank you, Dr. Oye. Thank you, Dr. Oye, very much. Okay, so first off, we're going to be thinking about just a basic definition of peripheral artery disease. So this is essentially atherosclerosis in the peripheral arteries, as it's stated. It can also occur in the upper limbs, although the upper limbs often will have more vascular supply of different collateral arteries. And so this doesn't usually present with as many complications and symptoms as the lower limbs. In the lower limbs, we're thinking about atherosclerosis of the iliac, femoral, popliteal, and tibial veins, tibial arteries, which could be diseased and result in symptoms in peripheral artery disease. You can see that here. So the risk factors for peripheral artery disease or any sort of risk factors for atherosclerosis. So smoking, diabetes, hypertension, hyperlipidemia, older age, particularly over 65 or even over 40, any sort of family history. The biggest risk factors are diabetes and smoking. And so those are the lifestyle interventions that you want to go for first. Peripheral artery disease and all these risk factors will increase the risk of MI, stroke, and any sort of cardiovascular death. So the epidemiology of peripheral artery disease is the diagnosis usually increases after age 40, particularly after age 50. And it occurs later in women than men, particularly after menopause, but it's more common in women than in men. This is due to longer. Also, it's a coronary artery disease risk equivalent. Essentially, that means the risk of having an MI or a major coronary event leading to death is equivalent to coronary artery disease itself. The actual number of risk is about a 20% risk of coronary artery death or MI over the next 10 years from diagnosis. This was defined by the National Cholesterol Education Program, particularly the Adult Treatment Panel 3 in 2001. Coronary artery disease affects 8 to 12 million people in the United States, and about 1 in every 20 Americans over the age of 50 has peripheral artery disease. So that's about 5% of the population, which means it's very common and significant disease to be treated. So it needs screened. So the screening guidelines from the American Heart Association and the American College of Cardiology are the same. Anybody over the age of 65, or if they're less than 65 with risk factors like we talked about before. However, the primary care guidelines with the USPSTF say that there's insufficient evidence in screening asymptomatic adults. So you kind of take both guidelines and use it for clinical practice. So oftentimes this can present it can be asymptomatic, but there are symptoms, particularly intermittent claudication is the primary symptom that a patient could be experiencing. So like a cramp, often this will be relieved with rest after about 5 minutes and is exertional. You can have atypical symptoms, so leg fatigue, poor wound healing, and there can be a more critical and chronic ischemia, and this can present with rest pain. And if there's pain at rest, that means there's ischemia and tissue loss, and this is often a surgical emergency or requires surgical intervention outpatient. In general, there'll be reduced exercise capacity in somebody with peripheral artery disease due to the claudication. So this is what can happen in chronic limb ischemia, and this happens in less than 5% of patients with PAD, and this is a picture of dry gangrene. About 30% of people who have chronic limb ischemia will have an amputation, and about 20% have a 1-year mortality rate without intervention. So it's very needed to have urgent revascularization. So when you're evaluating a patient for peripheral artery disease, you're thinking about a history of walking, rest pain, and the ulcers, and you see the gangrene on the last slide. Particularly on physical exam, there'll be decreased peripheral pulses, so dorsal pedal pulse, posterior tibial pulse. Particularly, it'll be asymmetric, although it can be symmetric. You'll also be thinking about hair loss on the limb, so no hair on the limb that's affected, poor wound healing, cool limb, rubor. Particularly, it's important if you're thinking a patient has peripheral artery disease to educate them about foot protection, particularly wearing shoes, walking outside the home. Particularly, even more so if they have diabetes as well and peripheral neuropathy. So differentiating different types of claudication. So peripheral artery disease claudication is due to decreased blood flow, while you can also have pseudoclaudication, which is caused by stenosis of the spinal canal. So this is going to be more of a neurologic problem. It presents with more tingling and numbness, as well as the cramping and tightness, fatigue, and weakness that you could see with claudication. Particularly with pseudoclaudication, it's going to be relieved with flexion at the waist. It can also be relieved with rest, but usually it will take about 30 minutes to relieve rather than claudication due to peripheral artery disease, which takes about 5 minutes to be relieved. Pseudoclaudication is almost always bilateral, while claudication due to peripheral artery disease can be unilateral. So also furthering our differential here for looking at different types of ulcers. So you can have an arterial or a venous ulcer. The arterial ulcer is pictured here on the top, and the venous ulcer is here on the bottom. So looking at these types of ulcers, an arterial ulcer is more common in the foot, although it can be in the gator zone. Venous ulcer is almost always in the gator zone, and the gator zone is just here on the ankle. So usually an arterial ulcer is going to be deeper. It can have a necrotic eschar, it can have a yellow or gray base, and it's more demarcated in its borders. On physical exam, you're going to be seeing that decreased that increased capillary refill time from decreased blood flow. The pain is worse when the leg is raised if the artery disease is significant, which is in contrast to venous stasis ulcers, which the pain is often increased whenever the leg is dependent or down because the blood is not returning up to the heart through the veins. Often with the venous stasis ulcer, you'll see this hemosiderin deposits around the ulcer. The ulcer will be irregular or shallow with granulation tissue, and the capillary refill time is normal. So that's all making you think, is this peripheral artery disease? But what's the actual diagnosis? So the actual diagnosis is done by the Acute Brachial Index test. So the ABI test, normal test is in between 1 and 1.4, and a diagnostic test for PAD is anything less than 0.90 or 0.90 or less. It's severe peripheral artery disease if it's less than 0.4, and if you have a high ABI test or anything above 1.4, that means it's inconclusive due to non-compressible blood vessels. This is often due to atherosclerosis and calcium deposits in the arteries. So this is taking the ABI. So the ABI is the ratio between ankle blood pressure, which is measured at the dorsal pedal artery or the posterior tibial artery, and the brachial blood pressure, or here at the arm. So you would take the ankle blood pressure divided by the arm blood pressure. That would give you your ratio for the ABI. You can do this with ultrasound. So if you're having an inconclusive test result with the ABI, so above the 1.4, you can get not an ankle brachial index, but a toe brachial index. And it has different parameters, which will, the questions that we have, we'll talk about that. And if you have a normal test result of ABI, but the patient has symptoms or they have an ulcer or something, you can have them exercise and then repeat the ABI, and this will often elicit an abnormal test result for your diagnosis of PAD, so less than 0.90. Ultimately, you can get a CTA or an MRA if the patient has had significant symptoms that's affecting their life. They would need treatment. Particularly, this will allow the surgeon to look at the location that needs stenting. Often there could be an endovascular stent, or if it's very significant, there could be an amputation, etc. That would be up to the surgeon. So here we have a question. This is a diagnostic question. Read it, and then I'll read the answer choices. You guys can just answer on the chat, or if you want to come on, that's fine too. Speak. So a 66-year-old woman is evaluated for a routine follow-up visit. During the past 6 months, she has noted intermittent cramping in the left calf while walking. It usually decreases with rest. She has no other symptoms. 4 years ago, she had a myocardial infarction treated with percutaneous intervention of the left anterior descending artery. She quit smoking at that time. She had past medical history of type 2 diabetes, hypertension, and dyslipidemia. Her medications are aspirin, metformin, semaglutide, ramipril, and atorvastatin. On physical exam, her blood pressure is 126/78, pulse 72, irregular. Her femoral and pedal pulses are diminished bilaterally. Capillary refill time is normal. So the question is, which of the following is the most appropriate next step? Looking at ankle brachial index testing, CT angiography, exercise ankle brachial index testing, or a toe brachial index test. guys respond.
So we've got two different answer choices in the chat box.
Okay.
We've got three. We've got two people who say A and one person who says B.
Okay. All right. Well, I guess majority rules. We'll go to the next slide. Why is it progressing? There it is. Okay. Yeah, so the answer is A, achial brachial index testing. And I'll show you the commentary on that. So the most appropriate next step is achial brachial index testing. The ABI ratio of the lower extremity to the upper extremity is used for the diagnosis of PAD initially. I'll skip that top explanation and go to the why B and C and D are wrong. So CTA is not indicated in this patient as the first test in diagnosing PAD. CTA, along with magnetic resonance angiography, is most commonly used to plan for endovascular and surgical revascularization procedures. So that might be later down the road.
Oh.
They're not first line tests.
I think the next doctor has to go through, like,
Oh,
just say gloss
just
over,
go-
yeah.
going
Over
faster.
gloss, yeah.
Okay.
Yeah.
And so I guess I'll just stop there since the next doctor does need to present rather soon, and we'll continue. So I guess the overall idea is the achial brachial index test is that first next step, and diagnosis is less than 0.9. I'll turn this over to Dr. Michelle Oye. Thank you.
Great, thank you so much, Chair. That was great. So yeah, I will be talking about the medical management of PAD. So the main goal is to decrease the cardiovascular risk, improve function, and prevent amputations. The number one thing that we can do is to tell patients to stop smoking. Like everything in medicine, smoking makes things worse. Two, diabetes control, especially like using SGLT2 inhibitors and GIP1 agonists are very important. Studies have shown intensive glucose control has not been demonstrated to reduce macrovascular complications, including MI, stroke, or amputations. However, guidelines now suggest the use of SGLT2 inhibitors and GLP-1 agonists in patients with type 2 diabetes and peripheral arterial disease, as those decrease the cardiovascular events. But it's very important to realize that we need to monitor our patients closely if they're on SGLT2 inhibitors, because studies have also shown that patients on SGLT2 inhibitors have a reported increase for amputations in patients with peripheral arterial disease. Statins, especially high intensity statins, atorvastatin 40 to 80, rosuvastatin 20 to 40 is a part of the treatment for a PAD with a goal LDL of less than 70 if our patients are under the age of 75. If they're older than 75, then we should use a moderate intensity statin. Blood pressure control is very important as well, just like the general population. We should aim for a blood pressure of 130, less than 130 or over 80 in our patients with PAD. The cornerstone treatment, though, is antiplatelet therapy, specifically monotherapy with either low-dose aspirin or clopidogrel. Studies have shown that these reduce risk for MI, stroke, and peripheral arterial events, including chronic threatening limb ischemia in patients with PAD. There has been no compelling evidence for the use of dual antiplatelet therapy with both aspirin and Plavix in patients with PAD alone. And unless the patients have undergone revascularization, then that could be considered. But just in general, without revascularization, it just increases the risk of bleeding. There has also been no evidence to support the use of oral anticoagulation with warfarin or DOACs over monotherapy with either aspirin or Plavix. However, the combination of aspirin and low-dose Xarelto is an option in patients with PAD if they're at a low bleeding risk. Two trials I just want to hit quickly on are the COMPASS trial and the Voyager trial. The COMPASS trial demonstrated that aspirin 100 milligrams daily plus low-dose Xarelto 2.5 milligrams BID was associated with improved major adverse cardiovascular and limb endpoints compared with aspirin plus placebo in patients with CAD and PAD. And the Voyager trial assigned Xarelto 2.5 milligrams BID with aspirin compared with aspirin alone in patients who underwent endovascular or surgical revascularization for PAD. And that showed significantly lower incidence of primary efficacy outcomes, a composite of acute limb ischemia, major amputation from vascular causes, MI, ischemic stroke, or death from cardiovascular causes. So the overall theme here is monotherapy with either aspirin or Plavix is fine. If your patient undergoes revascularization or they have concomitant CAD, you can consider low dose Xarelto plus baby aspirin. A huge treatment, especially for intermittent claudication, is symptom relief. That being first line treatment is supervised exercise training is the most effective treatment for improving functional status in patients with PAD with intermittent claudication. Supervised exercise includes 3 times a week, 30 to 45-minute sessions, which improves walking distance and quality of life. Salicizol is a medication that we can use for symptom control in PAD that improves walking distance in intermittent claudication. We just have to be mindful that it is contraindicated in patients with heart failure because it's a phosphodiesterase 3 inhibitor and it increases cyclic AMP levels in cardiac myocytes, leading to positive inotropic effects, so increased contractility, which can lead to arrhythmias, tachycardia, and increased sudden cardiac death in patients with heart failure, so keep that in mind. And patoxyphylline used to be one of the treatments for symptomatic relief in PAD with intermittent claudication. However, newer studies have shown that it's not effective and should not be used. Just beyond the medical therapy, a little bit more, I know some of the vascular surgeons probably touched based on this earlier, but revascularization is not recommended in asymptomatic patients. It can be used in patients with life-limiting claudication and inadequate response to exercise and pharmacological therapy, and is obviously indicated in patients with chronic limb-threatening ischemia on a more urgent basis. And just one quick slide on acute limb ischemia. This is a medical emergency. Patients, to be diagnosed with this, they have to present with at least one of the 6 Ps, which includes paresthesias, pain, pallor, pulselessness, popliteal, which is coolness of the extremity, and paralysis. It's most commonly caused by acute thrombosis of the lower extremity artery, usually at the site of a pre-existing atherosclerotic disease or a stent or bypass graft. So from a medical standpoint, if a patient comes into the emergency department and they're found to have one of the 6 Ps, as a hospitalist, I should start them on a stat IV heparin drip, get a stat vascular surgery consult to determine limb salvageability, and diagnostic angiography should be performed immediately to define the anatomic level of occlusion for surgery. And also catheter-directed thrombolysis also improves outcomes in patients with acute limb ischemia. Jared has a question here. He can read it real quick and we'll just, you guys answer, and then we just won't go into much detail and then we'll be done.
Okay, thank you again. Do this quickly. So this is a question on treatment. A 63-year-old woman is evaluated in follow-up visit 2 months after undergoing percutaneous coronary intervention of the right coronary artery for inferior ST segmentation MI. Left ventricular systolic function was normal at the time. During the PCI, severe stenosis of the left iliac artery was noted as shown here. She is currently asymptomatic and participating in cardiac rehabilitation. She is a current smoker and is undergoing cessation counseling. Medications are aspirin, ticagrelor, metoprolol succinate, lisinopril, and atorvastatin. Physical exam, her blood pressure is 122/68, pulse is 69, and regular left femoral brewery is noted. We saw here, it's likely the source of the brewery. The left femoral pulse is 1+, and the right femoral pulse is 2+. On labs, the LDL is 52. So which of the following is the most appropriate management? Get a diagnostic test, ankle brachial index testing, cilostazol, CT angiogram of the abdomen with runoff, iliac artery revascularization, or continued current management. And you can answer in the chat.
Recording in progress.
So the majority says E.
Yes, and the majority is correct. The answer is E. So it's not wanting to progress again. Okay. There it is. Okay. So essentially, this patient is not symptomatic, adequately treated of her other complications. And so cilostazol would be the first symptomatic treatment. And she's not having any sort of life-threatening changes, which would merit CT angiogram or revascularization. So that's essentially what this describes. And that is our presentation. References, I'll turn it over to Dr. Oye.
Yes, that's pretty much all we have. So overview, peripheral arterial disease is important diagnosis not to miss. It's very prevalent here in West Virginia, as we've learned from other talks in Nigeria as well. So it's important to get our patients on the right therapy, whether it's exercise, symptom relief, or revascularization. Yeah, so that's it. So thank you. And if there are any questions, we'll be happy to answer them.
Thank you, Michelle.
Thanks.
Any questions? Medical therapy is important for those people's patients. To make clear about symptoms. If they have a lot of symptoms, then you have to intervene. They have symptoms to treat them medically. Thank you. And no one's voice.
I'm not sure if that was a comment or answer. I can't hear what was said.
I think it was just a comment. Thank you, Dr. Michelle.
Okay, thank you so much.
Could you stop sharing your slides, please? Thank you. I'll pull up the slides for our next speaker. All right. So ladies and gentlemen, it's my pleasure to introduce our next speaker, Dr. Ibrahim, a consultant occupational physician based in the United Kingdom. With extensive experience in school health, workplace health, and extensive health management in Nigeria, Dr. Ibrahim holds multiple postgraduate qualifications in public health, epidemiology, and occupational medicine from leading institutions in Nigeria and the UK, including the London School of Hygiene and Tropical Medicine and the University of Manchester. He's a fellow of both the Faculty of Occupational Medicine and the American College of the Occupational and Environmental Medicine. He currently serves as clinical lead for Health Partners UK at Rolls-Royce and visiting lecturer at the University of Birmingham. Today, Dr. Ibrahim will speak on stroke and work, exploring the burden of stroke, occupational and lifestyle risk factors, and how workplace health professionals can play a vital role in prevention, rehabilitation, and return to work strategies. Please join me in welcoming Dr. Ibrahim.
Okay. Can you hear me all?
Yes, sir, we can hear you.
Okay, great. Thank you very much for giving me the opportunity to speak in this conference. As earlier stated, my name is Dr. Ibrahim. I'm consultant occupational physician, and it gives me a great pleasure to speak on this topic that touches the very core of what we do, protecting the health and productivity of the working population. As you can see, you will all appreciate that a stroke, I've titled it Stroke and Work in Nigeria. Stroke is no longer a disease of the elderly. It's now striking men and women in their most productive years. And the bankers, teachers, drivers, engineers, nurses, doctors, and even politicians who keep our economy running. Occupational health physicians or professionals are at the front line, and they are positioned to detect risks early, intervene swiftly, and support reintegration in the workplace. So let's explore how workplaces can be part of the solution. Next slide. So by the end of the session, we should be able to understand the burden of stroke in Nigeria, recognize occupational and lifestyle risk factors, discuss some of the workplace role in stroke prevention and response, explore rehabilitation and return to work strategies, highlight the pivotal role of occupational health physicians. In essence, we are looking at stroke not just as a clinical condition, but as a workplace and productivity issue, one that requires a holistic, systems-based response. Next slide. Yep. So let's look at this. I am starting with an example, a case example. Let's begin with just a familiar story that we could all come across. Mr. A, 52-year-old banker in Lagos, is hardworking, dedicated, and often the first to arrive and last to leave. His days are long, his workload heavy, and physical activity almost non-existent. He's hypertensive, but often skips his medication because of work is busy. And then one afternoon, he suddenly develops slurred speech and weakness in his right arm. His colleagues think he's just exhausted and needs rest. 2 hours pass before anyone calls for help. By the time he reaches the hospital, the critical window for treatment has closed. Now, from an occupational health perspective, this is a missed opportunity for blood pressure control, stress management, and emergency response. Mr. A's story is unique. It's not unique. It's a reflection of how our work environments can either protect or endanger our health. Next slide. So let's take a look at some little epidemiology and the burden of stroke in Nigeria. And that is looking at the bigger picture. Stroke incidence in Nigeria is about 26 per 100,000 per person years, and prevalence is around 6.7 per 1,000. Mortality ranges from 21 to 45%, and 30-day fatality can reach 40%. What's most concerning is that stroke is increasingly affecting working age adults, people in their 40s, 50s, and 60s. Sub-Saharan Africa's stroke incidence is 3 times the global average. That means more workers are disabled, more families struggling, and more economic productivity lost. Every stroke survivor who cannot return to work represents not just a medical statistic, but a lost contributor to our nation's development. Next slide. I'm not going to teach this fantastic audience what stroke is, because that is your bread and butter, most of you. But I will just, just lay it bare as it is. Stroke occurs when blood flow, to the part of the brain is interrupted, depriving the brain cells of oxygen. This leads to sudden loss of function. And there are two main types: ischemic stroke caused by blockage or clot, which accounts for 70 to 75%. Hemorrhagic stroke caused by bleeding accounts for 25 to 30%. And the key message here is simple but vital. Time is brain. Every minute of delay, nearly 2 million neurons die. So early recognition and rapid response are absolutely critical. Next slide. So what are the risk factors for stroke? And they fall into three broad categories: non-modifiable, which include age, family history, genetics, and these we cannot change. There are modifiable ones like the medical conditions we suffer from: hypertension, diabetes, lifestyle, smoking, alcohol, obesity, sedentary lifestyle. These are the ones we can manage and change ourselves. Then there are workplace-related factors like prolonged sitting, job strain, long hours, high stress, shift work, and poor sleep patterns. And many of you who are medical doctors will fall into this kind of category. In Nigeria, many workplaces still normalize 12-hour work days, skip meals, and minimal exercise. Over time, this culture becomes a breeding ground for chronic disease. And let's not forget psychological factors. We talk about workload pressure, burnout, job insecurity, all of which raise cardiovascular risk. The message, therefore, is clear. The workplace is both a risk zone and a prevention platform. Next slide. So how do we recognize stroke? This is a common thing that is, in the cardiovascular world, it's there. It's not something that I'm inventing. So the acronym FAST is a powerful tool everyone should know in the workplace. And that is face drooping, arm weakness, speech difficulty, time to act. Beyond these, we may also see confusion, vision loss, dizziness, or severe headache. In the workplace, we should train employees to recognize these signs and respond immediately, not to dismiss them as stress or tiredness. Organizations should also establish stroke response protocols and maintain a link with nearby stroke-ready hospitals. That simple preparedness can mean the difference between recovery and permanent disability. Next slide, please. Diagnosis and emergency care in Nigeria. Ideally, stroke diagnosis requires CT or MRI to distinguish between ischemic and hemorrhagic strokes. Early intervention like thrombolysis or thrombectomy can save brain tissue, but only if the patient arrives early. In reality, many Nigerian facilities lack stroke units. Delays in transport, limited imaging availability, and high treatment costs compound the problem. What can employers do? They can play a life-saving role by having a workplace emergency plan, ensuring quick transportation to a stroke-ready hospital, and supporting insurance coverage for staff. The occupational health practitioner's role is to liaise with the hospitals, facilitate referrals, and follow up on recovery and integration. Next slide, please. Next slide. Yep. Statistics, tell a sobering story. Many patients in Nigeria present late, sometimes days after symptom onset. 30-day fatality can be as high as 40%, and strokes account for up to 17% of hospital deaths. Predictors of poor outcome include severe initial symptoms, hemorrhagic type, delayed presentation, uncontrolled comorbidities like hypertension and diabetes. From a workplace perspective, every delay in recognition of referral is a lost opportunity to save both life and function. Next slide, please. So now let's bring, the focus, to the world of work. Stroke primarily affects adults in their productive years, the workforce that sustains families and drives national growth. When stroke strikes, the effects ripple far beyond the individual. There's income loss, increased caregiver burden, and stigma around disability. Yet, most organizations in Nigeria lack formal policies for reintegration or post-stroke accommodation. This gap means that many survivors, even those capable of modified duties, are excluded from employment. It is therefore time to view stroke not only as a health issue, but as an occupational and economic challenge, one where prevention and rehabilitation directly benefit employers too. Next slide. So let's talk about rehabilitation and return to work. Recovery doesn't end at discharge. It's a journey. Early rehabilitation, including physiotherapy, speech, and occupational therapy, help regain function and independence. Cognitive support is equally crucial. Memory, attention, and problem solving often need retraining after stroke. For workplace reintegration, strategies will include gradual re-entry to work, modified duties, flexible hours, ergonomic adjustments. The occupational health practitioners coordinate this process, assessing functional capacity, counseling employers, and redesigning roles where necessary. With the right support, stroke survivors can and do return to productive employment. Next slide. So let's look at prevention through primary, secondary, and tertiary framework. Primary prevention will include promoting health before the illness starts. This includes regular BP checks, wellness programs, stress management, and healthy lifestyle campaigns. Secondary, identifying early disease through medical screenings and prompt referral, while tertiary will be rehabilitation and return to work support for those already affected. Examples abound in Nigeria. So there are wellness programs in banking and oil and gas sectors. There are companies that are doing annual health fairs, BP monitoring clinics, and workplace exercise challenges. The message actually is a proactive workplace with a good health system saves costs and lives. Next slide. We all understand here in Nigeria that there are system challenges. So what should we do? Because there are few stroke units, we need more regional centers. Late presentation while in the office, we need more public and workplace education. Low insurance coverage. The NHSIS needs to expand its reach, limited rehabilitation services. There's need for integrating stroke services into primary care as being the key. There are also issues about cultural beliefs and delays, and these require sustained community education. So it's not just, we're thinking about education, and trying to reach the people who we feel will benefit from this. These are not insurmountable barriers, and with strategic investment and crossover collaboration, I do believe that the country can strengthen its stroke care continuum. Next slide. So what are the roles of occupational physicians? Where does occupational physician fit in all this? Our role is central. We bridge health and productivity. We design and lead workplace health programs along with public health, educate staff on risk reduction, and establish emergency response systems. We support rehabilitation, guide reintegration, and advocate for policies that protect workers' health. Occupational health practitioners are the link between the clinic and the company, the worker and the system. We are not just medical officers, we are advocates of sustainable, healthy workforce. Now, next slide, please. So let's have a reflection on the case that we had in the beginning on Mr. A. So if we return to him, what if his colleagues had recognized the signs of stroke using FAST? What if his organization had a BP control program or an emergency response plan? What if there was a return to work framework for stroke survivors? The story could have been different. He could have received timely care, survived with minimal deficits, and returned to work with support. This reflection reminds us that occupational health systems saves life and preserve productivity. Next slide. So what are the key takeaways? Let's summarize this. Stroke is common, costly, and preventable. Early recognition and action save lives. Workplace prevention and preparedness are vital. Rehabilitation and reintegration are part of true recovery. Occupational health practitioners are crucial in linking health with productivity. And above all, just remember that time is brain and you need to act fast. Next slide. So as I conclude, let us remember that the health of the worker is the wealth of the nation. As the World Health Organization so aptly said, stroke doesn't only destroy neurons, it destroys potential. Our task as health practitioners, including occupational health practitioners, is to create systems that prevent, detect, and respond. Systems that protect workers, saves lives, and preserve productivity. Thank you.
Thank you, Dr. Ibrahim. Do you have any questions in the comments, in the chats?
Yes.
Yeah, we can hear you.
Yep.
Yeah, thank you very much for that inspiring and very thought-provoking presentation. Stroke can be the major problem in the sub-Saharan region, as like you aptly mentioned, particularly in Nigeria, where the causes of stroke is not really ischemic, but mostly hemorrhagic, because we have a lot of problems with uncontrolled high blood pressure, unreasonably high blood pressure. So in identifying the patients, like you mentioned, that the FAST obviously very good, nicely to get started. But prevention is key. If we cannot have patients be treated quickly, let us prevent them. So I guess we should be more creative in ways to control our blood pressure, high blood pressure sample. Taking a look at the Niger Delta region, for example, imagine if we could get people in the workplace, in the marketplace, at churches and mosques, whatever, have the blood pressure checked 3 times a day, just to identify those people at risk, and then send them where they can be closely monitored for a year. I think we might be able to make a difference in that regard. It's hard to get physiotherapists here in Nigeria alone, even in one given area. So again, training more physiotherapists and healthcare occupational therapists is very helpful thing also for the post-stroke care. So again, thank you very much for the very, very insightful talk.
Okay, thank you.
And we should see you next year again and again. It's very talk.
Thanks, man. All right. Have a beautiful conference and keep going.
Thank you. Thanks a lot.
All right then. Okay.
Thank you, Doctor. So our next speaker is Dr. Melissa Oye, a dedicated hematologist and oncologist who provides expert, compassionate care to patients with blood and cancer disorders. Dr. Oye is deeply committed to advancing cancer awareness, early detection, and evidence-based medicine with a special focus on breast cancer care and patient education. Her work combines clinical excellence with a strong advocacy for patient support and multidisciplinary collaboration. Today, she'll be leading a session titled Breast Cancer Talks, where she'll discuss key aspects of breast cancer prevention, diagnosis, and treatment, as well as the importance of ongoing awareness and support. Please join me in welcoming Dr. Melissa Oye.
Hello there. Should I share my slides or do you have them?
You can share them.
Okay. 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 All right, you can see my slides?
Yep.
Yes.
Okay, great. Well, thank you all for having me. I know this is an endovascular talk, but I'll be talking about breast cancer because all of these patients, whether they have peripheral vascular disease, strokes, heart attacks, can get cancer. So you will definitely be seeing patients with cancer in your clinic. So briefly on staging, breast cancer, any type of solid tumor stage from 1 to 4. Stage 1 is going to be an early breast cancer localized to the breast, which is great. We want to find these cancers early. Stage 2 is going to be a more locally advanced breast cancer. There may be some regional lymph node involvement. Stage 3, again, getting a little bit more aggressive in the size of the cancer and some more lymph node involvement. And stage 4 is metastatic cancer that has spread to other sites of the body. Stage 1, we think of curable. Stage 4, we think of as treatable. Breast cancer is the most common cancer in women worldwide. 1 out of 8 women will be diagnosed with breast cancer. So we all know 8 women in our lives, and 1 of them will be diagnosed with breast cancer. It is the second leading cause of death, cancer death, with lung cancer being the first worldwide. And we know early detection saves lives. Thinking a little bit more about Nigeria, breast cancer is the most common cancer among Nigerian women. There was a study in 2020 that showed there was approximately 28,000 new cases of breast cancer in Nigeria, and that's projected to increase as the years go on. There's a high mortality rate. Nigeria has one of the highest mortality rates of breast cancer in women among African countries or sub-Saharan African countries. And the majority of women in Nigeria are presenting at late stages. This is stage 3, stage 4. The peak age of Nigerian women being diagnosed with breast cancer is between 40 and 49, which is very young. The average or the median age of breast cancer diagnosis in the US is about 62 years old. So these women are being diagnosed about 10 to 12 years earlier than in the United States. When we think about risk factors for breast cancer, we have our non-modifiable risk factors. So age being one of them. The older women get, the higher the risk of breast cancer becomes. Being a biological woman, that increases your risk for breast cancer. And then family history. You can't change your genetics. There are some things that are modifiable, like lifestyle. So alcohol increases the risk for 6 different types of cancer, including breast cancer, obesity as well, and physical inactivity. Thinking about Nigeria, we are seeing some rapid urbanization. We're seeing kind of adapting of a Western diet and lifestyle. And as we see those changes, we're seeing increased diagnoses of breast cancer. And there was an interesting population-based study looking at Chinese women who migrated to the US. And what they saw is that over time, their risk of breast cancer increased and became equal to the risk of breast cancer in American women. So we know there's something about adopting this Western lifestyle where we're not having great food, high quality food, fast food, very inactive, high rates of obesity. All of those things combined together increase the risk of breast cancer. And we're starting to see these in a lot of countries. So screening recommendations, this is specific to the US. It is recommended for biannual mammograms. There are a lot of breast cancer societies that don't agree with this and think women should get mammograms every year, starting at age 40 to 74. Women at increased risk of breast cancer will have a little bit of different recommendations. Clinical breast exams, they're not recommended by guidelines, but it is good to know you and who you are and if there is something different, if you feel or palpate something different, so you can make your clinician aware. Some problems that we see in Nigeria is that there's limited access to mammograms. There's low awareness and there's not a national screening program. So if we say early detection saves lives, we have to have the resources and the infrastructure to get these diagnoses early, which means access to mammograms. So first, we start with a mammogram. If there's abnormal findings on the mammogram, there may be an ultrasound, MRI to support additional workup. We need to diagnose it with a core needle biopsy, and that's going to give us information about the type of breast cancer. What is the subtype of breast cancer? What's the aggressiveness of the type of breast cancer and the hormonal status of breast cancer? And it tells us about the Ki-67, which is how quickly those breast cancer cells are dividing. In Nigeria, another problem that we have is that if you get your mammogram, you have your biopsy done, we need a pathologist to be reviewing these reports. So we can say, this is the type of breast cancer you have, this is how active it's moving, and these are some recommendations for treatment. So if we don't have the pathologist, if we don't have the lab resources to make the diagnosis, we're going to be doing a disservice to Nigerian women who are diagnosed with breast cancer. So quickly, for the non-oncologists, this is the main types of breast cancer. Someone says, I've been diagnosed with breast cancer. If you ask a few of these questions, they'll think that you really know what you're talking about. So hormone-positive breast cancer, it's the most common type of breast cancer. This is breast cancer that is fed off women hormones, estrogen and progesterone. If this is caught early, the 5-year overall survival is greater than 90%. Some studies even say greater than 95%. These are very curable breast cancers when detected early. HER2 positive breast cancer, it historically was a pretty aggressive type of breast cancer, but now with newer therapeutic agents, targeted therapy, it's become a breast cancer that we can treat and sometimes even cure. So the 5-year survival is 85 to 90%, again, if caught early. Triple negative breast cancer, this is the most common aggressive type of breast cancer. We see this at higher rates in Nigerian women and Black women. This has a 5-year survival between 65 and 70% with standard chemotherapy. Now, if you don't have access to the treatment that we have here in the US, the survival rates are going to be much lower. The localized disease management, it's really a multidisciplinary discussion between surgical oncology, medical oncology, and radiation oncology. So the first step, if it's localized, is we want to remove the breast cancer. So anything that can be seen in the breast and the axilla needs to be removed. After that, we discuss radiation therapy. So for any localized breast cancer that remains after surgery, that's treated with radiation. And then where medical oncology comes in is with systemic therapy. So we remove the breast cancer, we've done radiation for any local disease disease that was not removed by surgery. And then we know there can always be some breast cancer cells that are still floating around in the bloodstream. Surgery can only remove what you can see, but there can be some micro metastatic disease that you cannot see that's in your bloodstream. And that's where systemic therapy comes in to reduce the risk of a breast cancer coming back. Some challenges that we have in Nigeria. So late presentation, we know that women are coming in much later. And when you come in at a later stage, many times we're not talking about curing the cancer anymore, we're talking about treating the cancer. And there can be many reasons that people are presenting late: fear, stigma, going to traditional healers to try to cure themselves versus going to trained professionals. Limited diagnostic infrastructure and not enough oncologists, right? And then again, we need mammograms, we need MRIs to help diagnose breast cancer. And if we don't have that, if we don't have functional machines, we're not going to get diagnosed early or start treatment in a time-sensitive manner. Cost. Cancer care is expensive everywhere, especially here in the US. Now, if you're talking about other countries where you may have to pay out of pocket, where there's no insurance coverage, this can be something that many people can't get cancer care. Not only is diagnostic testing expensive, but treatment as well is very expensive. And then we have that cultural component that we spoke about in the last presentation that may cause people to delay coming to get care. So these are some really big things that we have to think about when you think about, breast cancer. It's something that many women will try to hide, and you can, right? You can put your clothes on and people can't see it, but if not treated, it can lead to very devastating complications. Some survivorship. This is one thing that I think in the US that we're moving towards, not just curing women from the breast cancer, but also addressing the long-term implications, health implications that our treatments have. You can have cardiovascular disease after some chemotherapy. There's a risk of getting secondary malignancies from some of our chemotherapy. There's long-term side effects, menopausal-like side effects. There's a lot of psychosocial, financial distress. So we are working on improving women's care in like a comprehensive manner. We want you to survive your breast cancer. We want to cure your breast cancer, but we also want you to have a long, fruitful life. And this is something that's not really emphasized in a lot of other countries. So it's something that we're going to have to continue to improve on. So there's a lot of health disparities in breast cancer care in the US and outside of the US. So Black women globally have a 40% higher mortality from breast cancer compared to white women. In Nigeria, again, we talked about some of these structural inequities, delayed access to care, which is going to be impacting women's overall survival from breast cancer, and some of those cultural components that may lead people to delay seeking care. So moving forward, especially in other countries like Nigeria, we have to have better early detection and awareness. Early detection saves lives, it saves limbs, it saves hearts, it saves brain. And this is going to be the best way that we can give women, especially in Nigeria, a better chance for curing their breast cancer is we need to detect it early. But that requires a lot of things. Like I said, we have to have mammograms, MRIs, radiologists, pathologists, oncologists. So this is not a one person type of job. This is many people coming to work together to improve the care of women. And this is something I think we do well where I'm at Emory, is we have multidisciplinary discussions where we have the medical oncologist, the radiation oncologist, the surgical oncologist, and we all sit together and say, what's the best game plan for this patient? But it takes a lot of people to coming together to make those decisions. Genetic testing is something that I think we do fairly well here. In other countries, again, limited access. We know some of these breast cancers are hereditary. There are genetic mutations that a woman has that increases their risk of breast and ovarian cancer. And if we can identify those women earlier who have genetic mutations, sometimes it's recommended to get a prophylactic mastectomy or remove the ovaries if we know your risk of breast cancer, your lifetime risk of breast cancer is very high. But in order to make those personalized decisions, we have to have access to genetic testing. So that's my kind of quick and dirty on breast cancer. But yes, early detection in any disease state that we're talking about is going to save lives, especially in breast cancer, where a lot of these early stage breast cancers are curable. So thank you guys for your attention. And if you have any questions, I'd be happy to answer them.
Thank you, Melissa. I have a question. Melissa, can you go back to your diagnosis slide where you have the receptors and just go over that slide one more time, just because that is such an important.
Yeah, absolutely. So these are the subtypes of breast cancer that we think about. The most common type of breast cancer, this is about 60% of women will have hormone positive breast cancer. So this is breast cancer that grows, it's fed off of women hormones. So estrogen and progesterone that every woman has in their body. Right. So this is good because we have targeted therapy. We can have anti-endocrine therapies that we lower the estrogen levels in the body. And by lowering the estrogen levels, we deprive the cancer of the food that it needs to grow. Right. So that's great. That's great that this is the majority of types of breast cancer can be treated with a pill that you take every day to lower the estrogen levels in your body. HER2 positive breast cancer. HER2 is a protein found on all cells, but it's overexpressed in breast cancer cells that are HER2 positive. And now, thanks to science and advancements, we have HER2 targeted agents. So this before carried a very poor prognosis, but now with our HER2 targeted agents, women can live much, much longer and even be cured from HER2 positive breast cancer, which was not the case 15, 20 years ago. And then triple negative breast cancer. This is a breast cancer cell that doesn't have estrogen, it doesn't have the women hormone receptors, and it doesn't have HER2 on the breast cancer cell, meaning that we don't have any specific targets to treat that breast cancer. So the mainstay of treatment is going to be chemotherapy. And this is tough. The chemotherapy is tough. It's not great. It doesn't work that well, but it's the best that we have. And unfortunately, what we see is Black women in America and Nigerian women have the highest rates of triple negative breast cancer. So we have the highest rates of the most aggressive type of breast cancer where we don't have good targets. Even our treatment right now is not great. And women with triple negative breast cancer tend to be diagnosed at a younger age. So you see women coming in 30 years old, 40 years old with triple negative breast cancer. And so the question kind of becomes, why are Black women, Nigerian women having higher rates of triple negative breast cancer? And I don't think there's one specific answer. I think there's a lot of things that play into it, maybe some genetic, biological factors, but then also a lot of psychosocial factors, increased risk of stress, comorbid conditions that also contribute to Black women having the most aggressive type of breast cancer.
Thank you. And I know this is my last question, but when do we use the tamoxifen in these patients?
Yeah, so tamoxifen is going to be one of those endocrine therapy. So that's going to be used for that hormone positive breast cancer.
And it's for 5 years after after.
Yeah, so for early stage hormone positive breast cancer, the mainstay is going to be removing it. So you get surgery first with either a lumpectomy or a mastectomy. Some people will need radiation, and then tamoxifen or endocrine therapy is for at least 5 years. It can be extended up to 10 years, but that is to prevent the risk of recurrence, breast cancer recurrence. Those women are treated, cured with surgery, and then the endocrine therapy is to reduce risk of recurrence.
And is that in a certain age population, if they're like over the age of 60, or to use another medication, or is it just tamoxifen?
Tamoxifen is for premenopausal women, and then for postmenopausal women, we use aromatase inhibitors.
Awesome, thank you.
Yes. Any other questions?
One of the benefits of endovascular therapy for even cancer patients post-radiation is sometimes can develop upper extremity edema, and sometimes we can do endovascular therapy, venogram, whatever, to identify if subclavian vein is stenotic, and we may be able to offer them endovascular treatment to allow drainage. Thank you so much. Nice talk.
Yeah, absolutely. Like I said, after our breast cancer treatments, women can be left with long-term health consequences. One, upper extremity edema, radiation can cause some stenosis in those vessels. So there's a role for vascular surgery. So tying it back together, since this is an endovascular conference.
Thank you so much. Thanks, Melissa.
Thank you. Thanks. Okay, let me stop sharing my slide.
We had a question in the chat, I think.
Oh, sorry, there is a question.
Yeah, there's one in the chat.
Okay.
It says, how do you explain the difference between MRI and other imaging modalities like CT scans or X-rays when addressing patient concerns about radiation exposure?
Yeah, this is the question that we are getting a lot, women concerned about radiation exposure. So one, for mammograms, the exposure is very low. This, it's about equal to kind of us just walking around in the world for 6 to 7 weeks, because we all have background radiation exposure just from living. So a mammogram has about 6 to 7 weeks of just living a regular life. So that's one thing we say. And for a lot of these women, when we are talking about curing their breast cancer, we talk about risk versus benefit. So yes, there is some radiation exposure, but we're trying to cure you of a breast cancer. So we try to frame it like in that capacity. And if someone has additional concerns, you know, we can talk about the use of ultrasound, which of course doesn't have radiation and other modalities. But I think overall it's a risk versus benefits. If we're talking about cure, there will be some radiation exposure. And that's like kind of what we have to take with being able to diagnose and adequately treat the breast cancer. But this is something we are hearing a lot more as people kind of talk more on social media about all of the disadvantages of like medical Western medicine and advances in medicine. We also think about, well, what are the advantages, which is if we're curing a breast cancer, yes, you get some radiation exposure. And we know long time radiation exposure can increase the risk of cancer. Long time, long term. But some of these, you know, hopefully for a year or two, you're getting some radiation and then we're curing your breast cancer.
Great, thank you.
Thanks.
So our next speaker is Dr. Monique Oye, a highly trained and highly skilled cardiologist dedicated to the prevention, diagnosis, and treatment of cardiovascular diseases. Dr. Oye brings extensive experience in the management of acute and chronic cardiac conditions with a strong focus on evidence-based care and improving patient outcomes through timely intervention and education. Today, she's presenting acute coronary syndrome, discussing its pathophysiology, clinical presentation, and the latest approaches to acute management and long-term prevention. Please welcome Dr. Monique Oye. Dr. Oye, are you there? I see
Monique,
that
we
you're on
can't
mute.
hear you.
Yeah, we can't hear you.
Can you hear me now?
Yes.
Okay. Let me share my screen. You can see my screen?
Yes.
Yes.
Okay, so I'll start. Okay, so I am going to be talking about acute coronary syndrome today. And to start, we'll just start out with the case of a patient that we saw who came to the hospital. She was 40 years old, came to the emergency room with chest pain. On arrival to the emergency room, her blood pressure was a little high at 151/84. Heart rate was normal. Oxygen sats were 100% on room air. In terms of her medical history, she did smoke about 1 to 2 packs per day and had high cholesterol. She described the chest pain as being central chest pain, heaviness going up to the neck and shoulders, and got better with rest. In the ED, did troponin levels, which were elevated and were rising, started at 650, then 770, and then up to 824. She had no other malignant arrhythmias. She was not hypotensive. Otherwise, she was hemodynamically stable. So this was her EKG when she came in. And when we're looking at the EKG, one of the first things you want to look for is if there's ST elevations, which would signify a STEMI, which could mean that there's a complete occlusion of one of the coronary arteries, and that's a cardiac emergency and it needs to go for emergent catheterization. However, with her, we don't necessarily see ST elevations in a distinct coronary segment, but more we see diffuse ST depressions here. If we look at lead 1, lead 2, we see ST depressions, as well as V4, V5, V6, V3. When we look at lead AVR here, though, we do see some slight ST elevation. So when we see this pattern of diffuse ST depressions with AVR elevation, although it's not necessarily a STEMI, it can signify that there is a high ischemic burden or potentially left main disease. So a very high-risk EKG, especially in the setting of her new onset chest pain and rising troponin markers. So she was medically managed. She got aspirin, she got a beta blocker and metoprolol, and she was started on a heparin drip with nitroglycerin as needed for chest pain. So what would you do next when you see a patient with these concerning findings and high-risk EKG? So basically, when a person comes in, and we'll get back to her case and her ending of her story at the end, but when we have a patient coming in with acute chest pain, which is very common, the most common complaint probably in cardiology is chest pain, we need to figure out what's the likelihood that it is due to something that is emergent, meaning a heart attack or myocardial infarction. So first we get the EKG, make sure that there's no STEMI, and if there is a STEMI, activate the STEMI protocol, and they should get immediate revascularization with PCI or stenting if available. If there's no ST elevations, but they still have elevated troponins, concerning history, we call that a type 1 myocardial infarction or NSTEMI. And it's not necessarily as emergent as a STEMI, but we still need to move quickly to figure out the diagnosis and treatment. So we always look at what's the likelihood of the patient. We want to kind of bucket them. Are they high risk? Are they intermediate? Or are they low risk? And the new classification for patients coming in with chest pain and concerning signs for acute coronary syndrome are cardiac. So based on their signs, symptoms, EKG, we say it's very high likelihood that this is actually cardiac chest pain, or if we're not sure, we say it's possibly cardiac. And then there are some patients who come in with chest pain, but based on their story, their age, their other risk factors, their labs, it does not seem like it's cardiac at all, and we call it non-cardiac chest pain, and we look for other reasons why they could have chest pain, especially if it's very low likelihood that it is cardiac in nature. So we start, we get our history, we get our exam, we get EKGs, and then troponin markers are very useful in these patients to help risk stratify them. There are different risk stratification systems that we can use. A lot of times in the emergency department, they like using the heart score and using the history, the EKG, the age, risk factors, and troponins. They decide if a person comes in with chest pain, but they fall into that low risk, then they say, okay, you can be discharged from the hospital, from the ED, and just follow up outpatient. If someone's high risk, then they need to be admitted and further worked up and managed. So we get the EKG. The first EKG may come back and it may look completely normal. So we always want to, especially if the patient's having continued chest pain, repeat that EKG every about 15 to 30 minutes because we may see what we call evolving changes. So just because the first ECG is normal, the one in 30 minutes now could show a STEMI. We get the troponin markers, lab markers, and we repeat those every 3 to 6 hours. Once again, when a patient comes in, especially if they're coming in very early on, that first troponin marker can be normal, which is less than 6, but then the second one may come back at 1,000. So we always have to trend that and make sure that it's not going up. As that troponin marker elevates, it's a marker of an adverse prognosis. There's other risk scores that we can use, like the TIMI risk score and the GRACE risk score as well. But the main theme with all of these risk scores is that you're just kind of looking at the patient's age, their risk factors, their EKGs, their labs, and putting it into this calculator that's going to tell you what's their that they're going to have a cardiac event. And so when we're managing, so we said for STEMI or ST elevation MI, that's like our biggest emergency that we want to move very quickly and get that vessel opened and revascularized as soon as possible. But in patients with non-ST elevation acute coronary syndromes or NSTEMI, We sometimes have a little bit more time if the patient is not hemodynamically unstable. If they're hemodynamically unstable, hypotensive, if they're having arrhythmias like ventricular tachycardia, ventricular fibrillation, that's an emergency and they need to go to the cath lab immediately. But if they're more hemodynamically stable, we have more of an early invasive strategy, but they have about up to 24 hours where you have time to figure out, plan, and get them to the cath lab. So sometimes these patients, let's say if they came in at 3 in the morning with a non-ST elevation MI, you don't necessarily need to take them to the cath lab at 3 in the morning. You could wait till 8 in the morning when the whole team is there and then do the testing and potential procedure. And so this is just the criteria for a STEMI, which is an acute occlusion of a coronary artery, and we get 1 millimeter ST elevations in our EKGs. A new left bundle branch block may be suggestive of new ischemia or injury or infarction, but it could also, that left bundle branch block could be due to many other things. So it all just has to be put in to the clinical context. As we talked about, diffuse ST depressions, especially in combination with that AVR elevation, can signify an extensive ischemic burden. So it's very important that probably the EKG is one of the most important things because we need to be able to diagnose from that EKG. And if we see a STEMI, get them to the cath lab and get them reperfused because we want the least amount of ischemic time. Time is everything. So the longer you wait, the higher increased risk that you're not getting blood flow to that muscle, that heart muscle. And if you wait too long, that muscle dies. And once you get to that point, even if you go and open up the artery, it's too late and you're probably not going to get much benefit from it. And places where you cannot go to a cath lab and get a PCI or stent very quickly, in those cases, you can give patients thrombolytics for those emergent scenarios. And those thrombolytics are things like tenecteplase, alteplase, and it's basically medication that you can give through the IV to help break up that clot. However, even when you do those thrombolytics, there's always a chance you may break up that clot, restore blood flow, but there's a chance that's going to reocclude again. So even if you give thrombolytics, you still want to eventually open up that vessel with a stent. And there's a lot of contraindications to giving thrombolytics, and those are going to be people who have issues with bleeding or recent strokes or aortic dissection, because those medications are very strong and can cause very concerning bleeding events. But thrombolytics really are the last resort if you cannot just go to a cath lab and get a stent. The preferred strategy is primary PCI or percutaneous coronary intervention to stent the heart arteries, open it up, and we want what we call the door to balloon time to be less than 90 minutes if possible. In some very rare instances, where you can't get this, you can't do the stenting, or it's a complex case and it would be better served with cardiothoracic surgery or open heart surgery. You can do a primary CABG for these acute myocardial infarctions as well, but this is more rare. So let's say you go in and you find that occluded vessel, it's the right coronary artery, and you open that up, but you also see the left coronary artery also has significant blockage. Do you open that up there while you're on the table as well? Well, so basically that's when we call, we want to do complete revascularization, meaning we fix the artery that is causing the immediate problem, but we don't want to also leave other things unfixed. We just wait until patients are more stable. We don't necessarily do it all at one time. You fix the one that's causing the acute problem, and then what we call staging, you bring them back to fix, let's say they also have a left-sided one that's more chronic, not causing the acute presentation. We can do that at a later time during that index hospitalization stay, but you don't necessarily need to give them all that contrast dye, longer procedure time to do everything all at that one time. You can stage them later on. And then, so this kind of goes back to the thrombolytics we were talking about. So if they can't be in a place at a cath lab that can do stents, you can give them the thrombolytics, you can give them heparin, transfer them to a hospital that possibly can do stenting if possible, within at least 3 to 24 hours. So the key points really when looking at patients with acute coronary syndrome is first we need to risk stratify. So really the history is everything because even if you have a normal EKG or your troponin levels are normal, like we said, they can be maybe normal if someone comes in very early on in the infarction phase and they just haven't risen yet. But if they have a concerning story, if they have concerning risk factors, that really trumps everything. So even if everything else looks okay, but their story sounds concerning, central chest pain radiating to the jaw, radiating to the arm, they have risk factors, they smoke, they have high cholesterol, we just have to have a high index of suspicion, even in the absence of other high risk findings. And we always, if possible, want to get them revascularized as soon as possible, complete revascularization, restore that blood flow because time really is heart muscle. Otherwise, we want to try to do this revascularization at the most within 24 hours, but the sooner the better. And early reperfusion does improve survival for all patients. So when we get back to our case, so based on her EKG, her story, her history, her troponin, she was diagnosed with a non-ST elevation MI. So she was planned for an early invasive strategy, meaning she didn't go immediately to the cath lab. She went within 24 hours that next morning. In the meantime, she was managed with heparin, aspirin, and metoprolol. And when she went to the cath lab, she was found to have left main disease, and that was the culprit vessel. And it was 71% blood. She also had some moderate disease in her LAD, and she was, because it was left main disease, she was sent to cardiothoracic surgery and had a bypass surgery done to fix this. And if you remember, she was only in her 40s, so she was young, but she had risk factors. So really, this can happen at any age. Usually as people are older, but we're seeing it happen younger and younger. So we never want to dismiss someone just based on their age. It's more their clinical history and their exam and findings when they come to us. And that is it. Does anyone have any questions?
Monique, I have a question. I just actually had a patient on with this yesterday, like an NSTEMI. And then, after you reperfuse or sometime during the hospital course before discharge, you get an echo. And if the echo, less than 35%, I know you don't go right away and put an ICD in, you at least give it 90 days. But what are the guidelines saying about a life vest in these patients? I've read conflicting things. Some are saying, really no benefit of life vest anymore. Some are saying you should still give a life vest. What do you do in clinical practice?
So the life vest is the wearable cardiac defibrillator. So we have the ICDs that can be implanted into the heart, and if the person were to go into an arrhythmia, it will shock them. But in patients who come in with acute coronary syndrome, and then they develop heart failure from that, the thought is once you open up that vessel, that heart muscle will recover, go back to normal, and you won't need a permanent device. But to protect them kind of in that 90-day phase before that heart muscle has time to recover, we put on a vest that's wearable that shocks them back into a normal rhythm. It's really like a 2A recommendation, so it can go either way. Some people feel that it's not really necessary. If you've already opened up that vessel, you fixed the problem, then there's very less likelihood that they're going to go into an arrhythmia, a deadly arrhythmia, so they don't need a life vest. Other people feel that they should be protected with the life vest. So it's all kind of personal preference because it's a 2A recommendation. So it's more like shared decision making. It's just the patient, are they going to wear the vest? Because some people don't even wear it. So if you're not wearing the vest, it can't really protect you. So it could go either way. There's not a right or wrong answer. It's more like a shared decision making with the provider and the patient.
And I have just one last question. When we're looking at the risk stratification using like the TIMI or GRACE scores, I know that, if they're unstable, go within like 2 hours. But with the delayed early invasive approach, there's also like the delayed ischemia approach where they're like low risk. you could either do like a stress test or a cardiac CTA. Say that either the nuclear stress test or a cardiac CTA are positive. Do you have to, the patient's like clinically okay, do you have to perform the cath inpatient, or can that still be an outpatient approach in this scenario? So just
If you get if they're low risk, you get the stress test and it's normal or low risk, or a coronary CT is kind of the same thing as a cath. It's just a non-invasive approach. So if that testing is low risk or normal, then you don't have to cath them inpatient.
okay, but if so, but if it's positive, you would just recommend not waiting until like scheduling an out.
Yeah, if it's positive or high risk, then you would do the cath inpatient.
Very good. Thank you so much, Monique. Thank you so much. Nice talk. Appreciate your participation. Look forward to seeing you again next year on an interesting talk. Thank you.
Yeah.
And you have one more question. It's in the chat.
Oh.
It says, what's the clinical significance of FFR?
Oh yeah, so yeah, FFR CT is really good. We use it a lot because, and especially now the machines are so good, it can tell us, okay, maybe somebody has a blockage that's like moderate or like on that border of moderate to severe, but then when we actually do that FFR CT, it tells us if that blockage is hemodynamically significant, meaning like if the FFR is positive, then that's probably a good chance that it's causing the patient's chest pain or symptoms, and going in and fixing that could help with their symptoms. But if it's negative, even though their blockage is like 71%, there may not be a benefit to going in to fixing it. So sometimes, like I have patients who have chest pain, we get a CT, the blockage is 71, but the FFR is negative, then I don't necessarily send them for a cath, just kind of do more medical management, because we know in the absence of like acute coronary syndrome, hemodynamic instability, cardiac arrest, there's really not the only benefit to going in and stenting someone is for symptom relief. So if the FFR CT is negative, then we could just do more medical management and help with their symptoms that way.
Thank you.
Any other questions? Seems we've got no other questions. Thank you, Dr. Monique, for your presentation.
Thank you.
Oh, seems like we've got one more question in the chat. You still there?
Yeah, so it depends. So can NSTEMI only be managed with drugs? Yeah, so it depends. So sometimes it is just managed with medications. It more has to do with the presentation and like, is the patient stable or unstable? Because sometimes patients will present with an NSTEMI, we cath them, but like maybe the vessel that they presented with, it's like a small branch vessel. So like going in and putting a stent could actually, it's not really worth it, or it's going to be high risk. You're going to have a risk of dissecting the vessel. So then we just manage it with anti-anginal meds, aspirin, statins, getting the risk factors under control. So it really does just kind of depend on the situation, but definitely can be managed with medications or revascularization, depending on like the location of the vessel, the amount of stenosis, the complexity, all of that.
Any other questions? Okay. Thank you, Dr. Monique, once again. Our next speaker is Justine Almeida, a third-year medical student with Avalon University School of Medicine, and she'll be discussing the retrograde popliteal approach.
Ibrahim, can you hear me okay?
Yes.
And can you see my slide?
Yes.
Okay, perfect. So good morning, everyone. My name is Justine Almeida. As Ibrahim said, I'm a third-year medical student with Avalon University. I'm very honored to be presenting here for all of you today and grateful to Dr. Oye for providing us with this opportunity. I'm also thankful for my co-authors who will be authoring this paper with me, which is Dr. Oye, Ibrahim, and Sharon Shaji. So today I'm going to be presenting our proposed retrospective cohort study, which is going to evaluate the clinical significance of the retrograde popliteal approach in peripheral arterial disease. This technique has become an important alternative when the traditional antegrade approach has failed. However, there's still very limited data that's comparing the two techniques. So our study aims to close that gap. So the first thing that we want to ask is, why is this important and why is it clinically relevant? And as Michelle and Jared kind of mentioned in their presentation, peripheral arterial disease is a global health problem. It currently affects over 200 million people worldwide, approximately 12 million of which are Americans. Additionally, PAD is one of the leading causes of morbidity, disability, and amputations globally. Many of these PAD patients will go on to develop chronic total occlusions, one of which is of the superficial femoral artery, which is where our focus is going to be. What initially kind of begins out as intermittent claudication with leg pain and progressive weakness during exercise can quickly escalate to pain at rest, and this can also eventually become critical limb ischemia. Critical limb ischemia can result in non-healing ulcers, infection, and/or gangrene. And if it's not properly revascularized, the risk of amputation in these patients is going to significantly increase. The first image that is shown here is from a study that shows the trends of case number in prevalence in incidence, death, and disability-adjusted life years across 204 countries and territories between the years of 1990 and 2021. The second image is from the same study that shows the prevalence of lower extremity PAD worldwide in 2021. And overall, you can see that the absolute number of cases of lower extremity PAD cases has continued to rise yearly worldwide, and this is continuing just to increase today. So next, we're going to look at the challenges that this SFA occlusion can present when you're trying to do revascularization, because there are numerous different challenges that you can face. So firstly, these are often long lesions. They can be anywhere greater than 10 to 15 centimeters. So next, they are often, the proximal cap can be difficult to visualize on angiogram, which makes it a lot harder to guide the wire or the catheter to the correct path. If you're unable to do this, then it's easier to advance into the wrong location, such as the subintimal space, which is going to pose an increased risk for dissection, as well as making it a lot more difficult to re-enter the true lumen. Furthermore, there are a bunch of studies that have shown that antegrade recanalization fails in approximately 20 to 40%, and even higher as the cases become more complex. Now, 20 to 40% failure rate is not ideal. So we have to then ask ourselves, what are the limitations to this antegrade access that is causing it to be unsuccessful? So firstly, the antegrade approach usually begins from the common femoral artery, and the wire then has a longer distance to travel before it reaches the proximal cap. This increases the chances of entering that false lumen. Next, when we do reach the proximal cap, this is often hard and blunt, and it's very difficult to penetrate in a lot of cases, and it's going to require more force. As more force is required, the risk of dissection is going to increase. These lesions are often heavily calcified, which is going to increase the difficulty of passing the wire through. It can reduce the expansion of the balloon, and it carries an increased risk for perforation and dissection. Historically, when this antegrade method has failed, open bypass surgery, such as the popliteal bypass, was the fallback plan. However, many patients that have peripheral arterial disease at this stage are going to be elderly, they're diabetic, they have coronary artery disease, renal disease, and they're often chronic smokers. These make for very poor surgical candidates. The FemPop bypass graft placement already comes with a lot of complications of its own that include stenosis and occlusion, and this complication is only going to dramatically increase in patients that have one or more comorbid or risk. When the bypass narrows or convoluted over time, going to need to undergo surgery again to fix it, and oftentimes they're no longer surgical candidates. If the bypass isn't an option, the alternate plan is going to become amputation. Amputation carries a lot of its own risks and complications, as well as mortality for and this became the retrograde approach. So comparing the two, compared to the FemPop access offers more advantages. In elderly, diabetic, CAD, CKD, and smokers, the FemPop bypass patency offers within just 2 to 3 years due to poor runoff, calcification, infection risk, and high thrombosis rates. In terms of limb salvage, the retrograde endovascular angioplasty offers similar or better results, but it has a lower perioperative risk, as well as it's a lot easier to treat these patients that have restenosis percutaneously, which makes it a safer and durable option in high-risk patient populations. So what is this method and what are the benefits? So the retrograde popliteal approach is an endovascular alternative that allows the vascular surgeon to be able to access the occluded artery from below, which is closer to the distal cap of the occlusion. Typically, this approach is currently used just as a bailout method in cases where they've already tried antegrade and that method has failed. The distal cap is often shorter, it's softer, more tapered, which allows it to be more easily penetrated in comparison to the proximal cap that we discussed prior, which is harder and more blunt and requires more force. The distance from the popliteal access site to the lesion is shorter, which makes it easier to advance the wire with less chance of entering a false lumen. The image that's presented here is showing a flush total occlusion of the SFA, and this was treated with the intraluminal retrograde passage of the lesion, followed by drug-coated balloon angioplasty. So now let's compare the two approaches. So as we said, the antegrade approach must go through a more heavily calcified proximal cap, longer subintimal planes, and retrograde is able to avoid these obstacles by approaching the lesion from a better angle. Multiple studies have been conducted that show that adding the retrograde access increases the overall success rate dramatically in cases where antegrade alone has failed. So the image that I'm showing you here is from a study that shows a combined approach. So in this case, antegrade failed and retrograde access was added. In image A, you can see that the right SFA is completely obliterated. The second image, so image B, is showing you how the guide wire failed to pass through the occlusive lesion during the antegrade approach. And C shows how they used the retrograde puncture of the SFA that was performed after that initial failure. The CART technique, which is the controlled antegrade and retrograde tracking and dissection, is shown in D, and this kind of facilitates the linking of the two. So it facilitates the linking of the retrograde wire to the antegrade wire. E then is showing you that the antegrade wire was then able to be successfully entered into the true lumen, after which the retrograde wire is removed, balloon angioplasty and stent placement was done, and then that allowed for successful recanalization of the SFA. So as the retrograde access approach has increased in use over the past couple of years, many studies have been conducted to support its effectiveness. So the first study that I have listed here is a systematic review and meta-analysis. It mainly looked at the technical success and complication rates for this retrograde access in patients with critical limb ischemia. It showed an overall technical success rate of 96%, a limb salvage rate of 77%, and you can see that the complication rates were very low. So the risk of perforation was only 2.1, dissection was 0.6, embolization was 0.1, and local hematoma risk after the surgery was 1.3%. The second study that I have listed here focused on comparing the antegrade to retrograde access in patients that had similar disease characteristics, and they wanted to see how the retrograde approach in femoral popliteal occlusive disease, they saw that it was associated with a longer overall procedure time. However, there was significantly improved limb salvage rates. So where we had 22.4 limb amputation rates in antegrade approaches, it was only 8.6% in those who underwent retrograde revascularization. The third paper that I have listed here looked at the outcome of the SFA interventions, and they were able to see that there was a technical success rate of 94%, and after 30 days, there were no major limb adverse effects, and there were no major amputations after those 30 days. So the complications from this approach are comparatively similar between antegrade and retrograde. If anything, they're a little bit less, and most of these complications are minor in nature. Some of the things that we do look for during and after the procedure include bleeding or hematomas, pseudoaneurysms, any arterial dissection or ruptures, thrombosis or embolisms that may form during the procedure, as well as AV fistula formation. So now on to our study, which we really do hope is going to be completed by the next global grand round so that we can present our findings and results to you. So currently, there is strong evidence of the technical success rate and limb salvage with retrograde access. However, most of these studies are very small cases and they don't have direct comparison groups. There's very few head-to-head comparisons between antegrade and retrograde. So our study aims to lessen the knowledge gap by comparing the technical success of retrograde popliteal access and the antegrade access in infrainguinal angioplasty for patients with chronic total occlusion of the SFA due to peripheral vascular disease. And then secondarily, we can look at limb salvage rates, complication rates, and any need for reintervention. Our study is going to be retrospective in nature, comparing 30 retrograde to 30 antegrade cases. We will include patients with similar lesion locations, including adult patients with peripheral arterial disease and infrainguinal chronic occlusions that are undergoing endovascular intervention with either the antegrade or retrograde access. We'll exclude any patients that have inadequate imaging or lack of follow-up. And we will extract demographic and comorbidity data and detailed data from the procedure in order to look at the predictors of success or any complications that may occur. Our primary outcome is looking at success of the procedure in terms of the ability to cross the lesion and adequately restore flow without having to convert to a bypass procedure. Our secondary outcomes are going to look at limb salvage, symptomatic improvement in the patients when they come for follow-up, the rate of reintervention to assess the durability, as well as any complications. So with this study, we propose that retrograde popliteal access will demonstrate a technical success rate compared to antegrade that is going to be higher in complex infrainguinal chronic occlusions. We also expect that there will be equal or better limb salvage outcomes for these patients. We do not predict that there will be any increase in complication rates. If anything, they might be lower. And lastly, we believe that the retrograde access is going to reduce the need for bypass or amputation, therefore improving patient outcomes overall. If our results do indicate that retrograde access improves the technical success and limb salvage without increasing complication rates, it would provide solid evidence for the earlier use of retrograde access in these patient populations, instead of just using retrograde as an alternative approach. It could become the new standard. It would reduce the need for unnecessary bypass surgeries, improve quality of life, and help with limb salvage. So with all this information that I've thrown at you today, these are kind of the key points that we really want you to take away from this. So peripheral arterial disease is highly prevalent and it's a very disabling disease. Antegrade access does fail in up to 20 to 40% of complex SFA occlusions due to the long distance, the harder proximal caps, and heavy calcification. Retrograde popliteal access overcomes these barriers by approaching the shorter, tapered distal cap, and it allows for better wire control. Literature has already shown the technical success rate and excellent limb salvage with low complication rates. Retrograde can prevent the need for bypass or major amputation, improving the overall quality of life and survival in these patients. And our study directly compares the retrograde versus antegrade to provide evidence for when retrograde should be used earlier and not just as a backup or bailout method. So in conclusion, when antegrade fails, retrograde succeeds. So why are we waiting to use what works? Retrograde popliteal access offers higher technical success, improved limb salvage, and the potential to shift PAD treatment towards a more effective endovascular standard of care. These are my references. And thank you so much for the opportunity to present to you all today, and welcome any questions that you may have.
Hello, nicely done. Can you hear me? Hello, can you hear me?
Yes, I can hear you, Dr. Oye.
Yeah,
yes.
Nicely done. Nice presentation. Again, you're absolutely right. You know, in my experience, I found the retrograde approach quite fascinating way to restore flow, and at the same time minimize the need for bypass. Worst case scenario, you have one incision versus having two incisions for bypass. So it's a great way to enter the true limit, like you mentioned, especially for very calcified arteries. So again, nicely done, and hopefully we'll continue to see better improvement in this lot. And hopefully also would have see if we can have doctors here in Africa consider using this approach. Thank you. Any other questions? Ibrahim, any questions from the chat box?
Nope, the chat box is empty. We've got no questions right now.
Very well. I guess you did a thorough presentation, so no questions for you, Justine. And we'll see you. Thank you so much. Nice job.
All right. So our next speaker is a second-year medical student who has shown a passion in vascular and endovascular surgery. Saad Balmain. He'll be presenting on. Sorry about that. He will be presenting on the review of abdominal aortic aneurysm training in the modern era. Please welcome Saad Balmain. Saad, I'll be sharing your slides now.
Thank you so much, Ibrahim. Good morning, everyone.
Morning.
So today I'll be presenting on abdominal aortic aneurysm training in the modern era, how it changed essentially since introduction of minimally invasive procedures. Next slide, please. So that's our objective. So first, I would like to thank my mentor, who I've been working with for so many years now, Dr. Jakob, who has been supporting this project. And our objective was to do a review of the training abdominal aortic aneurysms and how the training changed since the introduction of EVAR, which stands for endovascular aortic repair. And now is a question that the graduates, upon finishing the residency, they won't necessarily be able to successfully perform open repair in patients who actually need. Okay. Next slide, please. So a bit of background about this. So if we're looking at aortic aneurysms, their anatomy and their geometry tends to change significantly between patients. Each patient may not necessarily benefit from the same procedures. Some patients may sometimes undergo minimally invasive procedures, but they may not be candidate. So that's what is known as the use of endovascular graft against indication for use, which is IFU. And these patients, they're likely going to benefit from open repair. Like, for example, if there's juxtarenal, which means that the renal vessels are actually involved in the aneurysms, or there's pararenal as well. Question is, how do we deal with these patients? Or if they have a short neck, for example, we can't necessarily position and seal the aneurysm sac correctly to exclude the aneurysm sac. So we allow for regression of the abdominal aneurysm. So all of these patients, essentially, how do we deal with them? We have to offer them the option of open repair. Some patients may decline it, but that's okay. At least if the surgeon is capable of performing the procedures successfully, then we won't have the issue that is essentially coming over the following of years. Next slide, please. So the first thing we did, we looked at the ACGME data, which essentially compiles all of the training across the United States, and that's only for the postgraduates. So, for example, vascular training is required to log in their hours. For example, they've done these many open repair for aortic aneurysms that were ruptured. These were elective procedures. Some of them could be, for example, carotid endarterectomy, and so on. So that data, what it shows here is we can see that the exposure to open repair for those that are ruptured is essentially null. And that's what you can see in red. For those that are elective, you can see them in green. And then the endovascular repair took over. And that's not good, because then how are these graduates going to be able to successfully perform these procedures when they're facing patients that do require open repair? Or if you have to convert endovascular to open, what do you do? Next slide, please. So that problem has been going on for quite some time, and we can go look back all the way to 1997 since the introduction of EVAR, and that problem has just been progressively getting worse over the years. And we can see that today, where we stopped essentially collecting data was back in 2020. That was the most recent data then. And I'm sure that the problem hasn't been really solved since, because the patients tend to also favor, they don't want to stay in the hospital. They don't want to have the large median laparotomy. The long recovery time is about 1 year or so. So the EVAR and even the branched EVARs, for example, the chimney grafts as well, they just have been worsening the problem over time. Next slide, please. So one thing that can be done essentially is the surgeons can actually train in large center volumes. So if, for example, a surgeon wants to do a fellowship in open repair and get very good at it, they can go to large centers. For example, at Cleveland Clinic, as one of the centers that receive the most open repair. So these patients can actually benefit from having the procedures there. And the data shows that the mortality of these patients is much lower at the center that actually performs a large volume. And the surgeons that are there, they're more capable of performing these procedures safely. So for example, a trainee who's interested in enhancing their skills at open repair can go and train there. That's one thing that is possible. The second thing that is possible to enhance the performance of these trainees is to have them do something called composite surgeon volumes, which essentially translates to having the surgeons do different procedures, but these skills are directly transferable, and essentially they were going to allow them to safely perform an open repair once they're going to be facing a patient that requires it without necessarily having such a large volume during their training. For example, somebody could be doing carotid endarterectomy, they could be doing fem-fem bypass. All of these are going to go and directly translate to better outcome for the patient, and that's our objective. Next slide, please. Okay, so essentially the influence on outcomes, what is it? So we have an increased operative time and bleeding complications. These were the things that were observed when we have a vascular surgical training that is in the OR with the attending. So that doesn't necessarily mean that the trainee shouldn't be there, because they should. Without training, it's impossible to graduate and perform at what you do. And these are not life-threatening complications. Even the bleedings, they're minor. And even if we slightly increase the operative time, it was not shown to actually impact the safety of the patient. And some of the studies are shown here, for example, by Didato. And the training balance is that we want to, of course, emphasize on the safety of the patient. We don't want to interfere with that. But having the training there is also necessary. So we need to find the balance between patient safety and the adequate training of the surgical vascular training. Next slide, please. So since the transition to EVAR, as we've shown over time, that there's a massive decline, right, of exposure to open repair. And what can be done is what I already mentioned. And the implication is that there'll be a reduced hands-on opportunity for the training as the EVAR just continues to take over and over. So that's a problem. And we have to find an alternative training method. And some of the things that were suggested is, for example, the use of AI or preoperative imaging reconstruction outside of the OR. And that can help to enhance the skills and surgical skills. For example, if a trainee is required to know how to approach a certain anatomy, then maybe these skills can be essentially obtained outside of the OR. You don't necessarily need to go to the OR to do that. Next slide, please. So there is where simulation-based training comes in. And some of the benefits is, of course, patient safety. That's over everything. And what this also allows is, for example, if we're going to go outside and have, for example, the masks that you can go and then just have a 3D glasses essentially, and then you can see the virtual anatomy of the patient, and then you can train in these conditions where you're not harming the patient. You're still training in the same geometry of the aorta without being there. So you still learn the same skills. If we look at since introduction, for example, in cardiac surgery, they're using Da Vinci system. So that's virtual. You can still try to do the same thing, but without actually being in the OR and still acquire the same skills. And that's one thing that is possible. We can also do high fidelity models with cadavers that are still fresh. You can assimilate the hemodynamics with ECMO, for instance. And then the skills are still acquired without harming the patient. Next slide, please. And some of the key findings that we could find here is that high volume is important. Diverse exposure is also important to improve the outcomes. And then simulation also addresses the gaps in the training and AAA repairs. And future studies, they should actually focus on refining simulation tools and schedules of procedures, and then integrating AI to personalize the training, the vascular training. Next slide, please. So in conclusions, we saw that surgeon volume is very important, and diverse exposure is also important. Simulation can actually allow us to bridge between the training in the OR and when the vascular surgical training can go into the OR and safely perform the procedure. And as a closing remark, we want to be preparing, of course, the future vascular surgeons to require innovative, adaptable training methodologies. And that was my presentation. Thank you. And I'll take any questions if anyone has any.
Thank you very much, Saad. Can you hear me?
Thank you so much. Yes, I can
And
hear.
presentation, very nice and concise. Again, there's no doubt that there's a step down for the ability for hands-on training in vascular surgery as newer trainees do a lot more endovascular intervention. And if they're not trained in open surgical technique, they may run into some problem down the road. So yeah, so that the ability to get access to open techniques when available is crucial. For some patient, endovascular technique may not be the answer. Again, the ability of a surgeon to decide the best surgical option for the patient is critical for success. Sometimes endovascular surgery is a choice, sometimes not. So again, the trainees should endeavor to be exposed to both open surgical techniques as well as endovascular techniques. We have the opportunity to do that without in our training where we're well skilled in open surgical techniques before we go into endovascular techniques. So we don't have that problem, but again, it's a problem that we have to be cognizant about for newer trainees. Nice talk. And again, the use of AI, embracing AI should be top and center, front and center for any trainee now, and even practicing vascular surgeon, because that's the way of the future. Thank you.
Thank you so much, Dr. Oye. I have a question for you.
Yes.
Based on your experience, what would you say is the best for a medical student or like a first or second year resident to focus on to enhance their skills in open repair? Would you say simulation outside of the OR is best?
Well, it depends. It depends when you select. You should engage. First of all, find since you're still an extern, find physicians who will engage you to be part of the team. Sometimes in a surgical team, as a medical student, where you don't get the opportunity to actively perform, so that doesn't help you. The more you do early on as a medical student, then as an intern, then as a resident, will certainly increase your skill set. Again, and also when you apply for residency, you want to apply to a program that's willing to have you operate. No sense going to a program where you're the 10th person behind the desk. If you don't operate, then you're not going to be skilled when you get out. So you want to kind of balance it out.
Thank you so much.
All right. Okay.
Thank you, Saad. Before we move on to the last speaker, I have a request from the coordinator who would like for the international audience to please put on their cameras so we can take a quick screenshot. So if I could get everyone's to turn on their cameras for just a brief moment. Thank you, Mr. Benny. Thank you, Jay. I see almost everyone's in their cars. Thank you, Dr. Monique. All right. Cool. Okay, thank you guys. Our final speaker is Jay Prashar, a fourth-year medical student who will be presenting. Okay. Who will be presenting an interesting case titled Multi-Level Endovascular Intervention for Severe Peripheral Artery Disease, a case report and literature review. Jay, the floor is yours. You're muted, Jay.
Yeah, sorry. Okay, thank you, Ibrahim. Can you guys see my screen?
Yes.
Yes, we can.
Okay, perfect. Okay, thank you so much. So, good morning, everyone. My name is Jay Prashar, and today I'll be presenting our case report titled Multi-Level Endovascular Intervention for Severe Peripheral Artery Disease with Concomitant Aneurysmal Disease. Okay, so a little on the abstract and learning objectives. So this presentation explores a case of a 78-year-old male with advanced peripheral artery disease and aneurysmal disease who underwent staged multi-level endovascular revascularization. And by the end of this session, we should be able to identify the diagnostic and therapeutic challenges in multi-level peripheral artery disease, understand the rationale for staged endovascular interventions, review the technical aspects of tibial and femoral popliteal revascularization, and then finally I'll finish with a quick summary of the outcomes and relevant literature to guide further practice. And this case underscores the evolving trends favoring minimally invasive endovascular first strategies in high-risk patients. And so peripheral artery disease, as many of you guys have mentioned, over 200 million people globally, and is associated with high risks of morbidity from ischemia and cardiovascular events. And complex peripheral artery disease often spans from multiple arterial levels, including femoral popliteal and tibial artery supplies, and can coexist with aneurysms, further complicating management decisions. With technological advances in balloon angioplasty, drug-coated balloons, and covered stents, endovascular therapy has become the preferred first-line approach for many patients. And this case will demonstrate exactly that. We'll discuss illustrate the diagnostic workup, procedural planning, and execution of multi-level endovascular repair in a patient with both tibial occlusive disease and femoral popliteal aneurysms. Okay, and then so a little on the case presentation. So our patient was a 78-year-old male. He presented with coronary artery disease, hypertension, hyperlipidemia, bilateral peripheral artery disease, and right lower extremity gangrene. And he denied any use of tobacco, alcohol, or drugs, and was on a standard aspirin, metoprolol, losartan, statin, and aliricimab therapy regimen. And he presented following an abnormal stress test obtained during a pre-op cardiac clearance with complaints of bilateral leg pain, which was greater on the right side than on the left. And then moving on to investigation. So we used non-invasive testing, raised suspicion for advanced peripheral artery disease, which further prompted angiography via left femoral axis. And our findings included a large popliteal aneurysm at the level of the knee, 90% stenosis of the anterior tibial artery origin, and 70 to 80% stenosis of the tibio-perineal trunk, and 50 to 60% stenosis of the posterior tibial artery. And overall, the angiogram revealed extensive tibial disease and compromised perfusion, necessitating revascularization. Okay, so as you guys can see in figure 1, starting with A, like lower extremity runoff demonstrating of popliteal artery aneurysm at the level of the knee with multi-level tibial disease. And as I mentioned, 90% stenosis at the anterior tibial origin, 70 to 80% stenosis was noted at the tibio-perineal trunk, and 50 to 60% stenosis of the posterior tibial artery. And in the second image, we have below knee images showing poor distal perfusion prior to revascularization. And in the second figure, as you guys can see, this was the post-tibial intervention angiography of the right leg. And the final angiogram after multi-vessel tibial angioplasty which we used a 3x40, then a 4x40 stent, and then tibioperineal trunk posterior tibial 4x40 millimeters, demonstrated restored distal perfusion with improved runoff with both anterior and posterior tibial arteries. Okay, and then for the second intervention, it was a left femoral popliteal aneurysm repair. And the second stage addressed the left femoral popliteal aneurysm and associated stenosis. Access was obtained under ultrasound guidance and upsized to an 8F sheath. Multiple femoral popliteal and tibial stenosis were treated using a 7x200 drug-coated balloon and an 8x50 Vibiband covered stent for aneurysm exclusion. An attempted 10x50 millimeter stent was aborted due to significant resistance, and hemostasis was ultimately achieved using angioseal closure device. And then finally, our angiograph revealed excellent flow without complication. So a little bit on the hospital course of the patient. So the patient was admitted overnight to the surgical ICU for observation, and then post-op management included a standard dual antiplatelet therapy, including aspirin and clopidogrel, statin therapy, IV fluids, and pain control. He did develop a little bit of acute kidney injury, but it resolved quickly with hydration, and he remained hemodynamically stable with no bleeding or access site complications and was discharged the following day. So moving on to the discharge and follow-up. So at discharge, he was stable and independent in ambulation. Medications included his aspirin, clopidogrel, and his regular home cardiovascular medications. And then at his 1-week follow-up with the vascular surgery department, he demonstrated symptom-free with no residual ischemic pain and palpable peripheral pulses. So how we came to the decision. So this case demonstrates that the importance of integrated cardiovascular evaluation. Peripheral artery disease was identified using cardiac clearance, and then further emphasizing overlap between the coronary and peripheral vascular disease. The endovascular first stage strategy minimized the perioperative risk and the contrast exposure, particularly important given his age and renal status. And the right tibial revascularization was prioritized to improve distal perfusion before addressing the left femoral popliteal aneurysm. So a little bit on the technical aspects. So the key procedural considerations included were accurate balloon sizing and controlled inflation to prevent recoil or dissection, use of a drug-coated balloon to enhance patency, and covered stent for durable aneurysm exclusion. While femoral popliteal interventions do show long-term outcomes, tibial patency remains limited, reinforcing the need for ongoing surveillance. And the staged approach allowed us for renal recovery and minimize the procedural stress. So a little bit on the regular evidence and guidelines. So current guidelines from the AHA and the ACC and Global Vascular Guidelines recommend endovascular therapy as the first-line management for chronic limb-threatening ischemia, and particularly in high-risk surgical patients such as the one that we had. The BASIL and BEST CLL trials demonstrated that endovascular revascularization can achieve limb salvage outcomes comparable to surgery when paired with optimized medical therapy. Advances in DCB and stent technology continue to improve patency and reduce reintervention rates. So just to finish off with a little bit of the case outline, the timeline. So it was the patient first, it was the cardiac clearance where abnormal imaging was noted, and it was done using the diagnostic angiography. Then moving on to stage 1, we had the right tibial multivessel angioplasty. Then stage 2, we did the left femoral popliteal repair using the Ranger drug-coated balloon and the Vibiband stent. And then post-op in the SICU observation, and he just had the mild acute kidney injury, which resolved with revascularization with rehydration. And then day 2, he was discharged and he was stable with palpable pulses. And then moving on to the conclusion. So to summarize, multi-level peripheral artery disease with aneurysmal disease requires individualized multidisciplinary care. Hybrid and staged endovascular interventions can safely achieve durable limb and salvage methods. Early identification of vascular disease during cardiac workups highlighted the significance systemic nature of atherosclerosis. Success in this case reflects adherence to guidelines, technical precision, and comprehensive post-op management. As endovascular techniques continue to evolve, patient-tailored strategies will continue to redefine peripheral artery disease management. And here's a little bit of the references. And thank you everyone for attending.
Nicely done, Jay. Can you hear me?
Thank you. Yep.
Yeah, well, nice job. Very good summary. Dr. Ibrahim, you have any words before I finish?
No, doctor.
Any questions in the chat box?
Nothing in the chat box.
Well, again, this is a very good presentation in terms of the role of endovascular surgery in solving the patient's problem that has both an aneurysm issue as well as a stenotic issue. So again, the patient came with bilateral problems, bilateral low extremity aneurysms. It's important if you suspect an aneurysm in the abdominal aortic aneurysm, it's important to the value of CT angiogram with runoff is not only to ensure that you find out they have an aneurysm in the belly, they may well have an aneurysm in the femoral area or the popliteal area. There's a 50% chance of that happening. So it's important that you do a CT of the abdomen with runoff, so that way you don't miss that problem. Again, popliteal aneurysms many years ago would literally do a bypass for that. Tie the aneurysm above and below, then do a bypass either with vein or graft around it. With endovascular interventions, if they have adequate runoff, can get away with endovascular intervention. So that was the case here. So anyway, we're going to wrap this up. It's been fascinating day of multiple talks, and I'd like to say thank you very much for the participation of all our speakers for the conference. Would like to say thank you for attending the 8th Annual Endovascular Conference here in Lagos and virtually. And the take-home message is PAD is a problem. PAD, be it PAD, be it stroke, be it heart-related issues, time of intervention, early interventions of great essence. And again, a unifying theme we're seeing for PAD problems as well as heart patients also, and stroke is hypertension. I suspect if we control the high blood pressure in many of these patients, we may be able to decrease their problem that they experience, their presenting problems. Again, the goal of this exercise for PAD in Africa and also in rural America is to make the care affordable as well as feasible. It makes no sense for the technology to be available where people cannot benefit from it. So we have to be creative in our approach. We have to continue to learn as medical students, residents, other physicians that we go up in the training, primary care providers, to be able to identify PAD and also let our patients be aware to identify this, because we don't sit with our patients all the time. However, once the patients have a problem, they should be able to come to the provider and tell the provider what the problems may be, and the provider should have the ability to now affect or direct them to where they can get best care. We invite you, furthermore, to join us on our quarterly global ground rounds, which is an opportunity for physicians and clinicians and non-physicians to engage with one another every 3 months. And the next one comes up on January 2026. We also would like at this point to thank our other contributing sponsors and partners in this program, the OUA Global Medical Foundation, particularly Mrs. Sharon Williams, who has been very helpful in contributing to the success of our ability to manage patients that need care. Would also like to thank Uzuma Foundation for its continued efforts to improve healthcare in Africa, especially Gambia. Would like to thank Silver Cross Health and Diagnostics for being a true partner in this process, and would also like to thank Bayelsa Special Hospital for hosting the first time of this program on October 13th. Again, this is a challenge. We've done well in 2025. We hope to do better in 2026 on the 9th annual conference, and do even better and better in 2027 on our 10th annual conference. So we'll look forward to you young doctors presenting today to come back in great occasion next year and the year after, even when you're in your residency programs. Thank you so much. And on behalf of the sponsors of this program today, let's say thank you, and thank you all for participating. Appreciate your help.
Thank you, Dr.
Ibrahim, for coordinating this program down the very early mornings of the hours. You've done a fantastic job. Thank you, Dr. Ibrahim.
Thank you, Dr. Oye.